صباح الخير على حضراتكم جميعا، يا رب تكونوا بخير. بعتذر جدا عن التأخير، وبشكر وجود حضراتكم. ان شاء الله النهارده هنتكلم على الهايلايتس. انا عارف ان النهارده 9/12، بس احنا هنبرز بعض واهم ما تم عرضه امبارح في مؤتمر الجمعية المصرية. حقيقة أول مرة أقدم التاسك دي، واتس تاف تاسك إن أنت تقعد تحضر يمين وشمال وتحاول تجمع، لأن البروجرام امبارح كان فيري دنس، وفي النص التاني من اليوم اشتغلت هول A وهول B. كان بداية اليوم ابتدى امبارح باليونج ايجيبشن يورولوجيست ميتنج، وكان فيه تو سيكشنز. اول حاجه كان في دكتور شادي ياسا، ودكتور شادي ياسا هو من المستشفى الجوي وحاليا في يو كي، وكان اتكلم على الكلينيكال اوديتنج. واعتقد ان الكلينيكال اوديتنج از فيري امبورتنت. احنا في الحياه اليوميه بنرش وبنشوف بيت فولز في البيشنت كير، و we never have time to stop and rethink. ودي is very important، لأن it's very important for your quality improvement and for your patient care. وهو he discussed the 10-step process which was very informative. وكان الهدف من الاوديت زي ما قلنا better patient care, less load. If you develop a system, if you move forward, reduce the cost, it will be reproduced. وهو قال ان شاء الله هيبقى في ويب سايت ان هو نقدر نستخدمه في جامعات مصر ونقدر نبني عليه. المحاضرة الثانية كانت عن recurrent urethral strictures و what's new in recurrent urethral strictures. وزي ما احنا عارفين الدايلاتيشن والفيجوال والسيرجريز always there is a room for more. وكان دكتور احمد ابو زيد اتكلم على الاوبتيلوم. للاسف الاوبتيلوم غير متواجد في مصر، ولكن ان شاء الله نلاقيه قريب. واتكلم عن الاوبتيلوم وازاي بيبقى باكيتاكسل كوتد ستنت، واللي هو اتس كيموثيرابي بيكومباين الميكانيكال دايلاتيشن مع السيمتوماتيك ريليف مع اللوكال دراج ديليفري. واتكلم ان ده بيقلل الانسيدنس اوف فايبروزز وانفلاميشن وجرانيوليشن فورميشن. اعتقد ان اوبتيلوم از one of the promising techniques in the market، اللي ان شاء الله باذن الله نامل ان هي تكون في مصر. بعد كده كان في سيشن ديديكيتد. احنا عارفين طبعا هجرة الاطباء دي حاجة من المواضيع الساخنة، فكان في البارت 2 اوف اليورولوجي اليونج يورولوجيست كان ديديكيتد على اليو كي واليو كي باث واي. وكان اهمهم ان احنا عندنا البريتش ايجيبشن ميديكال اسوسيشن. واعتقد ان السيشن ده كله is a very good start وهايلايتد where to start و how to start، وان احنا نتعلم من الاخرين. ومش كل حد من شباب المسالك ناوي يبدا تاني من الصفر، لا هو ممكن يروح للويب سايت ده ويقدر يستفيد من خبرات الناس ويقدر يستفيد من الكورسز. بعد كده كان عندنا الستيت اوف ارت ليكتشرز، كانت البلينري سيشنز، وكان طبعا موديليتورز كلهم اساتذتنا الكبار العظام. كان في البايرونيز ديزيز للاستاذ الدكتور احمد السقا من جامعه قناه السويس. وكنا عارفين ان هو it affects about 6% of the population في acute phase وفي chronic. لازم نبقى عارفين ان في treatment either by injections او needle. وهنيجي later on في اخر اليوم لديبيت ما بين دكتور عبد الرحمن زهران ودكتور جلال الشرباجي عن الانجكشن versus النيدل، وهنسمرايز. وكان رأي دكتور احمد السقا ان الشوك ويف ثيرابي has no role in Peyronie's disease, it only helps in plaque size, وراديوثيرابي is contraindicated. فالتيك هوم مسج ان there is no radiotherapy in Peyronie's disease. بعد كده كان في دكتور دانيير اوزومنوف من المانيا، وكان بيقول ايه المشاكل او ايه الاخطاء اللي هو واجهها في البنايل بروثيسز وازاي يقدر يحسنها. واعتقد ان ده برضو على نهج اليونج يورولوجيست ان احنا نتعلم من الاخرين، ودي حاجه مهمه. فطبعا كان اول بدا المحاضره بقصه ظريفه، ان هو كان راجل شغال راديكال بروستات اوبن وروبوتك. جاله عيان محتاج بنايل بروثيسيس، قال لك طب ما هي سهله، يعني انا بعمل الصعب مش هعرف اعمل السهله. وانتهى ب كوربورال بيرفوريشن. فطلع كلم دكتور ستيف ويلسون وكلم ناس اكبر في القصه، ان انت دايما لازم يبقى معاك فellowship تريننج، تروح تشوف الاكسبرتس ان ذا فيلد وتدور عليهم وتمسك فيهم وتتفرج عليهم. وتتدرب، وهو ده الحاجة المهمة، وهو ده المبدأ المرسخ في الجمعية. احنا ممكن السنة دي في المؤتمر البروجرام ما شاء الله مكثف الورك شوبس فيه بعنف، وكل واحد لازم يختار ورك شوب او اتنين من الشباب ويحضر، لازم يشوف مين المتخصص في المجال ويمسك فيه ويجري ورا محاضراته في كل محافظات مصر. برضو قال انك دايما استخدم ادرين، استخدم المامي راب، افويد تنشن. اتكلم على الانفكشن، لان الانفكشن دي طبعا حاجه احنا في مصر بنعاني منها، واتكلم على ان ازاي ان الانفكشنز ار ناو ان كومن، لان كانوا عملوا لارج ستادي على الاف العيانين لقوا ان 11% فانجل انفكشن. واتكلم ان اهم حاجه تريديوس التايم بتاع السيرجري، هو ده اقل حاجه، اكتر حاجه بتقلل الانفكشن، ونافويد المانيوال موديلنج. بعد كده كان في استاذنا الدكتور اسماعيل راضي من القصر العيني، وكان بيتكلم على سمول رينال ماسز، واعتقد ان اتس هوت توبيك رايت ناو. وكان في مجلد من الجمعيه من سنه او اتنين او اكتر، كان في دكتور عمرو فرجاني، وكان كل المجلد عن السمول رينال ماسز والمانجمنت سمول رينال ماسز. اتكلم على ان الانسيدنس بيزيد، كله النهارده بيعمل سونار، لو كح او عطس بيروح يعمل سونار. اتكلم على ان الراديكال نفراكتومي از decreasing، واتكلم على ان ممكن يبقى فيه لاباروسكوبيك او روبوتك او ابليتيف رول. واتكلم ان دايما في البدايات ما تعملش السنترال تيومرز ولا السيفير كدني ديزيز ولا الهاي بادي ماس اندكس. اتكلم على الاندياجو كارمين، والاندياجو كارمين بيدينا حاجتين، بيقول لنا الفاسكولاريتي بتاعت الكدني اخبارها ايه، عشان لو انا بعمل كلامبنج اطمن ان الفاسكولاريتي مش موجوده، وبيدينا برضو المارجنز، والمارجنز كان دكتور روني اباظه اتكلم عليها. الاي سي جي الحمد لله بقى متوفر في مصر، وفي كاميرات بتشوفه، وفي رساله مسجله في معهد الاورام عن الاي سي جي. وطبعا دكتور اسماعيل اتكلم على الترايفاكتا جول. اتكلم ان البوزيتيف سيرجيكال مارجنز من 2 to 4%، مش لازم تبقى حضرتك بتسر على اوبن ولا لاب ولا روبوت، الثلاثه السيم اونكولوجيك اوتكم، فاحنا بنتكلم على فانكشنال اوتكم بس ديفرنس. وطبعا اعتقد الثيم بتاع المؤتمر السنه دي والسنين الجايه هتبقى كله في الاي اي، وعندنا محاضره للاستاذ الدكتور عبد الرسول عن الاي اي، والاي اي هو دلوقتي الاساس في كل شيء، فلازم نخلي بالنا من الاي اي والاوجمانتد رياليتي. بعد كده كان في استاذنا الدكتور حازم عرابي سفير مصر في كليفلاند كلينيك، اتكلم على الجرافتنج تكنيكس، واتكلم على كان في ملخص حلو منه 4 استراتيجيز لحل اي مشكله، يا ترانسبلانت، يا تستخدم نون نيتيف تيشو، يا تشتغل ريجنريتيف تيشو، يا تستخدم ميكانيكال ديفايس. فدي تقسيمه جميله ممكن نقولها للشباب. واتكلم على الاوجمانتد يوريثروبلاستي لو انت هتستخدم بلادر ميكوزا او بينايل سكين. بعد كده اتكلم عن نيو جرافت ماتيريال، وكان هو واحد من الادفوكيتس للهارد بالات ميكوزا، وكان بيقول ان هذا better lamina propria، والسكسس ريت كان 82%. although الاستادي اللي كان معموله ما بين استاذنا الدكتور حازم عرابي ودكتور كالكرني كانت على very limited number of patient 10 patients، بس it's always there، لان احنا مصر it's a hub للسياحه العلاجيه، واساتذتنا اللي بيشتغلوا يوريثرال ريكونستراكشنز بيجي لهم فيري كومبلكس كيسز من الاماكن اللي فيها حرب حاليا، ربنا ينصرهم، فلازم نبقى دايما جاهزين بواتس نيو وواتس ديفرنت. واتكلم ان انت تكونسيدر نيور جرافس لو لونج سيجمنت او ليميتد دونر، عيان جاي واخد بكل واخد لينجوال وخلاص هتجيب له منين فكده. بس هو برضو رساله لشباب الاطباء، لان هو دايما التركيز في شباب الاطباء ان بكل ميوكوزال جرافت is still the gold standard. بعد كده كان في دكتور يوسف نملة سفير مصر في جايز هوسبيتال ان ذا يو كي، اتكلم على التوب 10 تيبس ان روبوتك فينس تيومر ثرومبكتومي، وطبعا ورى فيديوز جميله ورائعه للرينال ماسز والستيومر ثرومبس. وانا دايما بقول لو احنا ما عندناش اللكجري ان احنا نشتغل روبوت، احنا عندنا لكجري ان احنا نتعلم من فيديوهات الروبوت، لان فيديوهات الروبوت بتوريك اناتومي فوق خيال الوصف وصف، يعني انت اللي ممكن تتخيله في الكتاب الفيديو بتاع الروبوت هيوريهولك وهيفرجهولك. فحتى لو انت if you don't have the luxury ان انت تشتغل روبوت، انت عندك اللكجري انك تستفيد من الفيديوهات وتستفيد من الاناتومي، ولما تشوف اناتومي احسن definitely هتشتغل عمليات اوبن احسن. اتكلم طبعا ان 10% of renal masses present with the thrombus، 1% بيبقوا واصلين الاتريوم، open surgery is the standard. يعني احنا بنتكلم على سنتر جايز هوسبيتال in the UK. It's one of the top centers. فاحنا مش جايين هنا نقول ان كل واحد جاب روبوت في مستشفى جاله عيان برينال فين ثرومبس يعمل، لان احنا we still need the experience. اتكلم الروبوت ليه advantages ان هو بيقلل الاستيميتد blood loss. اتكلم على التيومر ثرومبس whether it's solid or friable لازم تكون عارف. اتكلم على الخطوات، وهو عامة الميزة في الروبوت انه it mimics the open. يعني انت اللي اتعلمته في الاوبن هتروح بديفرنت تول تعمله في الروبوت. واتكلم على الانتي كواجيليشن، الاي في سي فلتر، والرينال ارتري امبولايزيشن. بعد كده كان في استاذنا بدر الدين بدير الدين سوري من المنصوره، وكان اتكلم على الجينيتال سبيرنج سيستكتومي في الفيميلز. وحقيقه هو قال فعلا اتس نايت مير. يعني انا لا اتخيل ان في سيده داخله عليا في الاربعينات والخمسينات من العمر تقول لها النهارده حضرتك احنا ممكن نطلع لك بفلنشه على الجلد وممكن نعمل لك البول يسيب عليكي وهتخسري حياتك الزوجيه. ففعلا we have to consider female organ sparing cystectomy، بس we have to be very cautious. يعني هو السلاح ذو حدين، لازم يبقى in very well selected patients who are sexually active and motivated. وورى صور وفيديوهات جميله للفيميل سيستكتومي والاناتومي، وورى البلين اللي ما بين البلادر وما بين اليوترس والفاجينا اللي احنا عاده ما بنخشوش، احنا بنخش ورا. وكان حقيقه محاضره thought provoking. يعني هي تستدعينا للفكر، وان فعلا مش كل فيميل تيجي نقول لها anterior pelvic exentration. بالرغم طبعا من استاذنا الدكتور حسن ابو العينين ورانا تيبس اند تريكس كتير في محاضرات كتير عن الفيميل سيستكتومي، وازاي نقدر نحافظ على الراوند ليجامنتس ونعلق الباوتش وازاي نبريزيرف الفاجينا. ولكن لو واحده young small tumor away معانا good imaging we can justify. بعد كده دخلنا في الاندويرولوجي سكشن، وكان في محاضره لاستاذنا الدكتور احمد توفيق من عين شمس عن التي ار بي. والتي ار بي بالرغم من ان هيجي بعد في المحاضره الجايه استاذنا الدكتور انمار حبيب ويدافع بعنف عن الانوكيوليشن، بس لسه التي ار بي از ذا فيرست لاين اوف سيرجيكال مانجمنت، بالذات في بلاد الكوست. والكوست از ا ميجر ايشو. ولازم ميزه التي ار بي الوحيده ان هي تطورت تطور شديد، وبقت تقدم اللي الحاجات الاخرى بتقدمه. فالتي ار بي did not survive by resisting the change. احنا مش واحد قال لك احنا النهارده عاملين طياره تقول له لا انا لسه هروح الشغل بالعجله، لا it survived by evolving. ودي كانت جمله قويه. انت دلوقتي تقدر تعمل bipolar inoculation، تقدر تعمل ejaculatory sparing، تقدر تعمل حاجات كتيره، ودي ميزه للتي ار بي. واعتقد ان التي ار بي is still a gold standard. بعدين استاذنا الدكتور انمار حبيب هولب ثولب بايبولر، وهو he concluded ان all techniques are effective و guideline approved. فانت اللي يختار مننا ما ينفعش تبقى خناقه ليزر ولا بلازما ولا ثنائي القطب، لا هي الخناقه انت بتعرف تستخدم ايه احسن، وانت متمكن في ايه احسن، وانت هتطلع. ليزر اوفر البست هيموستيزس، بس الباي بولر از كوست افكتيف. وان انت تماستر الانوكيوليشن تكنيك، واعتقد ان احنا كلنا محتاجين نركز في الانوكيوليشن تكنيك راذر ذان نقعد نتخانق باي بولر ولا هولب ولا ثولب ولا تي اف ال. هي اول انرجي سورسز موجوده. بعد كده استاذنا الدكتور حسن شاكر اتكلم عن الليزر ابليشن، ودكتور مازن اتكلم على الفوكال ثيرابي. الليزر ابليشن طبعا وفي صدى دلوقتي، ما اعتقدش ان في حد من اساتذتنا كلهم اللي موجودين حد بيخش له العياده ما بيقولوش انا عايز اعمل البروستاتا بالايكو ليزر. فهو it's still investigational, it's still under clinical trial, it might have some efficacy، بس there is still a huge way to go بان احنا يبقى عندنا sound scientific content عن البتاع دي. ولو if you're going to offer it you have to know and you are offering it under clinical trial او clinical investigation. بعد كده كان استاذنا الدكتور شريف مراد اتكلم عن الرزوم، واعتقد ان الرزوم ده one of the newer minimally invasive techniques. في سلايد هنا ناقصه. one of the newer minimally invasive techniques اللي كلنا كيورولوجيست are familiar with it and believe in it. والريزلتس بتاعتها موجوده وموجوده بشده. كان في صوره دكتور شريف حاططها بس للاسف مش موجوده، من كيو ماكس less than 9 لكيو ماكس 20 لنو بوست فويد ريزيدوال يورين، لان التكنولوجي is sound، التكنولوجي is FDA approved، التكنولوجي is in the guidelines. بس upper tract urothelial cancer endoscopic management استاذنا الدكتور احمد شومه، وكان دكتور طارق عثمان. طبعا احنا بنتكلم ان دلوقتي في comparative outcomes في اللو ريسك، والاوفرول سرفايفل از ذا سيم، بس طبعا الريكارنس فري سرفايفل از بيتر فور راديكال نفرويوريتراكتومي عن الاندوسكوبيك مانجمنت. انت بتحافظ على بتعمل رينال بريزرفيشن وذ هاير ريكارنس، وحقيقه انك ساعات بتبقى مضطر للاندوسكوبيك مانجمنت سوليتري كيدني بايلاترال فيلد افكت في الحالات دي. واتكلمنا ان السيرفيلانس بروتوكولز هاف تو بي فيري اجريسيف، تاخد العيان تعمل له فلكسبل يوروتروسكوبي كل 3 شهور. ما هو العيان if he wants to preserve he has to know ان he has to go through an aggressive surveillance protocol. في الهاي ريسك upper tract urothelial cancer دلوقتي الاي يو اي جايد لاينز والاي يو اي ليسنز كلهم بيتكلموا على النيو ادجuvant كيموثيرابي. كنا زمان بنقول لا اب فرونت سيرجري، لا دلوقتي بقى الرول اوف نيو ادجuvant كيموثيرابي ماتش مور عن الادجuvant كيمو. وطبعا الاميونوثيرابي is changing the market في كل اليوروثيليال كانسر. لسه كان عندنا النياجرا ترايل في البلادر كانسر اللي قالت النيو ادجفنت دوفولوماب مع سيسبلاتين تزود من 5 to 8% سرفايفل ادفانتج، نطتها ل 30. ولكن يبقى في مصر الاميونو مشكلته الكوست. بعد كده كان في اندرولوجي سيشن في هول بي، والاندرولوجي سيشن اتكلموا طبعا استاذنا الدكتور محمد عبد الرسول عن الاي اي. دلوقتي الكمبيوتر اسيستد سيمن اناليسيس كله بيعتمد على الاي اي والديتكشن. اتكلم ان في اي ام جي للكافرنوزال بريشر، اتكلم ان في 7 تسلا ام ار اي ممكن يتوقع ان حد هيجي له اريكتايل ديسفانكشن عن طريق ام ار اي اوف ذا برين. اتكلم ان في تشات بوت، انت ممكن بدل ما بتخش على شات جي بي تي تساله ايه ازاي اوصل لمؤتمر الجمعيه المصريه، انت ممكن تخش تتكلم عن تشات بوت ديديكيتد للاريكتايل ديسفانكشن وتوصل لتشخيص. اتكلم على 3 دي مودلز للبينايل كيرفتشر وبينايل شورتنينج عشان تقدر تهلب يو ريكونستراكت وتعمل السيرجري بتاعك وتبلان السيرجري. بعد كده كان في استاذنا الدكتور ايمن حسين اتكلم على الايجاكيولاتوري داكت اوبستراكشن ووذر اتس فانكشنال اور اوبستراكتيف. نخلي بالنا من congenital bilateral absence vas deferens والretrograde ejaculation. الستاندرد هو الترانسركتال الترا ساوند عشان تشخص الايجاكيولاتوري داكت اوبستراكشن، تبقى الايجاكيولاتوري داكت اكتر من 2.3 ملم والسامنال فاسكلز اكتر من 15. والجولد ستاندرد هو التي يو ار فيرو. في اذر ميثودز بس التي يو ار فيرو از ذا جولد ستاندرد with a success rate of 60%. وكان في نقطة مهمة قال ان هو بيحقن ميثيلين بلو بعد ما بيعمل التي ار فيرو عشان يتأكد ان في السامنال فاسكلز عشان يتأكد من الكوميونيكيشن. استاذنا الدكتور ماجد رجب من طنطا اتكلم على ازوسبيرميا اند فاريكوسيل، واتكلم ان الازوسبيرميا والفاريكوسيل ممكن يبقى ليهم يبقوا سببين. الفاريكوسيل تسبب ازوسبيرميا، واتكلم على ان التستس عشان تفانكشن بروبرلي لازم تبقى اقل من درجه حراره الجسم بدرجتين والرياكتيف اوكسجين سبيشيز. واتكلم على الفاريكوسيل may help in azoospermia. هي مش هتحسن النورمال كونسبشن ولكن هي هتحسن الاي في اف ريزلتس وهتحسن خروج السبيرمز in the semen. الاي يو اي جايد لاينز no definitive evidence. اليوروبيان قالوا ان في one meta analysis بس هو حذر شباب الاطباء ان ما تعملش فاريكوسيل في حالات الازوسبيرميا لو في سيرتولي سيل اونلي سيندروم او الاف اس اتش از مور ذان 11 او في جيناتيك ديفكت. فدي الحاجات اللي نبقى كوشس فيها. الفاريكوسيل في الازوسبيرميا ممكن تكون مفيده ولكن في الثلاث حالات دول لن تكون مفيده. بعد كده استاذنا الدكتور صلاح زيدان من جامعه الازهر اتكلم على البريماتيور ايجاكيوليشن، ده الموست كومن ريبورتد سيكشوال هيلث ديس اوردر. واتكلم كلنا بنكتب الدابوكسيتين، كلنا بنكتب الزيلوكين جل. لا استاذنا الدكتور صلاح زيدان اتكلم على الفيلر واتكلم على الفيلر تكنيك، واتكلم ان ازاي ان الفيلر بيحسن الساتسفاكشن ريت اب تو 75%. المشكله ان ستيل ما نقدرش نعرف نحقن قد ايه ونحقن فين ونحقن ازاي. وقال ان احدث حاجه هو البوتوكس انجكشن في البالبو كافرنوزز ماسل وستيل اندر انفستيجيشن. بعد كده ننتقل للاندرولوجي سيشن 2 مع استاذنا الدكتور عبد الرحمن زهران وايمن راشد واستاذ الدكتور علاء عزت وعماد سالم. وكان في اول محاضره لدكتور احمد السقا عن الدايابيتس اند اريكتايل ديسفانكشن. طبعا there is no doubt ان tight blood sugar control و healthy lifestyle دي النمبر 1 ريكومنديشن في كل الجايد لاينز للتريتمنت اوف اريكتايل ديسفانكشن. بعدين دكتور جلال الشرباجي اتكلم على ازاي تو انهانس البينايل لينث. كل العيانين داخله عايزه a longer benign length. اتكلم ان الفنترال فالوبلاستي it's for your doctor satisfaction. اتكلم على السلايدنج تكنيك والكوربوريال سيباريشن 20% جلانس نكروزز، وكل البانل قالوا voted against السلايدنج تكنيك. اتكلم على السوبرا بيوبيك لايبكتومي، واتكلم على الانسيجن اند جرافتنج، وقال ان احنا we have to be very cautious من البنايل lengthening مع البيشنتس عشان ما نقدرش ان احنا يعني اوفر بروميس. واتكلم على القصر العيني تكنيك، واتكلم ان احنا في القصر العيني في بروتوكول موضوع ان لو الستريتشد بينايل لينث الفلاسيد ستريتشد بينايل لينث مور ذان 12.75 ما تعملش بينايل لينثنينج، ولو الفيزيبل لينث مور ذان 10.75 سنتيمتر ما تعملش بينايل لينثنينج. بس وكده بكونكلود امبارح، وبشكر حضراتكم جميعا، واتمنى يبقى ده ملخص كويس لليوم الاول، وان شاء الله اليوم الثاني بروجرام تقيل وقوي، وان شاء الله يبقى يوم مفيد للجميع.
Thank you very much, very much, Dr. Ahmed Salah from Cairo University. يعني من أحسن المرات اللي سمعت فيها highlights. I have attended several international meetings, and I have was keen in every time to listen to the highlights because it summarizes what has been delivered on the day before. Ahmed did a marvelous effort in preparing the whole harvest of what have been mentioned yesterday. It was 3 rooms simultaneously running in scientific subjects. Ahmed could collect it and could give us the very good intravenous injection or even intrathecal injection of this juice of scientific juice from yesterday. I like to thank you very much, Ahmed. You did a very good job, and this may be carry a responsibility on your shoulders to be keen on the highlighting all the coming meeting, inshallah. You did it very well, and thank you very much. And I hope that it would be the most important session in the program. This is highlights, because if someone did not attend yesterday any of the rooms, he has to catch this from the juice that would very well prepare. Thank you again, and you did it very well. I think this is recorded, and all the events of this meeting is recorded, and it would be settled in the website of the society. For those who was not able to attend these highlights, he has to have all what have been mentioned on the day 1 of this conference. I think it is now the time to start the second session. I would call for my co-chairman. It is 9 o'clock exactly now. Let us to stick to the time, and I may invite my co-chairs. دكتور أحمد السقا، دكتور لطفي البنداري، دكتور إيهاب رفعت، دكتور طارق عبد الباقي. Very good. خير. Do you have all the lectures of the AUA meeting? Of course, for some constraints in the AUA policy, in the meantime, I think for some reason they couldn't come physically to attend the meeting as it was in the previous years. I think, but they were generous enough to send all the presentation. electronically, and we will listen to the topics they have to address, and then we have to make sure mere rearrangement of all what cooperation between us and the American Association of Urology should continue and should be more strong. But for some administrative issues in the recent era of the how to manage spending money and all this, because you know Mr. Trump is affecting all the policies of the country. In the meantime, I don't know if this is the reason or not, but anyway, let us to be scientific, and we have to start this session of the AAU and the AUA. I think we have also to invite the first the welcome message by Dr. Joe Karam. He is the one who is leading the administrative part and organization of the cooperation between Egyptian and American Association of Urology. First presentation of the Joe Karam, please.
Good afternoon. Thank you very much for having me today. I am especially grateful to Professor Hassan Abulainen and Professor Sharif Murad for the invitation, and I appreciate also the invitation to the AUA in general and to my colleagues from the AUA. My talk today will be regarding salvage surgery for local recurrence after primary treatment for patients with kidney cancer. And these are my disclosures. Just to start, I'll go ahead with definitions at the beginning, and I want to define definitive treatment as a treatment that we are doing aiming for cure. And this could be anything like focal or ablation therapy, such as radiofrequency ablation, cryoablation, microwave ablation, and sometimes we could even consider radiation for renal masses as one of those treatments. The more definitive treatment that we're all familiar with is surgery, which could be anything from open to laparoscopic to robotic surgery, and this could include partial nephrectomy or radical nephrectomy. So let's also define what we mean by a local recurrence. So after ablation, this is something that we refer to as an increase in size of the tumor that we ablated, or presence of enhancement in the residual tumor, or a positive biopsy that is done more than 6 months after the ablation. Now, after radiation therapy, the definition of local recurrence is still very unclear. In clinical trials, this has been defined as an increase in size by more than 20%, which is meaning using the RECIST criteria. However, for some reason, they don't consider enhancement after radiation or even a positive biopsy after radiation as local recurrence, which is very debatable to say the least. So what about defining an isolated local recurrence? So this means we have a cancer that we already treated, there was a recurrence after that, and the recurrence is in the retroperitoneum, which could be anywhere from the kidney itself, or where the kidney used to be, what we call the renal fossa, or the adrenal gland on the same side, or the lymph nodes and at the same side of the kidney. And this is all in the absence of distant metastatic disease. Again, this is how we define an isolated local recurrence. How often does this local recurrence happen? With ablation therapy, it's generally under 10%. In appropriately selected patients with partial nephrectomy, it should be under 5%. With radical nephrectomy, it should be under 3%. Current data with radiation therapy is very close to 0% local recurrence, which it's difficult to believe, and it could be related to the way that the definition of local recurrence is done in patients who had radiation therapy. So how do we find the local recurrence? Generally speaking, we find it after routine imaging that is done after therapy with either a CT scan or an MRI. Rarely we find it after symptoms from treatment or after treatment, such as pain or bleeding or fatigue, weight loss, or actually feeling a mass. And if these happen, usually this happens many years after the initial therapy, and by that time the patient is possibly lost to follow-up. So what are the two possible scenarios in this case? We could have either a local recurrence alone, and this is the best case scenario, or we can have a local recurrence plus a distant recurrence, which means metastatic disease in addition to the local recurrence. And of course, this is not the most favorable scenario. So what do the guidelines tell us? Multiple guidelines are out there, as you know, and there is no specific recommendation regarding the management of patients with a local recurrence. So what do we do when we do find a local recurrence? One of the most important features, in addition to defining the isolated local recurrence, is to check for metastatic disease. And for that, we do need to do a metastatic workup, specifically a CT of the chest. We also want to personally review carefully the CT or the MRI of the abdomen and pelvis, MRI of the brain if indicated, and a bone scan if indicated. Now, if the suspected local recurrence is small, there is no harm to repeat the imaging on a short interval in a few months and keep a very close eye on this suspected recurrence. Now, of course, if you see a lesion and you're not sure if it's a hematoma or a recurrence or a calcification or whatnot, it's okay to do a biopsy if necessary. So how do we decide on what treatment should we do for our patients? And this is very similar to what we do for small renal masses, that we have to consider both the patient factors, such as the age of the patient, their performance status, how well their kidneys function, their medical comorbidities, their oncological comorbidities, and also what the patient wants and expects from the treatment. In addition, of course, we have to consider tumor factors, such as the size of the tumor, the location of the tumor, the growth rate of the tumor, and any pathological information from the biopsy if available. So let's talk about three major categories of local recurrence. The first one I'll start with is local recurrence after focal therapy. The next one is recurrence after partial nephrectomy. And the final one is recurrence after radical nephrectomy. So let's start with focal therapy, including ablation and radiation therapy here. Generally speaking, as I mentioned earlier, it's less than 5 to 10% recurrence after ablation. And there's multiple options at this point. We could observe these patients because generally the initial mass even was small and potentially could have been observed. So a small local recurrence can be observed in the appropriately selected patient. Of course, we can do a repeat ablation, or we can take the patient for salvage surgery. Now, these data are a bit on the extreme because these are in patients who have von Hippel-Lindau disease, and these patients have had multiple prior surgeries sometimes, and they have, in general, multiple tumors at the same time. So this is a series from many years ago, including 13 patients with VHL that had prior radiofrequency ablation, and all of these patients had salvage surgery for the local recurrence. All had a partial nephrectomy. The average number of tumors removed was 7. The average operating time was 8, and the average blood loss was 1.5 liters. So very extensive surgery. This is our experience with surgery after local recurrence after ablation. This is also many years ago, and we included 14 patients. 10 of them had RFA and 4 had cryoablation. Surgery was done roughly about 2 years after the ablation. 11 patients had a partial and 3 patients had a radical nephrectomy. Patients were at the expected age group of 65. Surgery took a bit longer than the average, roughly about 3.5 hours. Blood loss was within acceptable limits, and the size of the tumor, as expected, was small, about 3 centimeters. 4 patients had major complications, and they all recovered. Only 1 patient out of these in our series had a recurrence locally, and this was a patient with VHL as expected. Now, these are updated data from the Cleveland Clinic, including 27 patients. Most of them had cryoablation, and out of these 27 patients, 14 had a partial nephrectomy, 12 had a radical nephrectomy, and 1 patient actually had an aborted surgery. The median tumor size, as expected, was also small, about 3.6 centimeter. Blood loss was similar to our series, a little over 200 cc's. 22% of the patients had a major complication, and the follow-up was still on the short side, a little over 1 year, with 2/3 of the patients having no evidence of disease, 8% having a recurrence, and the rest having been lost to follow-up. This is from our European colleagues. 35 patients with ablation failure, Patients had a robotic partial nephrectomy for the most part, and the vast majority of these patients were pathological T1A, again indicating the small tumor size after ablation or recurrence. 2 patients had major complications, specifically bleeding requiring angioembolization. 5 patients had a minor complication, and the follow-up was a good length of follow-up at about 3.5 years, with no local recurrence and the median renal function of GFR of 38. Now, this is a patient, just to illustrate what we're dealing with here, with a right renal mass that had ablation therapy, that was failed by the ablation therapy, and then we did an open partial nephrectomy with a clamp time of 8 minutes. Pathology was T1A as expected, small tumor, with clear cell being the pathology, low grade, negative margins, and now the patient has been with no evidence of disease for more than 5 years post-operatively. Again, indicating a favorable outcome in general in these patients, because in general you're already starting with a small tumor and you do ablation, and recurrence after that can still be successfully managed in the appropriately selected patients. This is another patient showing you here, 71-year-old who had chemotherapy for lymphoma and had no evidence of disease from the lymphoma. And this is at diagnosis. You see a small renal mass in the upper pole medially. You see here the lymphadenopathy from the lymphoma treatment. And from, this is residual lymphadenopathy at this point. It's not active disease. So again, this is at diagnosis. The patient was referred for ablation for this mass because of her age and lymphoma status. However, this is how it looked like several months afterwards. You could see here the tumor is now extending into the diaphragm and into the adrenal gland. Still relatively small, but in a pretty bad location. Again, showing you the images here. You could see the tumor extension clearly in this video. So this patient had robotic left radical nephrectomy and adrenalectomy, in addition to resection of portion of the diaphragm en bloc with a tumor and a closure of the diaphragm in a primary fashion. And this was the pathology showing a recurrent clear cell RCC, still again small tumor, 3.8, low grade. However, it is extending into the perinephric soft tissue and into the renal vein. The adrenal gland itself had no tumor and the margins were negative. So even in these extensive recurrences, surgery can be successful again in well-selected patients. Now this is moving on to radiation. This is a phase 2 trial looking at 70 patients here. Age was 77, a slightly older age group than our usual series. Patients had different types of radiation depending on the tumor size. The endpoint was local control. Again, this was defined by RECIST criteria as tumor with less than 20% growth. Follow-up was around 3.5 years, and the local control at 1 year was 100%, which essentially means that none of the tumor grew by more than 20%. And some of the statements from the authors were that the post-treatment tumor responses evolve over years. And in contrast to ablation, persistent enhancement following radiation is common and is not correlated with the risk of subsequent progression. However, this is a bit theoretical still at this point and remains to be proven. I'll show you a different patient that I took care of, a 55-year-old healthy patient who had a nephrectomy 10 years prior to presentation for a T1B disease at a different institution. And the patient was referred by her local physician for stereotactic radiation. You can see the tumor here in the lower pole of the solitary kidney, on the right kidney. And this is before ablation. Quite a small tumor, very manageable with surgical resection in a healthy young patient. However, the patient was referred for stereotactic radiation. Now this is after stereotactic radiation, specifically 6 months afterwards. And you could see here some evolving changes. It just still did not look right, but you could see some changes here, maybe some extension into the kidney, and the patient was doing fine clinically and was happy with her outcome. But I insisted on getting a biopsy just to be sure, and the biopsy showed no viable tumor. So we said, okay, well, let's bring you back to clinic in 6 months and see how it looks like. However, 6 months later, this is what it looked like. As you could see, quite different, much larger, some vascular changes in the kidney, some deep extension as well. And you could see it right there. So at this point, we decided to proceed with surgery. I decided to do an open partial nephrectomy since the patient had a solitary kidney and had radiation to that kidney, and the tumor appeared to be quite extensive. This was done with 11 minutes of cold ischemia, and the pathology was pretty impressive. It was a grade 4 tumor, measuring 3.2 centimeters, invading the sinus fat and invading the lymphovascular space. Margins were negative, so it was a T3AR0 tumor. And this patient subsequently ended up receiving adjuvant immunotherapy. Now, moving on from local recurrence after ablation, let's talk about local recurrence after partial nephrectomy. And just showing you some representative pictures here. This is a patient who had a partial nephrectomy at an outside institution. And this is many years afterwards. You could see a central tumor in the right kidney on MRI with extension into the renal vein at this point. Thankfully, this occurrence is unusual. In isolation, it's less than 5%. And then the way we define it is either in the kidney itself, in the same area of the prior treated tumor, or in a different area of the same kidney, or around the kidney, such as in perinephric fat, or in lymph nodes, or the adrenal gland. This is from the Mayo Clinic series, looking at patients who had a prior partial nephrectomy, 48 patients with 68 tumors. In this series, all the recurrences from the partial nephrectomy were treated with salvage cryoablation. The tumor size, as expected, was small, about 2.5 centimeters. Major complications were about 5%. However, the follow-up was still short at about 1.5 years, and about 10% of patients had another recurrence. This is from the NCI. Again, very heavily treated patients, mostly patients with VHL disease. And here they looked at 47 patients that had a local recurrence that were treated with a repeat partial nephrectomy. As expected, very long surgical time, significant blood loss, 7 tumors removed on average, and the average size of the tumor was about 3.5 centimeters. Complication rate, not surprisingly, was around 20%. Major complications, and 3 patients had to have a radical nephrectomy, and 1 patient died postoperatively. The follow-up was about 5 years, and 20% of the patients had another recurrence that required surgery. Again, keep in mind these are patients with VHL. Ultimately, 46 patients were still alive at the time of the last follow-up. Now, this is from our series looking at 44 patients with a local recurrence after partial nephrectomy. So this is a very strict definition that we use with a recurrence in the same kidney. And then we looked at 163 matched controls with no recurrence. And these are the pathological stages at the initial partial nephrectomy. As you can see here, about 40% were T1A and about 20% were PT3. And most were clear cell at the time of the partial nephrectomy, the initial one. And here we're looking at difference in the recurrence-free survival based on the margin. As expected, here in the blue line, you see patients who had a positive margin tend to have a higher recurrence rate. Patients who had a higher complexity of the tumor, here specifically the renal score of 10 to 12, they tended to have a higher recurrence, local recurrence after the partial. If there were more than 2 tumors, it tended to have a higher recurrence afterwards. Of course, patients with stage 3 or T3 disease tended to have a higher recurrence. And again, this is all in the blue line. Patients with a solitary kidney, the recurrence rate was higher. And again, here when we put all this in multivariable analysis, you can see that patients who have a solitary kidney, who had a positive margin after the partial, who had more than 2 tumors after or during the partial, who had high complexity tumors, and who had T3 tumors tend to have a higher local recurrence rate. Again, none of these are surprising, and some of the explanation is that these are surgeries or partial nephrectomy specifically that we're doing because we have to do them in a solitary kidney or in multiple tumors, for example. So So again, none of this comes as a surprise to us. The timing between the partial nephrectomy itself and the local recurrence was 2 years. And this is what we did for these local recurrences, a combination of different salvage surgeries that you can see here, or salvage ablation. Some of them we even observed, and in very few cases we did systemic therapy, as you can see here. When we did surgery for these local recurrences after the original partial, time was a little over 2 hours. Blood loss was a bit over 500 cc's. And you could see here the pathological stage at salvage surgery was mostly T1, but we did have 10 patients with T3 at the time of the salvage surgery. This is the patient I showed you at the beginning of this section. This patient had a salvage laparoscopic radical nephrectomy. The tumor, as expected, was a T3A because of an invasion into renal vein branch. It was a high-grade clear cell RCC with negative margins, and at last follow-up of almost 3 years, the patient was still without any evidence of disease. And finally, the section on local recurrence after radical nephrectomy. This is a patient that I'll show you a few still images here who had a hand-assisted laparoscopic left radical nephrectomy at a different institution. And you could see some nodules around the spleen, some nodules on the diaphragm, some para-aortic nodes. You could see multiple nodules here. And the recurrence rate after radical nephrectomy is generally under 5%. This is MD Anderson experience, but this is from 30 years ago. 16 patients with locally recurrent disease. Half of them had neoadjuvant therapy. 15 patients had a complete resection. 12 of them had clear margin. Again, this is something that's been practiced for many, many years now. And about 12 of the 16 patients were alive at 2 years after the second operation, which is the salvage operation. Similar outcomes from our colleagues at the Mayo Clinic, that if your treatment of a local recurrence includes surgery, generally the outcomes are better. And of course, we can easily argue that this is due to selection bias, which is appropriate because we shouldn't be operating on all patients with a local recurrence. We have to define which patients are most suited for this aggressive approach. Now, a more recent work that we did spanning the years of 1990 to 2014, a little over 100 patients who had surgery for local recurrence. About 84% of these patients had the initial radical nephrectomy at a different institution, and then they were referred to us for surgery for the local recurrence. The timing between the nephrectomy and the recurrence was about 1.5 years. The patients were on the younger side. These are 55 years median age. 80% had an open operation. 60% were T3 and T4. About 20% were node positive at the time of the initial surgery, and about 14% had positive cervical margins. And these are the locations of the recurrences. Roughly half of them were in the soft tissue or in the renal fossa. About 40% were in the lymph nodes, and about 10% were in the ipsilateral adrenal gland. About 40% at the time of the local recurrent surgery had symptoms, and almost half received some sort of a neoadjuvant therapy. The recurrence size was about 5 centimeters on average. Most of these patients, we did open surgery for the local recurrence at the time. 15% major complications, blood loss of 700 cc's, and the surgical duration was about 3.5 hours, and hospital stay was about 1 week. What we saw here is about 60% of these patients had a cancer relapse after their local recurrence surgery, again indicating the aggressiveness of their disease and also the limit of what surgery can do in this setting. The median time to the relapse was about 2 years, and when we add everything together, the median survival after the second relapse was about 5.5 years. And again, this is before the days of immunotherapy and current systemic therapies that we have available. Now, what we found is that the predictors of worse outcomes after surgery for local recurrence includes having positive lymph nodes at the time of the initial nephrectomy. And again, in our series, we have 20% of patients that fit in this category. And the other predictor of worse outcomes is the larger size of the local recurrence, which biologically makes sense. This is what we see here in this graph, that there's really no difference in survival based on the location of the local recurrence, which is adrenal versus soft tissue versus lymph nodes. And moving on to an isolated retroperitoneal lymph node recurrence, which is a very important topic. This is work from 4 different major tertiary centers, including 50 patients. And the time between the nephrectomy, the original nephrectomy, and the recurrence in the isolated lymph nodes was about 1 year. And the follow-up after removing the lymph nodes was about 2 years. Ultimately, 26 patients had recurrence of their cancer roughly 10 months after the isolated lymph node resection. 10 patients died of disease, and the median progression-free survival after the isolated lymph node dissection was 20 months, with a 5-year PFS of 35%. And what the authors have noted is that if you have an isolated retroperitoneal node recurrence at less than 12 months after the initial nephrectomy, these patients had a worse progression-free survival of around 12 months compared to the recurrence that happened more than 12 months after the nephrectomy. And for these patients, the progression-free survival was about 4 years. This is data from our colleagues at the Mayo Clinic that looked at 16 patients who had a recurrent IVC tumor thrombus after an IVC thrombectomy. 3 patients had metastatic disease, so they were not offered surgery. These 3 patients died within 6 months, unfortunately. 13 patients had surgery, and the time from the initial nephrectomy to the diagnosis was 6 months. Surgery was completed in 11 of the 13 patients. Blood loss was 2.5 liters, and the median time to recurrence was 4 months after the second surgery, and the median time to death was 12 months. Unfortunately, all these patients recurred and died of disease with a median follow-up of 1 year. Now, there are some patients, at least in our practice, that have been able to undergo successful surgery. However, these are quite rare, and the number of patients that fit into this category are actually quite small. And by this, I mean patients who had an isolated IVC tumor thrombus in the absence of metastatic disease. In general, these patients present with metastatic disease at the same time, and in most cases are not surgical candidates to begin with. This is the patient that I showed you earlier in this section. So in 2015, when I saw this patient, we performed exploratory laparotomy. We removed all the retroperitoneal masses. We removed the artery and the vein stump. We did a distal pancreatectomy and splenectomy and hemicolectomy with our surgical oncology colleagues, in addition to a left adrenalectomy, lumpectomy, diaphragm resection, and lymph node dissection, essentially to clear out the entire left retroperitoneum. Now, the patient had another recurrence detected 3.5 years later, and you could see it here, essentially just posterior to the bladder, anterior to the rectum, and he had a robotic resection of the pelvic mass, in addition to portions of the seminal vesicles and the vas. So again, indicating that these patients can have other recurrences, but depending on the tumor biology, this could be quite prolonged, and then some patients could benefit from aggressive surgical resection when appropriately selected. So finishing up with take-home messages, we need to ask the question, does the patient need an intervention? Is the tumor amenable for an intervention? Is this intervention that you're thinking of the best one for this particular patient? And does the treating physician know how to do the intervention? And if all the above are correct or true, then it is okay to proceed with this intervention, but this has to be done very carefully and very thoughtfully. Local recurrences, thankfully, are rare, but can occur after the initial treatment. It is important to follow up with a urologist after and before the initial treatment. It is best treated in experienced medical centers. And then just to summarize the data, that surgical resection in patients with good performance status should be done. And in patients who have a local recurrence after focal therapy or a partial nephrectomy, the outcomes are generally excellent. In those who have surgery for recurrence after radical nephrectomy, you can approach a 40% cure in patients that are well selected with low tumor volume. The best outcomes in this scenario is to have a low comorbidity, to have good performance status, to have minimal to no synchronous metastatic disease, and to have a late recurrence, which is generally defined as more than 1 year after the initial procedure. And with that, I would like to invite you to come to the AUA in May of 2026, which will be in Washington, D.C., and I look forward to seeing you there. Thank you very much for your attention, and this is my email if you have any questions or if you would like to have any discussions about this topic or others. And again, I'm very grateful for the Egyptian Urological Association, and I appreciate the opportunity to be here with you all today. Thank you very much.
Thank you very much. And I'm sorry again for this is a recorded message, but it is very filled with a lot of thoughts about what has been known about kidney cancer. Of course, he went through a long journey, especially dealing with late local recurrence or distant metastasis and different options of treatment. And the last take-home message was very clear that is it amenable for intervention? Are you able to do it? Is it in favor of the patient survival or not? I think although the recurrence rate is rare of about 3 to 5%, whatever the technique you use, but anyway, we are faced, as we can see, in a few occasions of recurrence after the treatment of renal cell carcinoma. And of course, we don't have to stop follow-up of these patients. And last week, I had a case that had been operated by radical nephrectomy 15 years ago, and he came with a mass in the base of the neck between the two shoulders, subcutaneous big mass, still a little bit some limited fixity, and had been biopsied by general surgeon, and it proved to be renal cell carcinoma, although he was operated 15 years ago. So this means that the natural history of this disease is variegated from time to time, and once the patient has a history of malignancy, if he comes with any complaint, please consider that it could be related to the previous history of treatment of malignancy. This is the lesson that we can come from that. We have to move to the next speaker from the AUA program.
Next presentation by Professor Howard Goldman, Management of Sling Failures and Complications. Recorded also.
Hi, I'm Howard Goldman, and I'm from the Cleveland Clinic in Cleveland, Ohio. My area of expertise is functional urology and female urology, and I am quite happy to join you at the Egyptian Urology Association meeting on behalf of the AUA, and it's good to be here. So what my lecture is going to be about is the management of sling failures and the complications of midurethral slings. So these are some of the things we'll talk about. What happens if a sling fails? What happens if it causes obstruction? If there's injuries, or if there are some of the mesh-related problems that can occur. So if you look overall at midurethral sling outcomes, generally 5 to 15% of patients who've had one are considered a failure. Now here's a nice study that looked at both retropubic and transobturator slings, and between the two of them, again, roughly a little over 5% failure rate that needed to be redone. This was a very nice study published a few years ago, looking at thousands of patients. It was done at a big hospital chain in California, and they looked at 17,000, of which over 7,000 had at least 5 years of follow-up. And what they found was the all-cause reoperation rate at almost 10 years was 6%. The reoperation rate for recurrent stress incontinence was just under 6%, and re-op for some kind of complication was about 1%. And most of those cases were because of obstruction. Now, we know that the vast majority do well. But what do you do with those that are still leaking? Well, I think first you have to rule out persistent, maybe they have overactive bladder. And if that's the case, that's a different treatment. But what if they really have stress incontinence? So you could watch them, but it's not going to get better with time. You can try bulking agents that works temporarily, may recur, but there are some newer agents that are helpful. You can tighten the sling, or you could do another sling. Problem is there's not really good data to guide us on what the best next step is. There is currently a study that is enrolling patients, looking at the various different options for patients with failed slings, but we don't have the data yet. So when you think about bulking agents, in general, the outcomes are similar to patients who've received bulking for the first time. Works in some patients, doesn't always last, and sometimes requires repeat injections. But it could be used as a temporizing measure. And some of the newer agents we have in the United States, Bulkamid, otherwise known as polyacrylamide hydrogel, which very promising to date. Here's a study looking at it where they did it for patients who'd failed a previous TVT. They had about 1 year of follow-up. And the bottom line is they had a cure rate objectively of stress incontinence of about 73%. It's not bad. Here's another one looking at the same thing, same agent. And again, when they looked at it, they had about 25% cured or dry, but another 60% who were improved. So again, it is certainly an option. Here's another big systematic review, meta-analysis. This looks at not only Bulkamid, but looks at macroplastique as well. And at the end of the day, very similar findings. What about sling tightening? So this is based on the idea that the sling was put in too loose. And the way it's done is the sling is dissected out, it's then folded, and it's sort of tightened. Some sutures are put in to tighten it up. So if this is what the sling looks like, you put some suture in it, and therefore when you tie it down, it kind of shortens it a little bit. So I've tried this in a few cases. The data's mixed. It hasn't worked too well for me. This was a nice study where they actually looked at shortening of the tape or repeating a sling, and you can see the black lines are the sling repeat, and those patients clearly did a lot better. So if you do redo a sling, when do you do it? What type of sling would approach, and what about the original sling? And I think timing, most people would usually wait at least 3 to 6 months. Here are some studies looking at retropubic versus transobturator slings. And you could see the retropubics did better. They had a higher cure rate, even though the leak point pressures were lower. So it would seem while the stress incontinence was worse in those patients, the outcomes were better for a repeat sling with a retropubic approach. Here's another study. It was a 3-year prospective randomized trial between a midurethral retropubic versus a transobturator. And bottom line is, only 1% of those who had the retropubic sling needed another sling, whereas almost 1 out of 5 who had the obturator sling needed another sling. So again, what type of sling, what approach? I think in general, most people would do a midurethral sling. Some people might do a fascial sling. Perhaps if they had a fixed urethra, maybe they needed a fascial sling in the first place. My sense is that most people are more comfortable today with the midurethral synthetic sling, and there are studies that support that. And so if you're doing a synthetic, what approach? And again, I would suggest retropubic does better. Some people have talked about doing a spiral sling, where you sort of wrap the sling around the urethra, either with fascia or synthetic. There was a study. Most of the patients had a synthetic spiral, some had fascial, and they claim almost a 72% success rate. I'd be very careful with this. We've had multiple patients who had a spiral sling with synthetic sent to us where the synthetic eroded through. I think a lot of these patients go into retention, and that may be acceptable to some, but you have to be careful. So I don't think too many people do this currently, and there is a high rate of need for clean intermittent catheterization when this is done. And as I've said, we've seen a number of the synthetic ones that were wrapped all the way around that eroded. So autologous fascia, this is obviously quite popular, and many people would prefer to do this. It has high success rates, though it is a higher obstruction rate than synthetic midurethral slings. And I think it's important to realize that when the original autologous fascial slings were popularized, they were originally done primarily for cases of recurrent incontinence after prior Birch or modified Pereira or STAMI or some other type of procedure. So they were originally sort of a secondary procedure. So autologous fascia is good, and there's data on its use as a secondary procedure. This looks at some of the papers that have been published when it's used after a failed mid-urethral sling. This is a nice large study with at least a year's follow-up. They only ran into and cut the original sling at about 40%, but they had about a 70% stress incontinence cure rate after an autologous fascial sling, which had been done after a failed mid-urethral sling. There's also another interesting option. There's something called the adjustable sling. This is a very interesting sling. The idea here is it almost is like a synthetic mid-urethral sling, but the synthetic is just right under the urethra, and then there are polypropylene sutures that bring it all the way up into the prepubic area and anterior to the fascia. And there's this little device there that's almost like a fishing reel. And so what happens is you put this sling in just like you would a retropubic mid-urethral sling, but you make an incision in the lower belly, just above the pubis, a few finger breaths cephalad to the pubis, and then you hook the suture into this thing, and there's a screwdriver, and you tighten it up, and then you leave that screwdriver in place post-op. So it looks like this at the end of the case. And then what happens is the patient comes into the office the next day, or if you kept them overnight, you do it in the hospital, and you go ahead and fill the bladder with water through a catheter, take the catheter out, have them cough, they leak, and you give it a few turns. They leak, you give it a few turns. And as you're doing that, it's tightening it up. And you do that until they stop leaking. And then you loosen it a little. And then that screwdriver detaches. Now the nice thing is, let's say 6 months later they start to have leakage again. You can, prep that area sterilely, numb it up, and go back down to that little device and get a new sterile screwdriver and do the same thing and tighten it or loosen it as necessary. Interestingly, some people have actually started, in some cases, replacing that little piece of mesh with a small piece of fascia if they were going to do it a little on the tight side. So this is interesting. And again, as I said, it can be readjusted in the future, can tighten it or loosen it. Here was a study looking at this, and they looked at it for patients who had recurrent stress incontinence. And the bottom line is they had about a 70% success rate for the patients who had this done after a previous failed sling. So it's nice. Of course, it's more expensive than the standard sling, but it certainly serves a role. And sooner or later, about a third of these patients do need to have retentioning. There is obviously a higher risk for infection because you do have this foreign body sitting there, but I think in today's world, that risk is pretty low. What do you do about the original sling in any of these cases if you're going in to do a second sling? So I don't look for it. I leave it alone, assuming they don't have obstruction or like new OAB. I mean, if you think they're obstructed or the sling's causing a problem, then certainly you want to cut it or take it out. However, if you don't see it and they weren't having any problems, then you just do your standard procedure and you go ahead and place the new sling. Sometimes if you're doing a retropubic sling and you happen to hit the old mesh, you just have to move the choker a little bit to get past it. There's also the artificial urethral sphincter. So we're very familiar with that for using it in men for post-prostatectomy incontinence. But remember, it was originally designed for women way back when it was first developed. Now, it's currently not utilized much, except in France, they do utilize it a fair amount, and they've been doing them now robotically. So it's beginning to become a little more popular. And it's even getting a little more popular because there's now a company that has an artificial urethral sphincter that doesn't have the pump that goes in the labia. It just has an electronic key fob that they can hold on their keychain, and when you press it, it causes the balloon to deflate so they can void, and then it slowly reinflates, and it has some other unique properties. So this is undergoing testing right now, and we may in the future, if we're doing this robotically and without having to put a pump in the labia, this may become more popular. What about a birch? What about a copal suspension? So there's very little data on using that after a failed mid-urethral sling, and I think in general the birch is best for a first-line surgery in a younger woman with incontinence who does have urethral hypermobility. Now, if you look at what do surgeons and women think about all this, the bottom line is most surgeons prefer a repeat mid-urethral tape, mid-urethral sling, above other options. So I think that's what most people would do. If you look at the Cochrane Library, they did a whole review, and essentially, as you can see there in the conclusion, there were insufficient data to assess the different types of management. So again, we don't have that data, but there are studies that are looking at it. All right, let's talk a little bit about complications. So the most common one is iatrogenic obstruction. For whatever reason, it ends up too tight. And the classic example of that is a patient who's in retention. But there are many other symptoms that patients can have that unfortunately sometimes get missed. Someone could have incomplete emptying. Many patients will tell you they have a very weak stream. It takes them a long time to urinate. They have to move around or bend over to void. Some patients may start to get recurrent urinary tract infections. They may have new or worsening overactive bladder. And all of these may be a result of obstruction. So if you have a patient with any of these things after a sling, you have to evaluate them for obstruction. You should also do a cystoscopy to make sure the sling's not in the bladder. Again, if they have new OAB, evaluate for infection, obstruction, or maybe a foreign body in the bladder or urethra. The most important thing is the temporal relationship. So if somebody is urinating fine, they have a mid-urethral sling, and the next day they have trouble urinating, okay, that's fine for a day or two. But if a week later they're having trouble urinating, it's the sling until proven otherwise, or any of those other symptoms. Of course, you still have to do an exam, check a post-void residual, do a urinalysis. Many people might do a urodynamics to evaluate them, and we'll come back to that in a moment. Here's a patient, came in with recurrent UTIs for years. Now on history, 7 years ago, she had a vault suspension, she had an anterior-posterior pair, and she had a retropubic mid-urethral sling. Now we did do urodynamics, and on urodynamics, she ended up definitely, you'll see in a moment, having obstruction. So these were her symptoms. She didn't have any leakage, but when she voided, she had a strain, she had to move around, and she had trouble emptying. On exam, really not much going on. PVR was not that high. Cystoscopy, she has some trabeculation, so maybe she has some obstruction. But on urodynamics, what you'll see, so the yellow line is where we give her permission to void. And what you can see is you can see high pressure. There's low flow. Unfortunately, I believe it's covered by my picture here. But trust me, there's low flow. And on fluoroscopy that we did at the same time, you can see some trabeculation. And as she starts to void, you see a dilated proximal and mid-urethra with sort of a cutoff point over there. And that's where the sling is. So the treatment for that is she needs some kind of sling incision. Now again, many women in urodynamics may not generate a good extruser contraction. So if the history is good, if she says she was voiding fine until she had a sling and now has a weak stream and UTIs and OAB, even if the urodynamics does not show that classic obstruction, I would still go ahead and treat her. I'd cut her sling. And as a matter of fact, in my hands, if it's a very good, perfect story, I may not even get urodynamics. So again, treatment of obstruction with fascial slings, it could take a little while till they urinate normally, but with a mid-urethral sling, they should be urinating normally a few hours after surgery, or certainly within a few days. Now, in the first few days, you can go back and kind of pull it down a little, stretch it or loosen it. You rarely need to do a full urethrolysis because really the obstruction is on the undersurface and it just needs to be opened up. And we generally do a sling incision. So you just find the sling in the midline. Some people like to do it laterally. I like to do it in the midline, and I go ahead and make an incision. Now, that usually does the job. And again, in the first week or two, you can maybe stretch it or pull it down. But after about 2 weeks, you're not going to be able to do that. It's scarred in, and you've really got to cut it or take out a portion. Now, it's important to make sure that you actually saw the mesh. I can't tell you how many patients I got sent to me who had a sling incision, supposedly, and I go back in and find it. Many times when I read the operative note, they say, we saw some scar tissue, we cut it. It's critical that you really are 100% sure that you saw the mesh and you cut it. Here's an example of how we do it.
After the patient is prepped and draped, she is placed in a steep with position. The area of the obstructing sling is identified. For mid-urethral slings, this area of obstruction is approximately 2 centimeters from the urethral meatus. The anterior vaginal wall is then infiltrated with a mixture of lidocaine and epinephrine. A midline anterior vaginal wall incision is made 2 centimeters proximal to the urethral meatus at the area of the previously placed sling. With careful, sharp, and blunt dissection, the sling is identified.
And often you can feel it with the knife, like a scraping. And then you can see it. This one happened to be very distal. And eventually you just get around it with a right angle.
A right angle clamp is used to create a plane between the sling and the urethra. Once completely behind the sling, the right angle clamp is opened. The sling is then incised using a scalpel.
If you look overall, success rates are quite high. Recurrence originally was reported in about 20%. I think it's a little higher than that. And I usually tell the patients it's about 30 to 50% chance of recurrent stress incontinence. Other things, you could have mesh complications, you could have a vaginal exposure, you could have erosion into the bladder urethra. And so how do we handle that? So if it's extruded, if you see a little bit of mesh vaginally, if they don't notice it, they're not having any discharge, they're not sexually active, you probably don't need to do anything. But if they are having some pain or their partner is having pain during intercourse, then you probably have to do something. If there's mesh in the bladder, they will often have infections or overactive bladder or things like that. So the exposure rate is probably about 2%. Probably from a thin flap or maybe vaginal atrophy, or I think sometimes there might be a little hematoma, and then the incision line breaks down. So you could try putting some vaginal estrogens there. I think that may help a little bit, but usually doesn't cure it. Some people have tried dissecting it out and using a flap to cover it. I think usually it comes back, and I think usually you have to just excise the portion that's exposed. With the obturator slings, sometimes you'll get a buttonhole in the sulcus. Again, you can try a cream, but usually you're going to have to cut it out. And I think if it's a small area, you can often do it in the office, even with a little local. Here's one that they'd gone back 2 or 3 times and put flaps over. But the crazy thing here is the sling is not even in the right place. If you notice it, when they went to the transobturator area, they're sticking it through the labia. So no degree of flaps is going to help, and this has to come out. So again, that's if it's eroded, extruded. What if it's eroded? What if it's causing pain, infection, etc.? Obviously, you're going to do a cystoscopy to really take a good look. Okay, so if you see it in the bladder or even in the urethra, some people like to laser it and take it out that way. If you do that, you have to get really deep because you don't want any little prongs still sticking in the urethra, because if they are, that'll just form little stones on it. If it's in the posterior half of the bladder, I'll usually go in transvaginally. If it's on the anterior half of the bladder, I'll usually go in, I used to do it open, but now I do it robotically. This is just a paper looking at when they did it with laser endoscopically, they had to do it multiple times. So again, open, you can do a fan and steel incision. You open the bladder, you find where the sling is going in, you follow it in, you follow it back out, you remove that portion, and you close the bladder. Here's a little video of us doing one robotically. Once we do that, we start looking right at the level of the impedance, because really the sling should be, if you think about it, it's about 2.5 centimeters from the line. So the pubic symphysis, so the sling should be right over the symphysis in the middle. In this case, was weird because we didn't see it. Usually you see it right attached to the back surface of the bone. On both sides, we couldn't find it. You can see it going on the balloon, fully balloon. It was absolutely no sign of it. And then we noticed there was this band in the peritoneal reflection. And if you start to take down this band, as you'll see in a moment, lo and behold, there's mesh. So the sling actually was very cephalad. It was not against the bone. It was, they're lucky if it would have been a little more cephalad than the spine. That's the sling right there. So in this case, as you'll see, we're going to follow that down to the bladder. And once we get to the bladder, we're going to open the bladder right at that spot. And then essentially we will follow the sling back out of the bladder. So here we are sucking the sling, there we are, that's where it's going in the bladder. And then as you see, there's a portion of the sling in the bladder. And now we're just going to gently around it a little bit. And then in a moment, we're going to make a little crucial incision just distal to where it is in the bladder. And then we will follow it back out. Crucial incision, and now we're going to start dissecting it off the bladder. Out of the bladder. Essentially, we're going to cut it off. Use them. And then we're just going to go ahead and close the bladder into those. What about pain? So sometimes we see retropubic pain, but we've seen a number of cases of very bad thigh pain after transobturator sling, to the point that we've actually had to go ahead and remove that portion. And we'll show you a little video about that.
Thigh exploration for excision of a transobturator sling.
All right, so I think a number of complications we've gone over: failure, what to do about it, how to handle bladder outlet obstruction, and then how to handle mesh-related complications. I think the take-home message is that if these are managed appropriately, most of these can be treated with minimal morbidity. I do want to end just by reminding everyone, AUA, May 15th to 18th in Washington, D.C. We'd love to see you there. A lot of good things. Feel free to join the AUA. A lot of benefits to being a member of the AUA. Get a lot of their apps, a lot of their journals, and access to their core curriculum. With that, I would say thank you, and I hope you enjoy the rest of your meeting.
Thank you very much. Although with some technical problems of having the full video and the voice recording, of course, it has been sent by electronically, and maybe this is the taxes that we have to pay from the problems of technology, of course. I think sling operation is very well known for all of us, and especially with those who are specialized for female urology to treat stress incontinence. And we have been learned that the first success is the best. Revisional surgery usually is a little bit maybe demanding, and maybe goes into another complication rate, erosion, infection, failure, etc. I remember one case when I was in a visit to Qatar in Doha, and a simple sling surgery ended up by necrosis and gangrene of the area of the bladder neck and the urethra, that ended up by removal of everything, and the continent urine diversion was unindicated because the whole mechanism of voiding has been destroyed secondary to infection. She was, yes. And for this is the extremes of complication, of course, but anyway, the first success is the best. And for the time strains, we have to move to the next speaker.
Next speaker will be Professor David Benson. He will talk about high-risk prostate cancer.
Hello, my name is David Penson, and I'm the Secretary of the American Urological Association. It's a great honor to join you today and give this presentation at your meeting. I wish I could be there in person, but unfortunately I can't, so this will have to do. I want to congratulate you on your meeting, and I'm looking forward to speaking to you today. Today we're going to talk about optimizing the management of high-risk prostate cancer, specifically suspected localized high-risk prostate cancer. Let's start by agreeing on what is high-risk prostate cancer. Well, actually, it's not quite as straightforward as one might think. The original definition of high-risk disease, as put forward by D'Amico almost 25 plus years ago, is a patient who has either a PSA greater or equal to 20 nanograms per cc, or he has Gleason sum greater or equal to 8, or he has clinical stage greater or equal to T2C. Now, this is certainly very simple, but in fact, our understanding of high-risk disease has evolved over the past 25 years. Here you can see modern varying definitions of high-risk disease from several groups. From the AUA and ASTRO, you can see localized high-risk disease described as having a PSA greater than 20, or grade group 4 or 5, or clinical stage T3. AUA also breaks this down further and refers to locally advanced high-risk disease in patients who have clinical stage T4 disease or clinical node positive disease. EAU has very similar definitions, where localized disease again is PSA greater than 20, grade group 4 or 5, or clinical stage T2C, which is the only difference from the AUA definition. And locally advanced high-risk disease is anyone who has clinical T3 or 4 disease or N positive disease. The NCCN, on the other hand, has a completely different system. For that system, to be high risk, you can have no very high risk features. You have to have at least one of the following: T3A disease, grade group 4 or 5, or a PSA greater than 20, very much like the AUA definition. However, very high risk disease, you have at least one of the following: T3C or T4 disease, primary Gleason pattern 5, 2 or 3 high risk features, and greater than 4 cores of grade group 4 or 5. Regardless of how you define it, you can see that high-risk disease is what we think of as very bad disease: higher PSAs, higher Gleason scores, and usually clinically more advanced. High-risk disease, however, is really heterogeneous. This is a study from Janot and colleagues. They looked at 1,360 men with D'Amico high-risk disease, all underwent surgery without ADT at one of 8 European centers. They threw out men who had N plus or M plus disease. Good follow-up. The 5-year estimated prostate cancer specific survival was 96.4%, and the 10-year was 91.3%. And here on the right, you can see different groups based on different risk characteristics and how they begin to break down. You can see that one definition does not fit all. And in fact, you can actually make a good, intermediate, and poor prognosis subgroup based on 3 variables: the PSA being greater than 20, clinical T3 or 4 disease, or Gleason score greater than 7. You can see that if you had one variable, you were in the good prognosis group, that is the line at the top, you had the best cancer-specific survival. If you had 2, you were in the intermediate risk group, and then it was in the middle, and obviously the poor risk group had all 3, and it had the worst cancer-specific survival. So now that we've agreed on what high-risk disease is, let's talk a little bit about imaging in this setting. What we really want to do is we want to identify node-positive disease preoperatively if possible. And if you look at the guidelines, they all recommend bone scan for assessing distant metastases, although they're starting to talk more and more PSMA scan. NCCN does not feel that conventional imaging, CT or MRI, is a necessary prerequisite to PSMA imaging. PSMA imaging is equally, if not more effective than either of these. AUA recommends initial CT or MRI in high-risk patients. And I think that's because in the United States we have to answer to our insurance companies. But AUA does say that if conventional imaging is negative, you should be considering molecular imaging such as PSMA scans. And EAU states that PSMA PET-CT is more appropriate for nodal staging as compared to MRI, abdominal CT, enhanced CT, or choline PET-CT. Why does EAU say this? Well, there's some good data to back this up. This is the seminal study from Hoffman et al. In Australia. 302 men randomized to first-line conventional imaging or PSMA PET-CT. And you can see if less than 3 disembeds were noted, all patients crossed over to second-line imaging. And as I said, we're really concerned about node-positive disease. And here you can see that in red, the PSMA PET scan has greater area under the curve than the conventional imaging. And this is primarily due to increased sensitivity as seen on the right. And this holds up in a sensitivity analysis as well. The bottom line is PSMA imaging really is superior to any conventional imaging. However, that study only compared it to CT scan. Maybe it's not as good as or equivalent to MP-MRI, but in fact it is better. And again, I want to turn your attention to lymph node involvement as you see here. And you can see again that the PSMA PET scan with the MRI is actually more sensitive than plain MRI and equally specific. So not surprisingly, it is a better test. When we look at PSMA PET versus MRI across all the studies, you can see here from a meta-analysis on the bottom that it is superior. You can see the single center study up above showing that the PSMA PET MRI is superior to MRI alone. It is has good sensitivity, good specificity and reasonable sensitivity. But when you look at the meta-analysis, you can see that the PSMA PET scan has better sensitivity than MRI alone and equal specificity, so it has a better area under the curve. And so really, PSMA PET is a very important tool to use in high-risk prostate cancer patients. So now you've gotten your PSMA scan, and it shows that there's no metastatic disease. Perhaps it shows node-positive disease, but certainly there's no bony mets. And perhaps it shows just localized disease. So the big question we have is, how do we approach this? Do we do primary surgery or do we do radiation for these patients? Now, I'm a big fan of level 1 evidence, randomized clinical trials, and we don't have any evidence in this setting yet. There is an ongoing study, SPCG 15, which is a prospective study comparing surgery to radiation plus ADT for locally advanced disease. The planned enrollment is 1,200 patients in Scandinavia. The primary outcome is cause-specific survival, numerous secondary endpoints. The study opened up over 10 years ago, and it is still accruing, and it should accrue by the end of 2025. So we will not have results for at least another 5 years. So what do we have out there that already exists? This is a systematic review of treatments for high-risk or locally advanced disease. These authors identified 90 studies comparing various therapies. 30 of them compared surgery to radiation. Now, of these 90, and then of these 30, only one was prospective and observational. There were no randomized clinical trials. 11 reported radiotherapy as monotherapy without ADT, and 4 of the 30 included radiation doses which were less than 70 gray, which is suboptimal. So you can see already the literature here isn't great. 27 of these studies included data on overall disease-specific survival, and in fact, the majority of them showed a benefit for surgery. However, given the poor quality of these studies, the authors conclude, and I think rightfully so, the primary curative treatment modality, neither primary treatment curative modality has been shown superior over the other ones in terms of survival to date. So we don't really have good evidence. Now, what about the one study that compares them? Here you can see this is from MD Anderson from 2004 to 2013, 300 men. 73 were treated with EBRT plus ADT. The other 231 had surgery. And they only included men with high risk and very high risk tumors. You can see the median follow-up is 83 months. And here you can see that really there is no difference in local failure, distant metastatic failure, or overall survival. Although there does appear to be a trend favoring perhaps radiation in local failure, but this is not statistically significant even in multivariable analysis. So in the end, there is no difference. So we talked a little bit about this before, that in fact, we don't have any good evidence to drive decision-making. So how do we decide? Well, let's talk a little bit about each treatment modality and go through the pros and cons of each. The rationale for primary radiotherapy, acknowledging that radiotherapy alone is not going to do the trick, you're either going to need ADT or brachytherapy boost in high-risk disease. The rationale is that it may have equal oncologic efficacy when compared to surgery. It appears that way from the existing studies. It avoids the well-known perioperative risk of surgery. This is particularly relevant in older, sicker patients, although in robotic surgery, we are getting more aggressive in operating in older, sicker patients. The real selling point is it avoids the well-known quality of life side effects of surgery, and it does allow for treatment of pelvic lymph nodes in appropriate cases. Now, if we're going to talk about radiation, one of the questions is, should we be doing hypofractionated or conventional XRT? And the AUA guidelines recommend hypofractionated EBRT due to improved patient convenience, it's a shorter course, and resource utilization. And there are numerous studies that back this up. This is a randomized clinical trial comparing standard IMRT to hypofractionated IMRT. And you can see with almost 10-year median follow-up, there is no difference in any of the outcomes. So clearly, hypofractionated IMRT is safe. But you have to remember, if you're going to do XRT, you have to give hormones. This is the well-known BOLA study from 2009. 970 men with localized disease randomized either to 6 months of GnRH agonist versus 3 years, and it clearly showed a survival benefit to 3 years of GnRH agonist. And you can see the 5-year prostate cancer-specific mortality hazard ratio was 1.71 with a p-value well below 0.01. So in effect, you do need to give at least a longer course of GnRH agonists. Now, what's the right amount of time? Is it 3 years, 2 years, or only 18 months? This is up for debate. Here you can see the Embiid study comparing men randomized either to 18 versus 36 months of ADT. And what you do see here is in overall survival, you see no difference between 18 and 36 months. Disease-specific survival, you do not see a difference, but you do see a difference in biochemical failure favoring the longer course. And in fact, there seems to be a trend towards the disease-free survival, although it's not statistically significant. And this certainly holds up in the multivariable modeling. So in my mind, what this tells me is that in fact, Perhaps a longer course, 2 to 3 years, is better than just 18 months, and I usually put my patients on 2 years of ABT. Now, what happens if they get radiation and it fails? Well, this is problematic. If we look at patients who receive radiotherapy, roughly 22 to 69% will experience a biochemical recurrence, depending on the dose delivered and the receipt of ADT. We have various options for treatment, including observation, hormonal therapy, ablation therapy, reirradiation, or salvage prostatectomy. But you can see here with data from Capture that, in fact, looking over here, the majority of men who have primary external beam radiotherapy end up receiving hormone therapy, and very few get salvage local therapy. And that's not surprising when you stop to think about it, because we do know that salvage prostatectomy is a somewhat morbid procedure. However, if you are able to undergo salvage prostatectomy, the outcomes are pretty good. Here you can see the various studies looking at the efficacy of local salvage therapy following XRT. Surgery, you can see the 2 5-year recurrence-free survival rates and the risk of GU toxicity. Cryotherapy, similar numbers at 2 and 5 years. HIFU, again, similar numbers, maybe a little bit worse in terms of 2-year recurrence-free survival. Stereotactic body radiotherapy, and seed therapy as well. In the end, what we're looking at is reasonably good options, but all of them carry some toxicity. So, radiation works, but if it fails, we don't have many options afterwards, and the ones we do carry toxicity. What about surgery as primary therapy for high-risk disease? Well, I'm a surgeon, I believe in this, and I think there's a good rationale for it. Number one, some observational studies have implied surgery may provide better long-term oncologic efficacy and local control. Surgery allows you to look at the specimen pathologically and allows for better treatment individualization. Follow-up with PSA is quite simple. You just want to have an undetectable PSA. And most importantly, adjuvant or salvage radiotherapy is safe, effective, and easily delivered with minimal side effects after surgery. So I do mention that there are some studies that show an advantage to surgery versus radiation. These are all observational. These are data from the SEER database in the United States. It is a population-based study, observational only. And of course, you cannot control for all confounders, but it is a big study, nearly 15,000 men. You can see that when you look at 5-year cost-specific survival, it favors surgery when we look at the Kaplan-Meier curves. And in fact, when we do the multivariable analysis, this holds up. Surgery is favored over radiation. The issue here really is that you can't control for all the confounding. And so, in fact, short of a randomized clinical trial, I'm a little nervous to say conclusively that surgery is superior to radiation. Although in my heart of hearts, I believe it is, if for no other reason that I am able to provide a good local treatment following surgery in the forms of radiation, whereas men who get radiation often don't get local therapy if they fail. Why do I say that we can give good treatment after surgery? We have 3 very good studies comparing adjuvant versus early salvage radiotherapy, and all show similar findings. This is the Radicals RT trial, and you can see the study population of men with high-risk disease randomized to adjuvant versus early salvage, and you can see there are no differences in 5-year biochemical-free survival and no differences in the initiation of hormone therapy. The GET-ERG-17 study, very similar findings, very similar study design, no difference in 5-year biochemical-free survival. And the RAVES trial from Australia and New Zealand, a non-inferiority study, again shows no difference in 5 to 8-year biochemical-free survival. And when you do a meta-analysis of the 3 studies, it really shows no difference. So it's absolutely safe to give a patient surgery, and if their PSA is undetectable, wait to see if it recurs. And so, in fact, when we look at these studies, probably about half the men in the observation arm, the early salvage arm, never require early salvage therapy. So we are curing probably about half the men with surgery alone, which I think is a great statement. If you're going to perform surgery, what is the role of lymphadenectomy? I think this is an interesting question, and one in which my thinking has evolved over the years. There are different approaches to lymphadenectomy. In the United States, we see a lot of limited lymphadenectomy, as you see here, down to or just past the obturator nerve. We also see a fair number of extended pelvic lymph node dissections, which include nodal tissue down to the internal iliac and perhaps up to the bifurcation. And in Europe, we see the superextended lymph node dissection, which goes all the way up to the bifurcation of the aorta. Now, what's the rationale behind this superextended lymph node dissection? There's a single study from Europe. It's over 10 years old. 74 men with lymph node involvement, risk greater than 10%, but less than 35%. All underwent scintigraphy followed by surgery in the superextended lymph node dissection. 34 of these 74 men were found to have positive lymph nodes. The majority of the positive lymph nodes were found in the internal inguinal region, so they would have been picked up by a standard lymph node dissection. 26 of 34 men would have been correctly staged, and in fact, 10 of the 34 men would have had all positive lymph nodes removed with standard lymph node dissection. The difference between standard and extended is that 32 out of the 34 men, or 6 more men, would have been correctly staged, and 16 more men, or 26 out of 34, would have had all their positive lymph nodes removed. The superextended lymph node dissection allows for 1 more man to be correctly staged and 4 more men to have all of their positive lymph nodes removed. So the argument for the superextended lymph node dissection is, in fact, you are getting more men cancer-free, quote unquote, by removing all their positive lymph nodes. However, there's a risk to this. If you look at these more aggressive pelvic lymph node dissections, there are 3 clinical trials that show that the more aggressive lymph node dissection is associated with more complications. The first study looked at 226 men who had limited versus extended lymph node dissection, and the extended lymph node dissection was not surprisingly associated with increases in operative time, intraoperative complications, bleeding, and hospital stay. Another study of 234 men with high-risk disease, same design, and again, longer operative time, more lymphoceles. And in a very unique study, which men had a limited node dissection on one side and extended on the other, it was clear that on the side of the extended lymph node dissection, there were more lymphoceles and, in fact, more lower extremity edema. So there is a downside to performing a super extended and perhaps even an extended lymph node dissection. To me, the real question is, am I changing the outcomes? You're going to find positive lymph nodes, and that's nice. You'll know whether or not these men need to be treated, but does it affect an outcome? And when you do a systematic review of the literature, and admittedly this is 10 years old, you find that, in fact, it probably doesn't. This is, again, from Europe, 66 studies of lymph node dissection. Over 250,000 men were included. Overall quality of studies was deemed to be low. 61 were retrospective. But the authors concluded when considering oncologic outcomes, there was no good quality evidence that any form of pelvic lymph node dissection improves outcomes compared to no pelvic lymph node dissection. And so in my mind, I was getting away from performing lymph node dissections. My reasoning originally was, look, if I do it, it provides better risk stratification for adjuvant therapy, and it may improve prognosis in some men. We know from the Messing study that early hormonal therapy improves survival. And in fact, 1 in 5 men in the Messing study never, in the observation arm, never required hormones. And in fact, Abdullah and colleagues was able to identify certain groups of N1 patients who benefited from adjuvant radiotherapy combined with adjuvant ADT. And that was my thinking until very recently. This is a study from Memorial Sloan Kettering, really the best randomized clinical trial in this population from Karim Toujours. 1,432 men with localized disease randomized to limited versus extended lymph node dissection at a single institution, 5-year follow-up. There were no differences in biochemical free survival noted. But they also looked at metastatic events, and there were 123 metastatic events noted during the study. And when you look at this and you look at the risk of a metastatic event, in red is the limited node dissection, in blue is the extended lymph node dissection, and in fact, this is statistically significant, and it holds up in a multivariable analysis. That in fact, an extended lymph node dissection in node-positive disease prevents against metastatic disease. And so to me, this is an argument that perhaps we do need to do a pelvic lymph node dissection, and that in some men, we may actually get cures. Who are those men? Well, this is the same question as who needs long-term ADT? This is another study from Karim Toujours, looking at 369 men who had surgery at Memorial from 88 to 2010, who had positive lymph nodes on pathology and did not receive adjuvant ADT. And 40 of these men ultimately did following surgery, and they were censored at the time of ADT. The median pre-op PSA was 8, the number of nodes revolved was 15, and you can see the median follow-up. And here you can see the outcomes. 5-year overall survival is 91%, 10-year overall survival is 60%, so the operation is a good operation. Cost-specific survival is equally very good, 94 and 72%. When we look at metastatic free survival, again, good outcomes, 79 and 65%. Biochemical free survival, a little bit worse, not surprisingly. But the real question is, which patients benefited from the lymph node dissection? And the answer is here. If you count the number of lymph nodes involved, and you look at 1 versus 2 versus 3 or more, you can see that if you have 3 or more lymph nodes involved, you're at a much greater risk on multivariable analysis for a biochemical recurrence and a distant metastases. So in men with low volume disease, 1 or 2 lymph nodes involved, we may actually be getting cures. And so I do think there's a role for lymphadenectomy in these patients. What's coming down the pipe? Well, in the future, we're going to see neoadjuvant therapy in these high-risk patients. There are ongoing studies looking at this, Arneo, looking at dagarelix and apalutamide versus dagarelix alone. Another study looking at APA, Abi, Pred, and Lupron versus Abi, Pred, and Lupron alone. Neoadjuvant chemohormonal therapy versus neoadjuvant hormonal therapy alone. And Proteus, apalutamide and ADT versus ADT alone. These are all going to report out in the next 5 years, and I think they may be positive. So this may be an important additional tool in our war chest to fight high-risk prostate cancer. And so to wrap up, we're going to be doing multimodal therapy in these patients in all likelihood. What's the recommendation? What do you start with? Do you do primary radical prostatectomy and pelvic lymph node dissection followed by hormones as needed or radiation as needed? Or do you start with radiation and then go, an ABT and go from there? Well, the argument for radical prostatectomy is that it may provide better cancer control and cure rates. It provides more accurate staging and grading. PSA follow-up is simple. You may be able to avoid hormonal therapy, and we know that adjuvant or salvage radiotherapy is effective and safe as needed. On the other hand, external beam radiotherapy and ABT, it may work just as well as surgery. It avoids the perioperative risk of surgery and avoids the long-term quality effect of surgery, and it does allow treatment of occult nodal disease. In the end, we have to engage in shared decision with our patients and do what's best for them. And hopefully this talk will help you in that discussion. I want to thank you so much for your attention. I really appreciate the invitation to speak, and I wish you the best for your meeting.
Thank you very much for this very comprehensive treatment of locally advanced prostate cancer or high-risk prostate cancer. I think he touched what we like to know from either to do primary surgery, the extent of lymphadenectomy, the need for hormonal therapy in addition to radiotherapy, the deferred treatment or early treatment, the new medications, etc. I think this is a quite good elaborative lecture. And of course, as I have said that all these lectures are fixed in the archived material of the Association of Urology in our society. And anyone who likes to have a review of such literature, I think lectures, it is a very good amount of knowledge in this subject. Basically, of course, still the gold standard is radical prostatectomy with limited lymphadenectomy for staging and careful diagnosis. And we can stop on this limit if things are good. If we need more therapy, we still have the adjuvant radiotherapy in addition, plus or minus to hormonal therapy. Still the window is open for clinical trials in highly active disease or in locally advanced disease or in disease recurrences. Of course, for the time we have to move to the last lecture. I think we have all the urologists experience with effect of irradiation in our field. Some people like to refer the patient to radiotherapy. Some have bad experience from the secondary effects and complications of radiotherapy. But I promise that on the last 10 years, the technology of radiotherapy has been advanced. The machines has been renewed and they became very well civilized. The techniques they use has improved a lot. So we have to revisit our idea again about the use of radiotherapy. Dr. Ahmed Al will present the next speaker.
Okay, our next speaker, our last speaker is going to be Dr. Jasperi Sanju. He's going to talk to us about urinary adverse events after prostate radiotherapy.
Hello, it is a pleasure to be with you today, and it is my distinct pleasure to give a talk on urinary adverse events after prostate radiotherapy. My name is Jasprit Sandhu. I direct the Functional and Reconstructive Urology Service at Memorial Sloan Kettering Cancer Center in New York, and therefore we see a lot of urinary adverse events after prostate radiotherapy. I have no conflicts. And as an outline, what I thought we'd talk about initially is the natural history of urinary function recovery after radiotherapy for prostate cancer, and then talk about the adverse events. So avoiding dysfunction after primary radiotherapy, its etiology, its management, medical and surgical, and complications of, and finally late effects, which is an area of interest of mine, specifically urinary toxicities, urinary fistulae, and something that we are recognizing much more often now that radiation therapy has been in full force for the past 30 years is secondary malignancies. So natural history of urinary function recovery has been well documented for years. This is a publication in the New England Journal by Dr. Sanda and Wei, where they looked at quality of life and satisfaction among prostate cancer survivors, and specifically looked at patients who underwent radical prostatectomy and compared them to patients who underwent external beam radiotherapy and brachytherapy. And what they found is these patients act distinctly differently. So prostatectomy, as most of you know, you have urinary incontinence, immediately worse, and then stabilizes at some point. With radiotherapy, which is external beam radiotherapy, there is very little in the way of incontinence. In fact, it stays the same. Brachytherapy is slightly worse, but what's more important is the irritative and obstructive score gets worse immediately after radiotherapy and immediately after brachytherapy, and in some patients continues forever. That's persistent urinary incontinence and obstruction. I'm sorry, urinary irritation and obstruction. Now, this has been looked at longer term. Dr. Penson, who you all know, followed these patients for a longer course of time, the PCOS study, and what they found is there was no significant difference in patients who underwent radiation and prostatectomy in overall urinary function. Now, it doesn't mean there's not a difference between specific elements of the urinary function, which is where we come in. So we deal with patients who have specific urinary risk factors or adverse events. Now, what leads to adverse events? This has also been looked at for years. So what most people, and this is mainly from the radiation oncology literature, what most radiation oncologists think leads to worsening urinary outcomes after radiation therapy is fairly well known. Prostate volume and AUA symptom score, or the IPSS, are well known to predict worse urinary toxicity. So the higher the prostate volume, the higher the symptom score, the worse your urinary outcomes. Post-void residual, peak flow rate, and other objective measures also lead to worsening outcomes. So now multiple preoperative factors are implicated in urinary morbidity, including an IPSS greater than 8, a post-void residual greater than 100, a peak flow rate less than 10 milliliters per second, a prostate volume used to be 40 milliliters. Nowadays, most people think it's 60 milliliters or more. And objective measures, bladder outlet obstruction on urodynamics. Now, intraoperative techniques have certainly changed this. So by intraoperative, I mean radiation therapy techniques. The dose, the image guidance, et cetera, has changed the degree of urinary adverse events, but they're still present, and we see the patients who have these adverse events. So what this tells you is somebody who has not undergone radiation therapy, who's at a higher risk for urinary adverse events. And by that, primarily, I mean obstructive adverse urinary events. Objective urinary function after radiotherapy using urodynamics has been looked at by a couple of people. This is probably the nicest study out of Toronto, where they looked at patients pre and post radiation therapy to see what happens to urinary function. And basically what you see is that the capacity decreases, urgency and increases, and there's a hint that compliance probably gets worse. Now, most of these patients after radiation therapy are treated with medical therapy. Now, regardless of whether it's obstruction or storage symptoms, voiding or storage symptoms or obstructive or irritative symptoms, alpha blockers is the mainstay. There is also a role for anticholinergics or beta-3s in patients who have storage element or irritative symptoms. Injection of biological agents, particularly botulinum toxin, may or may not play a role, and there is very little in the way of study for neuromodulation. The tamsulosin is the drug of choice, alpha blocker. The reason it's used so often is it's been studied in a randomized fashion. In this study out of Cleveland Clinic, where they showed that patients on tamsulosin did better than patients on placebo when it comes to improvement in AUA symptom score, which is the same as the IPSS. The other medical agents, including anticholinergics, have also been looked at. This is one of the many studies, but this looked at patients who only had storage symptoms after radiation therapy, so-called brachytherapy related to True's overactivity. And what they found is patients with irritative symptoms, frequency, urgency, and nocturia had marked improvement. And what I'll tell you is patients here who were treated with, in this case, trospium, had a much improved urgency, much improved nocturia, and much improved frequency. This is the area where you can have a marked effect on patients who primarily present with frequency, urgency, and nocturia after radiation therapy. You obviously have to make sure their PVR is low or their post-void residual is low, and then they're in pretty good shape. Now, what's more common is retention. So urinary retention, particularly after brachytherapy, follows a bimodal distribution, usually immediately after implantation. Similar to after radiation therapy, it's usually immediately after implantation. However, there is a group of patients that have delayed presentation. Incidence used to be up to 90%, up to 20%, but since the radiation oncologists have gotten better at delivering radiation, this has decreased fairly dramatically to the point where it's in the single digits now. Prevention, we talked about, you know the risk factors. If you know the risk factors, you can ideally treat patients who are at low risk for this. So decreasing the risk of urinary retention. Now, when you do have urinary retention, in patients without radiation, a TURP is the mainstay. However, in patients who undergo TURP after radiation, there are specific risk factors which you should be aware of, specific outcomes which you should be aware of. Specifically, stress urinary incontinence, which can be as high as 70%. Nowadays, that was the first study ever done, 10 patients, 7 out of 10 had stress urinary incontinence. It's decreased now to probably closer to 20%, and that's because we select patients properly. And the other thing is we're careful about where we resect. The devastating complication after post-radiation TURP is a fistula. A posterior fistula is caused by posterior resection, and anterior pubic fistula is caused by anterior resection. So we've changed our technique and we focus more laterally. So that prevents rectal and pubic complication. Most patients have a pretty dramatic improvement. But incontinence is certainly something you should be aware of. Now, this is a study out of Mount Sinai by one of my colleagues, Marissa Kohlmeyer, is a radiation oncologist, where they look at 38 patients who were treated with TURP for retention or obstructive symptoms. Roughly 20% of these patients were incontinent afterwards. We looked at our series. We had about 111 patients. We had 27% who had new onset urinary incontinence. But the key thing to note is if you select these patients properly, they may actually get better because 43% had resolution of incontinence. So these are patients likely with obstruction, urinary retention, and overflow incontinence. So it's important to know that this is an option, but be careful in who you offer it to. Now, late urinary toxicity is something that we don't understand very well, but it's something we are very interested in. I'll talk about that in a second. And then we'll talk about urinary fistulae after radiation and secondary malignancies. So I had a patient who came in a few months ago now, 68-year-old man, radiation therapy 18 months ago, mild LUTS immediately, was resolved. However, he's at sudden onset of pain and dysuria. His IPSS is 16, his quality of life score is 5. urine culture is negative, you started on tamsulosin, what you would do for patients who have symptoms, but no resolution. This is what his typical presentation, this is not his, this is a typical presentation of IPSS. Patients have a little spike, do well, and then have sudden worsening, usually associated with pain and dysuria. Now, this patient had been given steroids, physical exam obviously revealed no tenderness, urine studies when I saw him was still negative. So we treated him with 6 weeks of antibiotics. He was seen as telehealth later, and his symptoms are now gone. This is his IPSS, 4/0. So there may be a role for prolonged antibiotics in patients that we treat for presumed prostatitis. This is something that we have very little data for, but it's currently being studied. Now, infection beyond prostatitis, including prostatitis, can occur anytime. Often it's diagnosed with a tender prostate on rectal exam, but in radiation therapy, this is often not the case because prostate is non-tender and there's no growth on antibiotics. So these are the patients we treat with a long course of antibiotics. There's no resolution, we introduce a suprapubic tube, and if there's still no resolution, we get imaging. And imaging can show something like this. This is a prostate abscess. Now, the problem with prostate abscesses in radiated patients is you want to treat them very, very carefully because the classic teaching is to unroof them via a TURP. But in radiation therapy, there may be a role for transperineal or transrectal aspiration because endoscopic manipulation of radiated tissue can lead to fistulae. So rectal fissulas are associated with colonoscopic or cystoscopic intervention, including a TURP. Pubovesical fistulas are associated with anterior PURPs. So this is what happens when you have a rectourethral fistula. This is my friend Dan Elliott at Mayo Clinic, 45 patients who had a rectourethral fistula, out of which 29 were radiated. Now, out of those 29, only 6 underwent definitive repair, and out of those 6, only 1 was successful. So 20% success rate in patients who have radiation-related rectourethral fistula, meaning they live with colostomies and uroscopies. So it's a nightmare, and patients are taught this. We're very careful in changing our technique. This is another thing that can happen. This is one of my patients that had urine going through the pubic symphysis. That's a pubovesical fistula. We reported on this now 15 years ago, or 13 years ago. 12 patients all had radiation therapy and all had post-radiation therapy endoscopic manipulation. 10 out of 12 of these, the other 2 were waiting, underwent a cystectomy and diversion. So it's a nightmare. This is the first recognition. Subsequently, others have seen it. But pubovesical fistula are likely due to aggressive endoscopic treatment of obstruction. So these patients present with suprapubic pain and osteitis, often with urinary tract infection, and almost always after radiation therapy. Most of these men have had conservative measures, including antibiotics, percutaneous nephrostomies, hyperbaric oxygen, but the only definitive treatment is cystectomy and diversion. This has been shown by other groups. This is Drew Peterson. He published this about 2 years after us. Again, 7 out of 8 underwent cystectomy diversion. Again, Wade Bushman's group, a couple of years after that, all patients underwent pubic bone debridement and cystectomy. Now, cystectomy in these patients is also something to be careful of because we have looked at cystectomy at our series, and we have noted about a 65% complication rate. This is non-radiated patients. Other organ side involvement or radiation drives this rate higher. So I tell everybody there's a nearly 100% complication rate in these cases. So it might prolong hospitalization, but usually can be dealt with in the hospital. Secondary malignancies, finally, an area of interest of ours, is prostate radiation associated secondary malignancies. The classic ones are sarcoma, bladder cancer, and rectal cancer. Bladder cancer and rectal cancer were looked at really nicely by the group out of Miami about 15, 16 years ago, where they showed that there was an increased risk of bladder cancer with radiation therapy compared to those men who had undergone radical prostatectomy. So it's important to note that radiation therapy might lead to an increased risk of secondary bladder cancer. Now, what happens when you get bladder cancer after radiation therapy? These patients do worse than patients who have not had radiation therapy. We looked at our series of patients who underwent radiation therapy for prostate cancer and was subsequently diagnosed with bladder cancer. So potentially a secondary malignancy, not necessarily, but what we saw is that the irradiated patients did worse than the non-radiated patients. So it's important to note that when you get a secondary malignancy, these patients may not do as well. So secondary malignancies, the risk increases 5 to 6 years after radiation delivery. It's important to note that hematuria and prostate cancer patients treated with radiation should not be discounted. You should treat these patients as anybody else. And patients should be treated as if they have a new primary because it's usually a high-grade disease. So in summary, there's diverse etiologies for voiding dysfunction after prostate radiation therapy, and it's important to know the natural history of recovery of urinary function. And the management varies by time from radiation therapy. So initial management is almost always medical. Alpha blockers, with or without anticholinergics or beta-3s. Surgical intervention, particularly for obstruction in selected patients and fistulae, but never forget about the late effects. And I thank you for your attention.
Thank you very much. Actually, before I move the mic to Professor Abu Al-Anin to wrap up the session, I'd like to emphasize on what Dr. Karim have said in his talk. If the place is very well equipped, and if the team is familiar with the intervention and the treating physician is well trained for such intervention, and if the disease is amenable to such intervention, and if the technique and if the all the infrastructure are present, so you go ahead and do your intervention. If not, think twice before you apply your intervention. This is actually can be applied to any disease in urology and probably in medicine overall. So now, Dr. Hassan, please just wrap up the session.
Thank you, Dr. Ahmed. And I would like to summarize what has been learned for today morning session. It is combined session between Egyptian Association of Urology and the American Association of Urology. It was a very nice and well delivered sections and very hot topics. All of us are seeing it in everyday practice. The first lecture was given by Dr. Joe Karam. It was an extensive review about the management of renal tumors, especially if there is some critical points of treatment of recurrences. Of course, we know that the rate of local recurrence after radical or partial nephrectomy is around 3 to 5%. And usually with meticulous follow-up, you can catch it early. And of course, he touched ways of treatment of such a disease if there is a recurrence. And he said, we can use surgery, we can use ablative surgery by cryosurgery, we can be guided by biopsy. And palliative radiation therapy has been tried as well, but it seems from his talk that the radiation effect is not very promising in the kidney cancer. Anyway, I think with the lowest recurrence of this disease, because now 95% of renal tumor cases come with small size, secondary to liberal utilization of ultrasound. And we can call it now the internist tumor, because usually those patients are referred to us on incidental discovery during renal pain, during flank pain, or some GIT problems. I think when routine ultrasound will give us the diagnosis, and then we can manage. And the vast majority of cases now are treated by partial nephrectomy, even if it is located deep in the kidney. And the liberal indication is getting wider and wider with time. Of course, after tumor recurrence, unless it is easy to do it by open surgery, we can refer them to cryosurgery according to the situation. The second topic was given by Dr. David Benson. I think it was a nice way of treatment of high-risk disease of prostate cancer. And he said that nowadays he addressed a couple of slides showing that promising results of using irradiation with hormonal therapy if compared to radical surgery, and secondary to the improvement of the technology of irradiation, especially on those patients who have a high risk for open surgery. I think now there is a very big competition between this treatment and the radical prostatectomy, especially in the era of widespread techniques of robotic approaches, and now robots are distributed everywhere now, and even in the small hospitals, I think. But still, the radical surgery with lymphadenectomy is the gold standard of that. Alternatively, the hormonal and radiotherapy can work and may achieve as good results as radical surgery. The issue of lymphadenectomy, to do it or not, and now the consensus now is to do a limited or standard lymphadenectomy, and the vast majority of positive nodes are located in the obturator area, on he call it in deep inguinal area. I don't know what is a deep inguinal area is there, but anyway, extended lymphadenectomy did not add much to the higher survival rate, but it gives impression of still you have a second weapon after radical surgery is radiotherapy, as well as in the hormonal treatment. The third lecture was about sling failure, and of course, as we addressed, it is better to avoid the failure and refer the treatment of stress incontinence to the highly specialized colleagues of this field, because it is not an sporadic surgeon urologist job. If you don't do it routinely or frequently, I think the results will be a little bit, you will pass through a longitudinal learning curve with, of course, lower results than the expert to do it. I think he addressed the reasons of the failure, and nowadays he said that we can retighten the sling to be sure that there is a new technology also to have a small calibration machine that can rotate it according to the situation, if the patient is still complaining of the failure or not. Of course, he addressed also, if you use a perch suspension, it is not working anymore after recurrent cases. It is good for fresh cases, and although it is an old technique, but it is associated with higher, and to avoid the synthetic mesh and its complications. This last speaker was Dr. Sando from States also. He gave us his impression about radiation side effects of urology. Of course, we are all suffering from when the radiotherapy is finished. The patient is still complaining of lower urinary tract symptoms, and he cannot go again to radiotherapist because he said, go to your urologist. And then you will receive the patient suffering from significant symptoms of LUTS, and we don't know what to do. You try to give a symptomatic treatment like alpha blockers, like anticholinergics, but sometimes the extreme complication is may go to contracted bladder, bilateral reflux. Of course, this is not bladder anymore after this radiation therapy. The second issue, when you are deciding to make reduction of the outflow resistance by TUR, take care of the radiation tissue. The irradiated tissue is very weak, is very thinned out, and you can easily perforate. And he said to have an anterior TUR much better, and it is a sort of tunneling, and not to be keen to go to the capsule, otherwise you will find yourself into the rectum. Of course, the rectal fistula after irradiation, urinary rectal fistula is a very silly disease, and it may be demanding in its treatment, of course, and many patients are living with suprapubic tube or even diversion techniques by ileal conduit, rather than they have a terrible complication afterward. I think we can reach the conclusion of this was a nice session addressing very hot topics, and we have learned a lot from that. Now it is the time of coffee break, and come back after half an hour. The coming session is very, very hot, the talent in urology, or urology got talent. This is a new program in this year that we have to invite the young colleagues to address their researches, and there is a judge to make a competition between which one of those presenting will win at the end. I think we have to enjoy our coffee and come back after half an hour. Thank you.
Good afternoon, ladies and gentlemen. We are about to start the next session, which is the Urologist Got Talent session. It's a new sort of sessions this year, and it's a competition of research session for younger urologists. And we think that we don't say young, and not all they are less than 40 years old. So we are waiting to have them all gathered because we are still for the time. If we have all of the speakers ready, we can start. Do we have everyone here of the speakers? How many speakers are there? 1, 2, 3. So we can start one by one, and because it is scheduled at 12 noon, but we can start now even better to have more time. So this is a very important session, and we will hear the competitors. What we do that we looked at the abstracts and we judged their presentations. We have another set of judges who marked their records, and today we will only give another score for the presentation, and we'll take the sum and the average of all the scores. The first three will have the opportunity to get very good awards, and that will be given in the gala dinner on Thursday, inshallah. So we will announce it at the end of the session, the winners, inshallah, and we will start with whoever is here. Is Dr. Muhammad Mitwalli here? No, so we go to the second presenter, Mahmoud Al-Fiqi. طب أنا مش عارف. Duai is here. Let's start with Duai. خد قدم.
Dr. Loai Abbas from Theodore Bilhar's Institute will present traditional HOLIP for treatment of benign prostatic hyperplasia, 1-year outcome of a randomized controlled trial.
صباح الخير جميعا. بتشرف طبعا بوجودي بس بتشرف بوجودي طبعا في المؤتمر السنوي لجمعيه المسالك البوليه، وطبعا بتشرف بوجود اساتذتنا التشير بيرسونز. المايك حاضر. هبتدي سريعا كده عشان بس ما اطولش عن ميعاد السيشن. As we all know, holmium laser enucleation of the prostate has been widely recognized as a minimally invasive treatment for BPH. It's known as a size-independent gold standard for management of large prostates, and even can be done in medium to small size if needed. It has the similar outcomes to TURP and open prostatectomy with a shorter hospital stay and lower morbidity rate and long-term durability. HOLIP has not gained widespread popularity between urologists due to its steep learning curve, but with significant advancements in surgical techniques have been made to achieve better outcomes. Traditional HOLIP has been modified to simplify the procedure and make it more reproducible, and as well to shorten the procedure and to try to lower the stress incontinence or the transient stress incontinence post-operatively. The modifications have been done just to difference in the anatomical direction and to understand that the relation between the adenoma and the external urethral sphincter. York et al. Was the first one to talk about the top-down technique. The aim was to shorten the operative time and to shorten the operative time and the learning curve as well. Another benefit of the top-down, which is our hypothesis, is to lower the overstretching of the adenoma on the sphincter, so we can reduce the transient stress incontinence. The primary difference between the traditional and the top-down is the direction of the dissection. Is it posterior, anteroposterior? Recently, it's gaining more popularity between urologists and different centers. And the evidence between that the enucleation is driven mainly by the completeness of the adenoma regardless of the energy source used. It can be done with a different energy source. We can use the holmium laser, green light, monopolar, bipolar, diode, or thulium YAG or thulium fiber laser. Whatever energy source we have, we can do enucleation. And we have to remember that enucleation is enucleation regardless of the energy source. Peter Gilling in 1998 was the first one to talk about the three-lobe technique, and it has been modified by Dr. Lingman in 2008 to the two-lobe technique, so we can put the median lobe with one of the lateral lobes. And recently there is the top-down, the horseshoe incision, omega sign and block technique, and no-touch technique, and the most advanced modification was the early apical release. As you all know, the holmium laser is the most famous one to be used. It has a high peak power with a very small penetration depth. The development of the pulse modulation have made the surgery faster and has better hemostasis. And here we can see the difference between the short pulse and the long pulse, and the pulse modulation has the double bubble effect, which gives us a faster and better hemostasis. This is the pulse modulation during the Moses technology. You can see you can just enucleate even without touching the adenoma with very good visibility. I'll just move to the other slide. So our aim is to determine whether the top-down has a faster enucleation time and to compare with the traditional technique regarding the functional outcomes. Our primary objective was the operative time. The secondary objectives was the functional outcomes and the transient stress incontinence. Between 2019, December 2019 to January 2022, 100 patients were recruited, and the inclusion criteria was patients more than 50 years, secondary to BPH, IPSS more than 15, with a quality of life more than 3, Qmax less than 15 milliliter per second, and a prostate more than 80 grams. The exclusion criteria was previously treatment of BPH, a history of prostate cancer or urethral stenosis, active UTI, prostate less than 80 grams. Patient demographics were recorded, including medical history, physical examination, the use of anticoagulation or antiplatelets, indication for surgery, and the most known the questionnaires. Transrectal ultrasound was done to measure the prostate. Our operative parameters of the enucleation time or sedation time, total surgical time, resected weight, and the enucleation efficiency and total energy used. Most of the patients were done under general anesthetic to shorten the hospital stay, unless contraindicated. In both techniques, we do a posterior groove incision. If it's a bilobar prostate, to do a 6 o'clock incision. If it's 3-lobe prostate, to do either a 5 or 7 o'clock. And the top down, we do an anterior commissure incision at 12 o'clock using settings 2 joules and 20 hertz to separate the adenoma, and then we start enucleation from anteroposteriorly. We use the Stores 28 French continuous flow resectoscope, oscillator from Karl Stores.
1 minute, have 1 minute, try to go faster.
So, okay. This is the main difference between the traditional and the top-down. As you can see on the left side, this is the traditional technique. We go from bottom top. This is the right adenoma. We are approaching the 12 o'clock incision. The 12 o'clock, as you can see, we're crossing the other side. This is what we usually do in the traditional technique. And here we reach the bladder at 12 o'clock, and then we start to dissect the bladder neck. And the top down, we start by doing this posterior groove incision, followed by 12 o'clock incision to separate both adenomas. And we start dissecting the prostate from above as if we're doing an open prostatectomy, which makes it easier to find the mucosal strip or the last attachment between the adenoma and the capsule.
Right, to conclude, Dr. Laya, just the research, no need for the videos, and just to conclude the result and the conclusion.
The conclusion that we compared both techniques, there was no statistically significant difference regarding the operative time or the stress incontinence actually. The only difference that we found, that we did not study this in our the comparative study did not include the learning curve, but we did another study related to this one, and we compared the learning curve between the top down and the traditional, and it found that it's faster to learn and it's easier to find the enucleation plane, and it's easier to be reproduced to other colleagues. There was no difference in the functional outcomes between both techniques, or there was no difference in the intraoperative or postoperative complications. Thank you.
Thank you very much.
Dr. Lai, thank you very much for the good presentation. I advise the presenters to exactly stick to the time. We have 12 presentations. To run this session properly, every speaker has to stick properly to the time. And one of the evaluation items is sticking to the time. This is more important than the presentation itself. You have to respect the time to have a good score. Thank you very much. The next speaker, Dr. Muhammad Al-Fiqi is here. Okay. The next speaker is Dr. Muhammad Al-Fiqi from MUST University, Egypt. He is going to present a paper entitled Comparing Surgical Techniques, THOLIB and the Transurethral BPEP for prostate over than 80 grams, intraoperative and postoperative results, a prospective randomized trial. Dr. Al-Fiqi, please.
Good afternoon, doctors. I'm Mahmoud Al-Fiqi, Assistant Lecturer of Urology at Must University. Today I'm going to present my study comparing thulium inoculation of the prostate versus bipolar plasma inoculation of the prostate, comparing surgical techniques for prostate over 80 grams. The study was published in the Arab Journal of Urology, and this is the link if you want to check it. These are the authors. And basically we will go through introduction, objectives, methodology, results, and discussion, and then we will conclude. QRB is the standard surgical option for BBH. Nevertheless, in cases involving enlarged prostates, QRB remains associated with significant adverse effects such as bleeding and TUR syndrome. Recent advancements in energy technology has given rise to several innovative techniques, which laser technique, and also the enucleation techniques. So thulium laser enucleation and the bipolar plasma enucleation are newer transurethral enucleation options. The goal is to evaluate safety and efficacy in prostates over 80 grams. This is the shortcuts for bipolar plasma kinetic enucleation and the thulium laser enucleation. Both aim to reduce LUTs, improve Qmax, post-voiding residual, and the quality of life. Well, we may know that thulium enucleation offer better hemostasis and visibility, but this was what was one of the key roles that I chose this comparative study to begin with, that we have very scarce studies that comparing the thulium versus the bipolar enucleation. Most of the studies are comparing thulium versus holmium, but I found very limited studies that compare the thulium versus the bipolar enucleation, especially in large prostates. The studies that I found was general prostates, not large prostates. So the objective was to compare perioperative and postoperative outcomes of thulium enucleation versus bipolar plasma enucleation, including the total enucleation time and the complications and the functional outcomes like IPSS, Qmax, post-voiding residual, and the erectile function score. It's a prospective randomized study, started at January 2022, concluded at July 2023. 108 patients with prostates over 80 grams were included, divided into two groups. Group A representing the bipolar enucleation, and Group B the thulium enucleation. The preoperative evaluation included history taking, clinical examination, and also images and labs like PSA, IPSS, erectile function, Qmax, post-voiding, and ultrasound truss. And we excluded patients with cancer, stones, neurogenic bladder, anticoagulants, urethral stricture, or any previous prostate or urethral surgery that may interfere with the results. In the bipolar arm, Group A, we used the Hermann-Weber enucleation electrode. We generalized the setting, 160 watt for cutting and 80 for coagulation. And for the thulium, we used 60 for cutting and 40 for coagulation. Same enucleation technique in both arms, 2 or 3 loops technique with 26 French continuous resectoscope. These are the tables of the preoperative and the perioperative data. As we can see, there is no significant difference. The only significant difference that we found is in the total operation time. Thulium was significantly lower than bipolar. This was the only significance between both arms. As I said, the enucleation time of the group A was 75 minutes and group B was 67, and adding the morcellation time, the total operative time becomes 117 and versus 90. So as I said, thulium is significantly lower in duration. These are the complications, nothing major, no significance between both groups. Only one patient had bladder neck contracture that we did later on, bladder neck incision after a month. Catheter time was shorter, hospital stay, and the hemoglobin drop was lower. All was lower in group B. No major differences in complications. And these are the functional outcomes at 1, 3, 6, and 12 months. As you can see, there is no significance between both, and both had the same equal functional outcomes at 1 year. This is what I said, that regarding the IPSS, Qmax, and everything was the same. Both groups showed a significant improvement. No statistically significant difference between both groups. So as we said, thulium enucleation advantages due to better hemostasis and visibility. That is shown in the total operation time. But bipolar enucleation still effective, cost effective, and size independent, and the learning curve easier than HOLEP for both techniques. The conclusion. Thulium enucleation of the process shows better perioperative outcomes, as we said, but the functional outcomes of both groups regarding the thulium or the bipolar are identical between groups. Both techniques are safe and effective. Bipolar enucleation of the prostate, while not as widely studied, as I said in my first presentation, laser-based, not widely studied as laser-based enucleations, it offers a practical alternative, especially in settings with limited laser resources. Not all the people have laser in their hospitals, and it offers good balance of safety, efficacy, and cost. And larger studies are recommended. Thank you.
Thank you very much, Dr. Al-Fiqi. I want to commend you for your sticking exactly to the time. This is excellent. Thank you very much.
Thank you.
We call the next speaker, Mohammed Mutwalli is here. Yes, please. To sheath or not to sheath in flexible ureteroscopy, a randomized controlled study from Suez University.
Assalamu alaikum. Thank you for accepting our work in this great competition. Our paper is to sheath or not to sheath in flexible ureteroscopy, a randomized controlled trial. Flexible ureteroscopy is now the preferred treatment option for renal stones. Urethral access sheath facilitates multiple passages, improves irrigation during flexible ureteroscopy. Conflicting data on urethral access sheath impact on the complication are in the literature. Our study objectives was to assess the effectiveness and the safety of urethral access sheath in flexible ureteroscopy procedure as regards stone-free rate, operative time, and complication. Study design was a randomized controlled trial, took place between April 2023 and January 2024 in Ain Shams University Hospital. Total patients was 120 patients. The debate was to use the urethral access sheath in flexible ureteroscopy. The pros was easy urethral access, improved visualization, reduced intrarenal pressure, and preservation of the flexible scope. Against that was the urethral injuries, comparable success rate without the urethral access sheath, and conflicting evidence as regarding the stone-free rates. Our patient allocation, we started with 127 patients. 7 patients were excluded, 3 were pre-stented, and 4 due to UTI. We randomized 120 patients into 2 groups. First group without an access sheath, the second group with an access sheath. Both contained 60 patients. Patient selection, our inclusion criteria was renal and proximal urethral stones, stone size 1 to 2 centimeters, excluded congenital anomalies, pre-stented patients, and active UTIs. We used an 8.6 French digital flexible ureteroscopy with the holmium YAG laser 30 watt. Urethral access sheath size was 10-12 hydrophilic urethral access sheath, and all patients received the 6 French double J stent at the end of the procedure. As regard the patient demographics, there was no statistical significance between both groups. Our age range was 23 to 65. Stone characteristics and hydronephrosis showed no statistical significance. Our primary outcomes were stone-free rates and operative time, which also showed no statistical significant difference. The post-operative complication was the only key finding in our study towards the use of urethral access sheath and had a significant statistical significant difference. Complication details in group A with no urethral access sheath, 15% of patients had fever, 8.3% had sepsis, and the percent decreased significantly in the group of group B using the urethral access sheath. This is how would we explain why urethral access sheath would decrease the infectious complication, as it facilitates continuous irrigation, lowers the intrarenal pressure, and reduces the bacterial translocation. Urethral access sheath is safe and does not compromise stone-free rates, significantly reduces the post-operative infectious complications, no increase in operative time or hospital stay, risk-benefit profile favors the use of urethral access sheath. Our study limitation was the limited sample size. It was a single center study. Patient comorbidities and stone composition were not considered in our analysis. We concluded that flexible ureteroscopy is reliable and efficient for renal calculi with or without urethral access sheath. Urethral access sheath has no impact on stone-free rate or operative time, but it significantly reduces the post-operative infectious complication. Our take-home message is that consider use of urethral access sheath for safer outcome as regard it maintains stone-free rate, 3 times less infectious complication, same operative time. Thank you.
Thank you, Dr. Mohammed, for sticking time. And the next is Mohammed.
Okay. Our next presentation is Dr. Ahmed Maher, Ain Shams University, speaking about inoculation preserving transurethral resection of prostate, which is a randomized controlled trial. Please.
صباح الخير، أنا متشرف إن أنا موجود معاكم النهاردة. تشير بيرسونز، أنا متشكر لوجودي معاكم. أنا هبدأ بس البرزنتيشن على طول عشان بس الوقت. Our talk today is about ejaculation sparing TURP. I'm Ahmed Maher Higazi, lecturer of urology at Shams University. I have no conflict of interest to declare. We used to practice that TURP is associated with inevitable retrograde ejaculation and dry orgasm happen in about 86% of our patients, which is a significant disappointment in our patients. And this led to patients, especially sexually active, may delay surgical decision or choose a less effective ejaculation sparing procedure. Okay, how do we ejaculate? Wilnert et al. Through his study using transrectal ultrasound, ejaculation is 3 phases: is emission, formation of pressure chamber, and expulsion. And the whole idea about this pressure chamber, this is an ultrasound showing the dilated urethra pre-ejaculation, and during ejaculation there is a progressive narrowing of the caudal part of the urethra around the verumentinum, and there is a dilatation around the verumentinum around 5 to 7 millimeters before emission. During the ejaculation phase, there is contraction of the posterior prostatic urethral muscle bundle, which is also known as the ejacularis muscle complex, lead to a caudal shift of the verumentinum, which is the main part of the pressure chamber, which led to the antegrade ejaculation. Even during ejaculation, there is some semen may go back with a patent bladder neck. This is an ultrasound showing ejaculation, and as we can see, there is a caudal shift of the verumentinum, which lead to pressure chamber between the external urethral sphincter and the caudal part of verumentinum. And this endoscopic view, we can see there is a caudal shift of the verumentinum, and this is the chamber with high pressure before emission. So the whole idea is to create a high pressure chamber in the prostatic urethra between two muscles and lead to the antegrade ejaculation. Based on this, many studies try to do an ejaculation sparing procedure. These many authors with different techniques, different success rate, and we have something in common in all surgical techniques. We don't have a consensus about the optimum ejaculation sparing technique, heterogeneous data, inconsistent outcome, and short follow-up. This is our study about ejaculation preserving TURP, published in Journal of Urology. Our aim idea is to spare 1 centimeter of urethral mucosa all around verumentinum, including the prostatic apical urethral mucosa. Inclusion criteria, we have a prostate size of less than 100 grams in sexually active men. Exclusion criteria, patient with neurogenic bladder detrusor, hypocontractility, urethral stricture, prostate cancer, or previous prostatic intervention. Our primary outcome was ejaculation post-operative. Secondary outcome, other voiding parameters, complication, operative time, and continence. This is images from our procedure. We have 106 patients finally evaluated in our study. Our pre-operative data is that we have an age around 58 years old, and prostate size around 76 grams in group A and 80 grams in group B with no statistically significant difference. Post-operative data regarding voiding parameters, there is no statistically significant difference between both groups. However, preserved anti-ejaculation was successful in 83% of our ejaculation sparing technique. Our post-operative complications were similar in both groups, but we noticed that early urine incontinence was better in the ejaculation sparing technique at 1 month. However, at 3 months, there is no statistically significant difference between both groups. This came from the urethral mucosa, which was spared, and too many mucosal folds aided in the coaptation and sealing effect of and the closure pressure of the sphincter, which helped to improve post-operative continence. What's the limitation of our study? It was a single-centered study, small sample size. Prostate size limitation was not a big size of prostate, around 76. Short follow-up duration, so durability is questionable, about 1 or 2 or 5 years follow-up. No standardized questionnaire for ejaculation quality like male sexual health questionnaire for ejaculatory dysfunction. What's next? This is a part 2 RP trial, multicentric trial, which will evaluate the ejaculation sparing after 3 years. This is a multicentric study based on 15 investigators who use the same ejaculation principle as we did, and we try to do an application to join them. This study will be available, its result about next year. It has 3 questions to answer: ejaculation and continence and flow and retreatment after 3 years. This is our second study, currently ongoing in Shams University. Is talking about the factor which will predict the success rate in our study, like prostate size, whole gland and adenoma, presumed circular area ratio, median lobe, intraprostatic protrusion, urethral length, demographic data, and a multivariate regression analysis will be performed to show which risk factor will contribute most to the success and failure of this procedure. To take a home message, ejaculation sparing TURB is not only feasible, it's an important evolution of how we approach a patient-centered outcome. Our technique is anatomically rational, easy to adopt, preserve sexual function while maintaining surgical efficacy. This is a QR code for our study for those who are interested to read about our study, and thank you.
Thank you, Dr. Ahmed, for sticking to the time and the nice presentation. Our next speaker is Dr. Mu'tasim is here. Okay, we shift to the next speaker, Dr. Saeed Aish, Jabir Ahmed Hospital, Kuwait. and rectus fascia slings for male neurogenic stress urinary incontinence, a modified pre-pubic approach. Slides يا جماعة.
Hi, good afternoon, everyone. I'm Saeed Yash, a consultant urologist in functional female and neurourology from Jabal Ahmed Hospital in Kuwait. It's an honor to be with you all today. I'd like to thank the organizing committee headed by Prof. Sharif Murad for the invitation. So today's presentation is about rectus fascial slings for male neurogenic stress urinary incontinence. We're describing and discussing a modified pre-pubic approach. Sorry, yep, all right. So to start with, I have no personal disclosures to declare, but this work represents a collaborative effort with Associate Professor Johan Ghani from the University of Melbourne and Dr. Stuart Whalen from the University of Dalhousie in Nova Scotia, Canada. All patients were operated on at Austin Health in Heidelberg, Victoria, Australia. So management of neurogenic stress urinary incontinence depends on many factors, and it's kind of a challenging issue for urologists, particularly neurourologists. We have a lot of limited options because of the anatomical and functional differences in this patient population. Usually in male patients, particularly who have stress urinary incontinence, we usually go for an artificial urinary sphincter. But in the neurogenic population, because some of these have impaired sensation below the umbilical level, placing an artificial urinary sphincter could be risky, risking infection, erosion, etc. So we usually depend on slinging the bladder neck for these patient populations. So the facial sling for this population particularly offered an alternative to bladder neck closure. It was first described by McGuire and Raz in the 1980s, but they described initially a retropubic approach where they passed the sling arms behind the urethra. It did have a lot of impact on the resolution of the neurogenic stress urinary incontinence for this population through increasing bladder outlet resistance. However, it did come with a significant morbidity profile, including a high rate of urethral injuries and erosions, bladder injuries at around 10% of patients, and even rectal injuries. And the complication rates worsened because of the neurogenicity of these patients. These patients had delayed presentations, they had impaired sensation, so basically these complications would cook over time before they actually present, and they would be very morbid or even more mortifying. So our objective was to describe a modified pre-pubic approach to pass these sling arms of the rectus fascial sling. And we wanted to highlight the outcomes of this modified approach. Our patient selection for urodynamic assessment was through the State of Victoria Spinal Services database. We included male patients who had proven neurogenic stress urinary incontinence. However, they had to be dexterous or trained to perform self-clean intermittent catheterization. Our primary endpoints were perioperative complications using the Clavien-Dindo scoring scale and the resolution of the stress urinary incontinence in the selected patients. Secondary endpoints included patient-reported outcomes through the Patient Global Impression of Improvement Scale and the Michigan Incontinence Symptoms Index. I'm going to share with you a quick video that shows the operative technique. So initially, the marking and the incisions are made just exactly how McGuire and Raz described the harvesting of the rectus fascial sling. So the sling is marked at around 2 centimeters in width and 8 centimeters in length. And during the harvesting, what we do is we pass a 1-0 proline at either end and secure it well with double surgical knots. These threads will act as the sling arms so that they facilitate the passage of the slings during the procedure. We then proceed to marking and creating a perineal incision and dissecting down the urethra to the point of the central tendon, which is then released, and the sling is fixed to the to the ventral aspect of the proximal urethra. So you can see the fixation is we do the fixation in the central aspect of the fascial sling itself. And then the sling arms are passed in the same direction that you would pass the tubing of the artificial urinary sphincter pre-pubically. As you can see here, we're passing a Kelly grasper to hold the sling arms and pull them up towards the suprapubic incision that we created.
1 minute left, please.
So for the sake of time, I'm just going to quickly narrate what happens. So once the sling arms are passed, they are passed twice through the rectus fascia, and then they are tied down securely to a 0 centimeters length above the rectus fascia in the incisional wound in the abdomen. This maintains the tightest sling fixation that could actually guarantee the resolution of stress urinary incontinence. So our results in a nutshell, we followed up the patients for a median of almost 24 months. These numbers represent the preoperative leak point pressure and Michigan Index symptom score. As you see, we only have 3 Clavien 1 complications, which were all seromas, which is expected with these kind of harvests. Patients at 6 weeks
Can we go just straight to the conclusion, please?
So minimal leak at 6 weeks and at the most recent follow-up, both self-reported and on the Michigan Incontinence Symptom Index. So in summary, this offers a great alternative, less morbid approach to inserting the the fascial sling for neurogenic stress urinary incontinence. Of course, we're limited by the number of patients that we enrolled, but this is a very rare population nevertheless, and we're looking forward to reporting a larger cohort for all of you. Thank you very much.
Thank you, Dr. Saeed.
So our next speaker is Dr. Khalid Abdulsattar Gad. Dr. Khalid will present a comparative analysis of the outcomes of resume therapy based on prostate size, a 4-year retrospective analysis.
بسم الله الرحمن الرحيم. أنا في البداية بحب أشكر الجمعية المصرية our study is a comparative analysis of the outcome of rhizome therapy based on prostate size for year retrospective study. First, I would like to express my greatness to Professor Dr. Muhammad Salman al-Rifai, Professor Dr. Muhammad Samir in Shams University, and Dr. Hussam Abd Samia for the valuable assistance and the efforts they devoted in the provision of this study. Contents of our study. Our contents is introduction, aim of work, objective, rhizome therapy, and patient method results, discussion, summary, and conclusion. في مشكلة بس. تمام. Surgical treatments of options for PBH. Transurethral resection of the prostate TRB, monopolar TRB, and bipolar transurethral resection of prostate, and the rhizome therapy. High quality studies investigating its application in large prostate remain limited, and some centers have confined rhizome therapy indications for volumes of 30 to 80 cc. Despite initial promising results, most existing trials provide only short-term follow-up. Our aim of the work was to evaluate the safety and efficacy of rhizome therapy in treatment of patients with both size from 50 to 120 grams, 5 retrospective trial with a 4-year follow-up period. The primary outcome was to determine the efficacy, and the secondary outcome to determine safety. We assess the efficacy of approach using IBSS, quality of life, Qmax, operative time, catheter time, hospital stay, BSA, post-voiding residual, and residual process size, and safety using the incidence and complication. So, Professor Dr. Christopher Cantrell, on late November 2015 at Urology San Antonio, has successfully completed the requirements that made him the first urologist in the nation to become a certified provider of the rhizome. So what is the mechanism of the rhizome therapy? Rhizome system contains a radio frequency power supply generator and single-use transurethral delivery device. It provides a consistent energy dose of 208 calories into the prostate tissue through a retractable 18 gauge needle. The vapor needle total penetration length is fixed at 10.25. Okay. So, what is the difference between convective and conductive thermal ablation? Rhizome represents convective thermal ablation therapy instead of conductive thermal therapy, which is used in transurethral needle ablation of the prostate and transurethral microwave therapy. Because it's only advantage of the rhizome therapy. Rhizome can be administered an alternative to medical treatment therapy, reducing the burden of pharmacotherapy. That's preserve number 2. Rhizome can preserve ejaculatory function, which is sometimes compromised by other surgical procedures, and the high safety profile with few intraoperative complications. Disadvantage of the rhizome: a limited number of randomized controlled trial with a short duration of follow-up. Rhizome shouldn't be used by patients who have artificial urethral sphincter or have received penile implant. Number 3, individuals with past radiation have been excluded from the rhizome trials due to scar tissue, loss of intracellular spaces, and irregular zonal border that may interfere with the rhizome convective heat transmission. Number 4, the lack of tissue diagnosis. Okay, our study was a retrospective study. Sample size 85 patients in each group. This was calculated using G-Power program with an alpha error set at 0.05 regarding to Garden et al. In 2021. The IBSS improved in both small and large prostate groups with percentage changes of 33%. A study period between January 2021 to January 2025 included patient aged 50 to 80 years with prostate volume on 50 and 100 milliliter, and sexual active, have severe LUTs, Qmax below 10 mm per second, and IBS score above 20. who have unresponsive to medical treatment with alpha blockers. Patient known to have prostate cancer and neurogenic bladder urethral restriction and urinary bladder stone or previous prostatic surgery were excluded from our study. Okay, as we said before, resume was implied as in our study.
Go for the result خالد عشان الوقت يعني اتكلم عن الريزلت على طول الوقت مش هيسعفك في التكنيكس.
Okay. The result of our study, table 1 was about preoperative crisis of patient. A total of 170 patients who underwent resume was included in our study. 85 had small prostate below 80 and 85 patients have a large prostate. There was the demographic data were comparable between groups except for prostate size and PSA, both of which were significantly higher in large prostate. The number two was about preoperative data, operative time, hospital stay, and the catheter duration. Operative time and the catheter duration were significantly longer in large prostate, and the hospital stay was similar between groups. Our study was evaluated patients between...
Khaled, shall we rush to conclusion, please?
Okay. Conclusion. Resume therapy is a safe and effective treatment options for PBH across a wide range of prostate size. However, patients with large prostate may experience higher rate of retreatment during long-term follow-up. Further, post-operative and comparative study are warranted to evaluate. Okay.
Thank you, Dr. Khaled. Thank you.
The next presenter is Dr. Ali Ibrahim Ali from Kafr Sheikh University, a paper entitled The Effect of Tadalafil 5 milligram on erection and persistent storage lower urinary tract symptoms after transurethral resection of the prostate, a randomized controlled trial. Dr. Ali, please.
Bismillah ar-Rahman ar-Rahim. My presentation is about the effect of Tadalafil 5 milligram on erection and persistent storage lower urinary tract symptoms after transurethral resection of prostate, a randomized controlled study, which was published in Basic and Clinical Andrology 2025. Introduction. Men with lower urinary tract symptoms due to benign prostatic hyperplasia have a higher incidence of erectile dysfunction. Moreover, lower urinary tract symptoms themselves serve as an independent risk factor for erectile dysfunction, significantly compromising quality of life. The underlying pathophysiological mechanisms linking lower urinary tract symptoms secondary to BPH and erectile dysfunction remain incompletely understood, although both conditions share several common determinants. TURB also may contribute to erectile dysfunction through various mechanisms, primarily due to thermal injury, other factors including psychological impact of the procedure and the temporary decrease of the sexual activity post-operative. Tadalafil 5 milligram once daily is approved for the treatment of lower urinary tract symptoms regardless the presence of coexisting erectile dysfunction. Another study reported that Tadalafil 5 milligram once daily improved lower urinary tract symptoms in men without erectile dysfunction by a magnitude like that observed in men with erectile dysfunction. Methodology. We conducted a double-blind randomized controlled trial to evaluate the effect of early administration of Tadalafil 5 milligram once daily on persistent storage lower urinary tract symptoms and erectile function following TURB. All enrolled patients underwent TURB and were randomly assigned to one of two groups. Group A received tadalafil 5 milligram once daily post-operative, while group B received a placebo. Erectile function was assessed using the International Index of Erectile Function, 5 questions, and lower urinary tract symptoms were evaluated using the International Prostate Symptom Score. The study was conducted at a tertiary care hospital between May 2021 and October 2022. Our results regarding to the baseline data, age and body mass index and medical comorbidities to prostate size, as there is no significant difference between both groups. Regarding the erectile function, the international, both groups show no significant difference in the baseline pre-treatment of the erectile function. But in group A, there is a significant improvement at 1 and 3 and 6 months post tadalafil 5 milligram. In group B, there is a decline at 1 month of the erectile function, which show a slight improvement at 3 and 6 months. And regarding the lower urinary tract symptoms, there is a comparable results in both group in the IBSS score and storage IBSS score, avoiding IBSS score with Qmax and post-voiding residue. Limitation of our study, the sample size was relatively small, and therefore a larger scale study involving a more extensive population is recommended. Additionally, the study didn't compare between the outcome of patients who received tadalafil on demand with those who received tadalafil once daily, 5 milligram, post-operative. Also, further clinical study with longer follow-up periods are necessary to comprehensively assess the long-term effects of tadalafil on erectile dysfunction, erectile function, and irritative symptoms following transurethral resection of the prostate. Conclusion, in comparison to placebo, early tadalafil 5 milligram daily monotherapy after TURB can lead to early improvement in the erectile function. However, its effect on persistent storage lower urinary tract symptoms post-TURB appears to be modest. Thank you.
Thank you very much, Dr. Ali. The next presentation for Dr. Amr Mustafa, comparison of laparoscopic versus robotic-assisted vesicovaginal fistula repair using the versus surgical system, a prospective cohort study on safety and efficacy from Cairo University. Amr is not here. Ahmed Tahir is here. ترتيب موجود. Okay, complex renal stones, which PCNL position can urologists do it for better outcome? Our center experience from Asyut University.
Assalamu alaikum. It's my pleasure to present our work in Asyut University Urology Center to present our technique. The idea was simple. What can urologists do for a better outcome? Can use supine or prone, especially in the complex renal stone. The surgical debate between prone and supine. Prone is the traditional and gold standard. However, it requires physical repositioning of the anesthetized patient and limit airway access during the procedure. In the supine position, which is proposed by Valdivia, it's introduced as the alternative to the traditional position. As a technique, it's game-changing as it offers significant ergonomics and anesthetic benefits. Our methodology was it's a randomized control trial. We select about 178 patients, allocated as 1-to-1, and we choose complex renal stone with Guy's score 2, 3, and 4. In patient demographics, we found that patient body mass index in the supine was significantly. This is a standard prone position. The standard prone position began with the patient placed in lithotomy for ureteric catheterization and then flipped to prone position. We need support on the chest, pelvis for breathing, access via posterior axillary line. Challenges was repositioning risk and airway limits. Here in modified supine position, this is a picture of our work. We don't use any operative repositioning. We put 2 saline bags, 1 liter behind the patient to create 30 inoculation. Simultaneously antegrade and retrograde access. The benefit was ideal for high body mass index and anesthesia safety. In our operative efficacy, we found that supine is superior to prone as it's shorter time in total operative time. Intraoperative access, to our mind, that access to upper calyx or middle calyx was difficult in supine, but in our study we found that upper and middle calyceal puncture easier in supine more than prone. We found it equivocal in the lower calyx. In stone clearance, we found that both techniques are equivocal. In safety profile, there is no comparison on safety between both techniques, each in fever, urinary leak, or blood transfusion, intra or post-operative. So here's the question, why supine? We found 3 privileges for using supine position over the prone technique. In no repositioning, it eliminates the time consumption steps of flipping the patient from lithotomy to prone after catheter placement. Also the physics. Intraoperative, we found that downward slope of the ambulance sheath allowed for spontaneous stone retrieval via gravity and irrigation fluid. Also for the obesity advantage, we found that it's more privileged in supine more than prone. So, clinical implication, in the anesthesia and ergonomics, we found that airway using supine positioning offers superior access for anesthesiologists to manage the airway, crucial for high risk patient. Also in hemodynamics as a better cardiovascular stability compared to the prone position, which can compress the chest and abdomen. Lastly, for the surgeon comfort, it allows the urologist to operate while seated, so it's reducing physical fatigue during long, complex cases. Last, our clinical verdict is that the modified supine BCNL is a safe, high efficient, and ergonomic alternative to the prone position. It significantly reduces operative time and improve access, making it ideal for obese patients and complex cases. Thank you.
Our next speaker is Dr. Koray Jorgenseniti, speaking about simulation models in female pelvic surgery, 3D printed versus cadaveric models for transobturator tape placement. Thank you.
Dear colleagues, dear friends, it's a real pleasure to be here in Cairo today. I would like to thank organizing committee for putting together such a well-structured program. My focus today will be on cutting-edge simulation technologies in female pelvic surgery, emphasize on simulation models in female pelvic surgery, 3D printed versus cadaveric models for TOT placement. Here are my disclosures. I currently serve as a clinical research coordinator for Ethicon and receiving honoraria from Institute Pharma, both of them not directly related to today's topic. When we look at global literature in sealing surgery, major complications appear rare. When we query the FDA mouth database that reports far more major complications. So these tell us complications are either underdiagnosed or underreported. And even though these are US data, I believe we are seeing the same picture globally, and many of these patients ultimately require reconstructive surgery, as you know. And there's a paper that I love, published Journal of Urology, titled, "Is it the surgeon?" I think the author says something striking. Why do they, or we say that? A substantial portion of these complications stem from suboptimal technique at the initial sealing placement, as you know. Sometimes poorly trained technique, wrong angles, wrong endpoints. So what fails us first? Anatomy or skill, psychomotor skill? The answer is, I believe, both. But how do we train them effectively and reproducibly? So this is exactly where simulation models come into play. Early in the learning curve, a surgeon cannot achieve consistent technique without both psychomotor skills and a dynamic understanding of pelvic anatomy. So on the left, you see the 3D model. We produced a realistic model, includes many of key landmarks needed during surgery. On the right, you see an image from our cadaver-based sessions, part of a modern surgical source led by Dr. Huri and Dr. Murad, who bring innovative approach to education. Traditionally, cadaver training fills the gap, but high-fidelity 3D printed models are emerging as a complementary option. So the question was simple: how do these two platforms compare for learning anatomy and technique in TOT placement? The real question was if a printed model can stand beside a cadaver. To our knowledge, this is the first study in urogynecology to directly compare them. For this study, we developed a structured simulation-based education program for both OBGYN and urology surgeons. 15 surgeons trained was delivered on two platforms, fresh frozen cadavers and then a 3D printed pelvic model. We assessed learning across three domains: cognitive, psychomotor skills, interoperative decision making. Each participant performed bilateral TOT insertion following the same standardized instruction before each procedures. This framework, developed, funded by a European Union project, allowed us directly compare how each platform supports different aspects of TOT training. Here we see the first part of result for basic anatomical orientation. Cadaveric still provide a clear spatial relationship, something 3D models cannot fully replicate due to the lack of real tissue depth, real tissue variation. Cadaveric training outperformed the 3D printed model in anatomical landmark identification and in recognizing the genitofemoral fold incision. Here we see the cadaveric training against shows a clear advantage. Surgeons were significantly better at avoiding excessive trauma on cadavers, and difference was more pronounced in managing probable complication. This actually highlights a simple truth. 3D models actually are excellent for standardizing the steps, but real tissue remains superior for teaching judgment, for teaching complication management. Since our time is limited, I will end not with more numbers, but with what this means for now and for the future. Cadaveric models still give us the anatomical fidelity we cannot replace, while 3D printed models offer a reproducible, low-cost way to build consistent psychomotor skills. So actually the question is no longer which one is better. It is how we combine them to ensure real skill to transfer to patient care. And current initiatives actually show that the future of pelvic surgery training will be hybrid. Structured, VR-based, simulation-based education. As a final word, cadaveric models remain the gold standards for teaching real anatomy. Even though they cannot replace them, 3D printed models offer a feasible, a reproducible platform for especially psychomotor skill acquisition. The last photo is from the hands-on surgical course in Istanbul. From Istanbul to Cairo, I sincerely thank my respected Egyptian colleagues for their friendship and for their warm hospitality. Thank you very much.
Thank you, Dr. Kourey. And we have now the second speaker, Dr. Ammar Al-Urabi, Minofia University, the efficacy of pyridostigmine therapy after transurethral resection of the prostate in cases with underactive urinary bladder prospective randomized trial.
ثواني نتكلم النهارده عن the efficacy of pyridostigmine therapy after transurethral resection of prostate in case with underactive bladder prospective randomized trial. The paper was published in the World Journal of Urology. I would like to thank the authors who contributed in this work: Dr. Khalid Zainuddin, Dr. Mohammed Shazli, Dr. Sam Kandil, Dr. Baer Salman, Dr. Mohammed Aziz. For the background, the underactive urinary bladder is a urological condition characterized by a reduction in the strength and the duration of the uterosal contraction, and consequently incomplete bladder emptying with or without prolongation. While the main pathology of underactive bladder is not well understood, one of the main causes of underactive bladder is prolonged bladder outlet obstruction due to prostatic enlargement. To make a diagnosis, it's necessary to perform a pressure flow study, which is, can distinguish between decreased flow rate related to bladder outlet obstruction with or without poor bladder contractility. Parasympathomimic agents have been suggested as a potential therapeutic options for patients with underactive bladder. However, a recent systematic review on the efficacy and safety of these agents for underactive bladder found that the evidence is not is still limited, without a definitive conclusion on their benefit or adverse effects. One of parasympathomimic agents is pyridostigmine, which is commonly used to treat myasthenia gravis, and also has been studied in a limited way for the management of underactive bladder. Patients with underactive bladder after TURB may still experience recurrent attacks of obstructive floods or even retention, highlighting to the need for effective treatment options for this case. Objectives of this study aim to evaluate the effects and adverse effects of pyridostigmine as a treatment for underactive bladder after transurethral resection of the prostate. This prospective, double-blind, multicentric, randomized controlled study was conducted between May 2024 and November 2024. 66 patients were who were eligible for TURB for BPH and have preoperative underactive bladder were included. Any patients with diabetes, neurological disorder, or pelvic surgery were included. Patients were randomized in two groups, pyridostigmine groups, who received pyridostigmine 60 milligram twice daily for 3 months post-operatively, and the control group who received placebo post-operatively for 3 months also. Patients were followed up for 3 months to observe the outcomes. Severity of LUTS by IBSS score and quality of life score, post-void residual volume by ultrasonography, QMAX by flowmetry, and bladder contractility index and the uterosal pressure at QMAX by urodynamic study. The results. 76 patients were enrolled in the study. After exclusion of patients due to procedural complications and patients who lost to follow-up, 34 patients were analyzed for bariatric group and 32 patients were analyzed for the control group. Regarding the demographic data and baseline data, including age, BSA level, prostate size, IBSS score, quality of life, post-void residual, and QMAX contractility index, all patients, there was no significant difference between both groups regarding these baseline data. On follow-up, the subjective outcomes and comparing between them pre-operatively and 1 to 3 months post-operatively, we compared between both groups. First of all, regarding IBSS score, IBSS quality of life, and the post-void residual, both groups showed significant improvement regarding the 3 parameters. Bariatric mean therapy showed significant improvement after 1 month, 2 months, 3 months. For the IBS score quality of life, bariatric mean group showed improvement at 2nd month and 3rd month. And for the post-void residual, there were improvement in the after 1 month, 2 months, and 3 months. Also, for the control group, there was improvement in the IBSS score at 1 month, 2 months, 3 months. The quality of life, there was no improvement, significant improvement. And for the post-void residual, there was a significant improvement. But where we compared between both groups, the bariatric group and control group, the improvement among the bariatric group were significantly better than the control group. Regarding the 3 parameters, IBSS score, IBSS quality of life, and post-void residual volume. When we compare the objective outcomes, compared between pre-operatively and 3 months post-operatively, first of all, the QMAX, there was significant improvement in the QMAX among the bariatric group and the control group. But when we compared between both groups, the improvement among the bariatric group was significantly different. The same for the pressure detrusal and the same for the contractility index. For the incidence of retention post-operatively, 3 cases among the bariatric group experienced retention, while among the control group, only 12 patients experienced retention, which was significant difference between both groups. For the adverse effect, we managed to observe the adverse effects. Adverse effects were reported in 8 patients among the bariatric group, including 3 patients floating, 3 patients experienced fatigue, 1 patient fatigue, 1 patient experienced muscle cramp, 1 diarrhea, 1 increased salivation, and 1 stomach ache, which all were mild adverse effects. For the control group, 1 patient experienced fatigue, which may be due to nocebo effect. The conclusion, bariatric mean after TURB in patients with underactive bladder with BPH led to significant improvement in post-operative subjective and objective outcomes with insignificant mild adverse effect and a wide safety profile, making the bariatric mean as a good therapeutic option for enhancing bladder function and recoverability after TURB. Thank you.
We have Dr. Amr Mustafa is here. Dr. Amr Mustafa, comparison of laparoscopic versus robotic assisted vesicovaginal fistula repair using Versio surgical system, a prospective cohort study on safety and efficacy from Cairo University. Fadl.
Good afternoon, everybody, professors and my dear colleagues. I am Amr Mustafa, lecturer of urology at Cairo University. This picture represents my family, my team at Cairo University, and أعتز جدا بالصورة دي ودايما بحطها في كل البرزنتيشن. Comparison of laparoscopic versus robotic assisted vesicovaginal fistula repair using Versio surgical system prospective cohort study on safety and efficacy. As we all know, vesicovaginal fistula is defined as an abnormal passage that connects bladder to vagina and allows the discharge of urine into vaginal cavity. The first reference to vesicovaginal fistula are from Egyptian paper from around 2000 BC. The majority of fistula etiology fall into major categories, either secondary to obstructed labor, commonly in developing world, or secondary to iatrogenic trauma, which occurs in developed world. The incidence of vesicovaginal fistula can vary widely based on geographical and socioeconomic factors. Estimates suggest that at least 3 million women in poor countries have an unrepaired vesicovaginal fistula, and that 3,000 to 130,000 new cases develop each year in Africa alone. The diagnosis of vesicovaginal fistula is a clinical diagnosis. Physicians should become suspicious of presence of vesicovaginal fistula when the patient complains of leakage of urine after pelvic operation. On pelvic examination, the vagina should be carefully inspected using a speculum under anesthesia if required. The cystoscopy is the first line technique for vesicovaginal fistula and urethrovaginal fistula. Most importantly, upper tract imaging should be performed in all cases of iatrogenic vesicovaginal fistula, as concomitant urethral injury may be present in up to 12% of cases. Cystoscopy examination confirms the presence of fistula, determines the presence of additional fistulae, and assesses in its size and location in relation to ureteric orifices. The management of vesicovaginal fistula vary. Maybe management options include non-surgical or surgical treatment, often implemented based on severity and location of the defect. For a smaller defect less than 5 mm in size, conservative therapy may be considered. This often consists of a period of bladder catheterization. Cystoscopy and fulguration is an option, and injection of fibrin glue or thrombolysin may be used. Laparoscopic and robotic approach. As with many surgical procedures performed in our era, minimally invasive techniques including laparoscopic and robotic approach have been increased performed to enhance visibility and reduce morbidity associated with open techniques. The advantage associated with robotic repair are 3D visualization, tremor filtration, high magnification 10 times, and the end rest with 7-degree mobility, leading to improved dexterity and the absence of fatigue. All this contributes to better reconstruction. The Versus Surgical System, CMR, has been licensed for use in Europe since 2019. Versus is a new surgical robotic system intended for use in performing robot-assisted surgery on patients in an operating theater. Versus has been diagnosed to mimic the articulation of a human, and the console of Versus is an open console. Our study is a prospective cohort study, was conducted on 40 patients with vesicovaginal fistula who underwent either laparoscopic, 20 patient, and robotic assisted repair using Versus system, 20 patient. Data were collected on demographics, operative variables, intraoperative and postoperative outcomes, and complications. Ethical approved was obtained from the Research Ethics Committee at the Faculty of Medicine, University. During the study period between July 2022 and January 2024, a total of 40 patients underwent minimal invasive vesicovaginal fistula repair at Cairo University Hospital. Robotic assisted repair was performed using Versus robotic surgical system platform. Inclusion criteria and exclusion criteria I will bypass. I will show the technique rapidly. الفيديو بيشتغل؟
ما في وقت للفيديو، باقي لك دقيقة.
اوكي. less than 1 minute. ممكن يشتغل؟
يلا result and conclusion please.
Okay. Our results, there was no significant difference between demographic data. Only the significant difference was between total operative time. It was less in robotic. Estimated blood loss was less in robotic, and also drain removal was less in robotic, also hospital stay. The comparative analysis between laparoscopic and robotic repair demonstrates an important difference favoring the robotic approach. Robotic repair was significantly shorter operative time, less estimated blood loss. Post-operative recovery parameters also favor the robotic groups, including faster return of bowel motion, earlier drain removal. Also difference in age, body mass index, fistula duration was not significant. In our study, laparoscopic was operative time was comparable to other studies done before. Success rate was 100%. No cases had recurrence or complications. Conclusion: robotic vaginal fistula repair is better than laparoscopic regarding operative time, blood loss, and drain removal. And thank you.
Thank you. Thank you very much for all the speakers. We will have 5 minutes the questions until we announce the 3 winners.
Dr. Maher, Dr. Amr Mustafa, why did you consider your study as prospective cohort? This means that it is an observational one. Why it is not an interventional one?
It's a prospective study. We started the cases from the start at our university, and we followed the cases for a period of time and compared between both groups.
Why it is not interventional? Why it is not interventional? Prospective cohort means it is observational. Why it is not interventional? Why you didn't consider it as intervention?
Yes, it's a conversional, it's an interventional study. Yeah. It's a prospective interventional study.
The difference is if you are going to start right from the start and you don't know the outcome, so this will be intervention. But if you did the work and you know the outcome and then you start to follow up from today to tomorrow, this will be covered. What did you do?
Interventional. We didn't know the result from the start. We made the cases and followed the cases and we
started comparing both techniques from today to tomorrow by doing intervention.
Yes.
So you agree that this is interventional, not prospective cohort.
Okay.
You agree?
Okay.
You publish this?
Still pending, yeah.
Okay. You can please correct this in your manuscript.
Yeah. Okay, sir. Thank you.
Thank you very much. دكتور علي إبراهيم علي. دكتور علي إبراهيم علي. مشي؟ طيب. You stated that it is a double blind. Please explain how it is double blind.
البارتيسيبنتس البيشنتس نفسهم
لا علي صوتك
الدبل بلايند البيشنتس نفسهم ما يعرفوش مين البلاسيبو ومين اللي هياخد تدرافيل 5 مللي جرام والاوبزرفر اللي كان موجود معانا احنا كذا حد مشترك ففي حد مسؤول هو الاوبزرفر اللي موجود.
Double blind means that neither the patient nor the doctor know the type of the treatment. To do a double-blind study, you have to adjust the placebo exactly the same like the medication. How did you do that? انت عملت ازاي placebo? How did you do placebo?
البلاسيبو كانت يعني
زي شوجر بيل كده نوت نون اللي هي لها.
طب the same question is asked to Dr. عمرو مصطفى. لا مين ده؟ لا عمار العرابي. عمار العرابي. Okay, you stated that it is a double-blind study. How
Yes.
did you prepare the placebo to be like the drug?
The company
Yes, perfect.
Provide us with the placebo.
Okay, this is the correct question. So the company has to do a special line of production to make the placebo exactly like
the same, yes.
the medication. Excellent. Very good.
Thank you.
Any other questions from the attendees? Please, go on. No other questions? Yes, please.
John Ezakkers from the Netherlands. Very happy to be here. And I have a question for the one who did the study in diffuser underactivity. And I wondered why he made the selection after TRP and not before in doing this study.
This is the same for Ammar. Ammar, yes.
Why didn't you randomize before the TRP?
We randomized after therapy, not because we need to exclude patients who had complications during the surgery, perforation or clot retention. Any patient with complication intraoperative were excluded from the study, in order not to have bias during this.
One more question. So did you do urodynamics before the TRP also in the same patients? Before the TRP? Yeah. Before and after. So didn't you have any patient with diffuser underactivity before the TRP then? And then they had a TURP, and then they had the other treatment. Okay, okay. Nice format. Thank you.
Thank you, Dr. Ammar. You did a good job. But I would like to ask you, the dose of pyridostigmine, you mentioned? Okay. Please, can you tell me again? Twice
Let us
daily.
hear the
Did you
discussion
have-
between. Let us hear the discussion.
Okay. Did you do any titration in the dose, increasing or decreasing? It is a stable dose for all patients. Twice daily, 60 milligram. Okay, thank you very much.
Okay, thank you very much. Now it's time to announce the winners. Before I announce, I have to give a statement that this competition has been judged by two groups of judges. The first one judged the material, and there were 5 judges. We took the average of their judgment, and then today another 5 judges here for the presentations and I mean the quality of the presentation, how to stick to the time, and this is what we need actually to teach every one of our future speakers to respect the time allowed for him or for her, because this is very important for the future. So we gathered and we took the average of all the scores from both groups of judges, and the third winner, I will start with the third winner, is Dr. Ahmed Maher. He got a total score of 6.9. Dr. Ahmed is here or he left? Okay, left, okay. Second, Ahmed. Mabruk, ya Ahmed. We will have a group photo now with all the speakers. The second winner is Dr. Saeed Yaish with a total score of 7.1. Mabruk. The first winner is Dr. Korai with a total score of 8.2. May I call for all the speakers for a group photo, please?
Calling Dr. Khalid Al-Hallaj, Dr. Akram Al-Maragbi, Dr. Ahmad Abu Talib, Dr. Ahmad Al-Dirwi, Dr. Karim Taha to start our session.
I think according to the program, still we have a 5 minutes gap, so it's good.
صباح الخير عليكم. Welcome to the 59th Annual Congress of the Egyptian Urological Association, a session of endourology and avoiding dysfunction. The first presentation is by Ervin Kosajnis from the USA, Management of Pope in the Elderly. Please.
Thank you very much. It's a pleasure being here with my friends and brothers from Egypt. Thank you for having me. This is going to be a little bit different compared to what we learned so far. Also because the times are changing, so are our patients. We are dealing with more and more elderly population that we need to learn how to manage. This is a true patient of mine, Miss Green. I asked her permission to share her picture, and I told her that I'm going to share her clinical problem with few hundreds of close friends here in Cairo. And she said, sure, go ahead. So she's 80 years of age. She has this bulging after urination and a feeling of incomplete bladder emptying. She is sexually active and feels ashamed and frustrated of her condition and denies any bleeding from the vagina or discharge. She has a new relationship, and she wants to start her new life with her new partner. And she came to look for help. Of course, anything that obliterates the vagina, anything that's like a pessary or obliterative procedure are not an option for her because it would completely jeopardize her sexual function. This condition is quite common in US. We have 26% of all the women 80 and above are seeking help with prolapse. And this is a potentially complex situation with associated surgical risk. And we need to learn how to manage properly these patients. We need to learn how to integrate the geriatric assessment in our practice. And this is not only in benign reconstructive female urology, but also throughout the whole urology surgery. What we need to learn how to evaluate the independence of the patient. What are the daily activities, their mobility, the cognition, depression, comorbidities, and frailty. These are all new concepts that when I was a resident a few months ago, we were not exposed to this. So what we've learned that we need to know this, especially to know which patient we shouldn't operate, in which patient we should be more conservative to prevent delirium, to prevent the polypharmacy, to have a clear discharge planning, so work with the caregivers or whoever lives with the patients so that we can actually have a plan after their discharge, goals in their care, and as I said before, knowing where not to operate. Why do we have to know this? Because this makes a huge difference in the outcome of any of our procedures.
Is one such validated assessment to evaluate three functional domains.
Can you raise the volume,
balance
please?
testing, gait testing.
So this is a core
each task is
evaluation,
how
we are managing
inability to perform the task.
our
to 4,
geriatric
meaning
patients
best
in my
performance.
department.
Total scores range from 0 to 12. The first aspect of balance testing is the side-by-side stand, where the patient will stand with their feet together for 10 seconds. A score of 1 point will be given if successfully held for 10 seconds. The patient may move their body, arms, or knees to maintain balance, but if they get out of the posture, the assessment moves on to the next section.
Do some balance tests. So first I'm going to have you keep your feet side by side parallel and hold it for 10 seconds.
The second component of balance testing is a semi-tandem stand with the heel of one foot touching the toe of the other. A similar scoring method to the side-by-side stand is used.
Semi-tandem stand. So you're going to put your heel parallel with your toe of the other foot. Not in front, but to the side, yeah. And then you're going to stand there for 10 seconds.
The final component of balance testing is the tandem stand, with the heel of one foot in front of and touching the other. 2 points are awarded if the position is held for 10 seconds, and 1 point is given if held from 3 to 9.99 seconds. If the patient cannot hold this position for 3 seconds, or they do not attempt this, they will receive no points.
The next one, I'm going to have you do a complete inline stand, so heel to toe, and then I'm going to have you balance there for 10 seconds.
The gait speed test is a course of 3 or 4 meters for time. The patient will walk at their normal speed, and the instructor will first demonstrate the walk. Patients who use assistive devices may use them during this section. At our institution, we use a 4-meter walk test. The scoring system is shown here, with higher points given for less time required to complete the course. Points are allotted for the best of 2 attempts.
All right, next we're going to do a 4-meter gait test. So this is not a test of speed, just walk at your normal pace. And I'm going to have you walk from the red tape to the green on our side, whenever you're ready.
You may start timing when the patient begins moving, and stop timing when 1 foot has crossed the line. The final component of the SPPB is the chair stand test. Without using their arms, the patient will stand from a sitting position. If they are able to do so, they will proceed to the next portion of the assessment.
I'm going to have you try to stand up from your chair without using your arms, if you can.
Finally, the patient will perform the repeated chair stand, going from a sitting to standing position 5 times in a row without stopping. Points will be awarded based on the time required to complete this, for a maximum of 4 points.
Next, I'm going to have you do that chair stand without your arms 5 times in a row.
The final scores from each component are summed to give a total score. Although not standardized, several studies have suggested that an SPPB score of below 10 may predict all-cause mortality, and patients with low or intermediate scores have higher risks of poor physical performance, loss of independence, and hospitalizations.
So this is a pretty baseline geriatric evaluation that we are actually using in our clinic. This was a patient candidate for a cystectomy. His score were pretty low, and he did pretty well after the surgery. As you can see now, this is part of the core curriculum for the AUA. We were asked to develop this for them. Why is this important in reconstructive surgery? Because a lot of our patients are in this category, and a lot of them, they are at high risk of developing in the first post-op week delirium, which can represent a major problem in managing of the patient. Risk factors includes, of course, age, education, higher frailty scores, depression scores, and this rate of deliriums are similar in the cohort of different type of surgeries. It's very important to know which patients are at high risk, so because we can prevent these problems at their discharge. And recent fall is another criteria that you need to keep in mind in the patients before advising any type of surgery. Where the patient lives makes also a huge difference. You can see here in the study showing that patients that are in nursing home facilities are doing significantly worse compared to patients that live at home and they have more independence in their everyday life. So those are things that we start evaluating when the patient enters into the room. We always observe how they interact with the front people, how they get into the room, how they get undressed, how they climb onto the examining table. Those are all criteria that you can manage in these patients. How can we integrate this in a patient scenario of the pelvic organ prolapse? Knowing that you want to preserve their sexual function, you want to improve their voiding dysfunction, and you want to be as less invasive as possible. And you can obtain this preserving the organs of the pelvic floor, specifically the uterus. Having a prolapse is not part of the normal aging of the female, because they do perceive this as a loss of self-esteem. They have a decreased attractiveness, loss of self-image, loss of sex appeal, and loss of femininity. These are all important things to our patients. If somebody comes just with a higher age, this does not equal just go home and live with your prolapse. Sparing the uterus is an absolutely viable option in these patients and represent a lot of benefits, especially in the length of the hospital stay and the amount of the blood loss, which is significantly lower if you spare the uterus. The only thing, as a urologist, we need to remember that the endometrial cancer, it's predominant in this population, so you need to have at least an ultrasound of the endometrium, and the thickness of the endometrium needs to be below 5 millimeters in order to safely spare the uterus. If it is higher than that, there is a higher chance of having endometrial cancer, like in this case here, where sparing the uterus is not an option. Pelvic organ prolapse can be associated with overactivity symptoms, especially in patients that have other comorbidities. So there are other things that can affect the OAB symptoms, like age, hormonal status, and a higher initial state of prolapse at the presentation. So the higher prolapse can be actually a reason for OAB, and repair of the prolapse can actually help significantly the OAB symptoms after surgery. So POP surgery should be prioritized considering OAB specific treatment. And again, this can actually reduce the amount of burden and medicine that these patients need to use before the surgery. Have a trial of pessary can be a predictive factor to see how they're going to respond after the surgery on OAB symptoms. And usually this is what I quote to my patients, 60 to 85% of patients, they're going to have an improvement or a complete resolution of their OAB symptoms treating the prolapse. And I have a whole lecture in the next one on showing you why this patient may develop overactivity with a severe prolapse. Some of the patients, they're going to have a persistence of the OAB symptoms, and only 5 to 20% they're going to have a de novo presentation of OAB symptoms, which you can treat if these present. What is the easiest way to preserve the uterus in this patient? In my opinion, vaginal approach is the easiest one. This patient can go home the same day, doesn't have to stay in the hospital. Where the patient stays after the surgery at this age is crucial. And what I'm doing usually is the sacrospinous fixation. I do single or both sides. It's a pretty straightforward surgery. You can attach the apex of the uterus onto the sacrospinal ligament bilaterally or on one side using suturing device. Here you don't have to expose the ligament, and you can use different type of devices. I'm actually familiar with all of them, and I was involved in the development of the second one, and I'm currently using the last one because it's the straightforward. You go straight with an anchor into the ligament without the risk of damaging the pudendal neurovascular bundle, which is very close to the ischial spine, which is the one that you actually try to identify during the surgery. It's called Anchorsure. As it goes straight into the ligament, is the one with the really lowest incidence of the specific pudendal neuropathy that may occur after this type of surgery. You can, through the vaginal approach, you can have the ability to correct other things, like if you have an incontinence, you can do this contemporaneously. And you can do a site-specific repair where you actually reinforce this, the ligament. This is an example of a surgery, anterior repair with the apex prolapse. I identify anteriorly the ischial spine. I prepare the ligaments with my finger, and here I just deploy the anchor straight into the ligament with a very low chance of causing any damage on the pudendal neurovascular bundle, which is a couple of centimeters medial to the ischial spine. I do this on both sides. Now I have a very strong support. I add a site-specific repair. In this case, I identify the elements of the pubocervical fascia. I placate this onto the contralateral side. So it's not everything based on a single point of support, but it's a combination of the two. And then I pass the sutures that I passed before into the cervix, and while tightening these sutures, you can see the cervix actually goes deep into the vagina, getting Miss Smith a very nice deep vagina without any shortening of the vagina, without any trimming of the tissue. And this is the end repair. To conclude, vaginal surgery with uterine preservation is a viable solution with very low morbidity, short operative time. This is like less than an hour surgery. The patient can be discharged home the same day, and it's very suitable in properly selected patients that are age 80 or above. Thank you very much for your attention.
Thank you very much, Dr. Ervin Kosanjic. I'm pronouncing your name right?
You're doing a pretty good job, yes.
Oh, thank you very much. Thank you for your nice illustration. I think if there is any question from the floor. Okay, I have a question about the scoring system that you illustrated. How much it will help me in assessing the patient? I mean, the points, if it's a lower or intermediate or high. What's the outcome of this to use it in my management plan? Because I didn't get it well.
Yeah, so you need to obtain a low score in these patients. This score is going to help you in identifying which patients not to operate. Patients that you do, okay, this specific patient was a patient candidate for a cystectomy. If the patient has a high score, he or she can have a significant higher chance of dying in the perioperative time because of the other morbidities. So those are patients that you can be very conservative, do endoscopical treatment, or in this case, walk the patient through the options and maybe discourage them from having the surgery.
Okay, thank you very much.
Dr. Ahmed, thank you for your nice presentation. My question for a patient with moderate dementia who cannot demonstrate their symptoms. How could you assess these symptoms, and what's your first line of management for them?
With the prolapse, it's easy because you need the physical exam, which you don't need a lot of patient cooperation for this. If the patient has a moderate to severe dementia, it's the patient that probably is not very interested in sexual activity. So those are patients that you can actually manage differently, like with the conservative treatment using, for instance, a pessary or an obliterative procedure if the patient wants.
Thanks.
Thank you very much. We'll move to the next presentation.
Next speaker, Professor Muhammad Shazli from Nafia University, Personalized Stone Approach, please.
Mr. Chairman, it's my pleasure to present this topic today, which is personalized stone approach. With the advancement in endourology in the last few years, with the more and more awareness of the patient about the social media, about the new inventions and advancement, the medical legal issues, and now it is one of the hot topics, how to take a decision for stones. Guidelines change slowly, but around us the advancement is progressing very fast, and we need to have a look about this topic, which is personalized stone approach. Urolithiasis contributes a significant burden on the healthcare system globally. The lifetime recurrence rate in patients is up to 50%. The guidelines need proper management with the best success rate and the least morbidity needs to take evidence-based decision. Still, we respect and follow the guidelines. All of us know the guidelines in the proximal ureteric stone, in the kidney stone, in the lower pool stones, and the practical examples. For example, a stone less than 1 centimeter, Hounsfield unit less than 1,000. It goes without saying that the shock wave is still alive and it is ideal non-invasive method. However, if the stone is hard and Hounsfield unit more than 1,000 or stone is large, now the retrograde intrarenal surgery offers an excellent solution for such stones with hard stones that need repeated sessions of shockwave. BCNL monotherapy is still the treatment of choice in large stones. Generally speaking, stones more than 2 centimeters, staghorn stones, branched stones, large sizable lower pull stones, still the guideline recommend BCNL as the first option. Can be through a single tract if it is not that complex, or can be through multiple tract BCNL. Sorry. However, the guidelines just consider the stone size and the stone site and doesn't take into consideration a lot of other factors. So you can see here the same size stone but in different anomalous kidney, different age population. So a lot of stone factors, patient comorbidity, cost issues, available resources, and surgeon experience can change our decision, not only the guidelines. The concept of PSA in endourology, or personalized stone approach, was firstly suggested by Paul Author when introduced the endoscopic combined intrarenal surgery, but now we popularize it for the decision making in general. The rationale of PSA is to provide a framework for an individualized approach to each patient. This creates the need of a personalized approach tailored to individual environment, taking into consideration the available resources of the treating physician. This approach begins with the synergistic communication between the surgical team and the patient to tailor the plan of action based on different considerations. What's called patient-shared decision. Now, not like before, even in our practice in Egypt, before the patient come and ask the surgeon to take the decision. Now patient comes and they went for ChatGPT, went for social media, reviewed the available resources, and after that discussing all the alternatives with the surgeon. This is different from the generation before us. So patient features should be taken into consideration: demographics, physical, medical, anatomical challenges in general or related to collecting system, stone factors, number of stones, location, size, composition and hardness, and associated UTI. Surgeon team features: the equipment, the expertise, the theater space, the availability of resources in the hospital. So don't consider the guidelines GPS navigation. You will take the decision in some situation. If you depend or rely only on guidelines, you will get lost, and you cannot take decision in some difficult situation. So the answer is personalized stone approach. Starting with BCNL, still it remains the gold standard for treatment of large or complex renal stone. Although effective, safe in expert hands, it remains a challenging procedure, and sometimes the morbidity is significant even in large centers. So the last guidelines start to open the door for flexible ureteroscope retrograde intrarenal surgery as an option, or a plan B option in large stones if the BCNL is risky. This is in the last European guidelines. So we can consider sizable stones to have a plan B retrograde intrarenal surgery in complex upper ureteric stones. Also expanded the parallel development in flexible ureteroscopy technology. For example, this is one of the cases: large sizable upper calyceal stone, but you can see here on the red arrow the window for BCNL is feasible but risky, and it is high and near the liver. So if we discuss the patient the other alternative, he agreed to have a retrograde intrarenal surgery for such case, to have a safe surgery, even if it can be 2 stages, and patient agree for this. Another example of retrorenal colon, still feasible, is still feasible. We can do very medial puncture, ultrasonic guided, still. But why if I have alternative safe solution like retrograde intrarenal surgery? Inside the BCNL itself, a lot of details in the procedure itself, which calyx to puncture, this need to be tailored to the patient. For example, upper calyceal stone constitute a challenge, and we should master how to do a supracostal approach. Sometimes in difficult situation like this, you can never get this stone from a lower calyx or a middle calyx, so you need to adjust the puncture and to go for the supracostal approach. If the organomegaly spleen is large, you can adjust your puncture to go very medial to avoid the organ to the site of puncture need also to be adjusted. In upper calyceal stone with narrow infundibulum, it is very difficult to go from other calyces, so you need to do a supracostal puncture like this case, or narrow infundibulum make the retrograde intravenous surgery difficult. So supracostal can be done. This was in a workshop case where the upper calyx is very high, above 10, and very medially complex upper calyx. So still you can do with adjustment of a supracostal puncture, taking into consideration to have a safe window through the lateral half of the last space and during expiration to allow the lung to retract and to avoid the pleural injury. This is a calyceal diverticulum, also needs to have a specific approach like this. In another situation that needs to have a personalized approach now with the dilemma of medium-sized stone, 2 to 3 centimeters. Now with the advancement of the laser lithotripsy, with the advancement in suction, many centers now shifting to do flexi for this medium-sized stone. One of the approaches is to counsel the patient for both possibilities according to the situation. And sometimes for this case, you go, الفيديو لو ممكن نشتغل. In this case, if the patient agree for both solution, can be happy to do either flexible or either BCNL. After retrograde biolography, the ureter was found to be very friendly and wide ureter, and the scope went very easily to the pelvis. And the stone itself is very friendly, calcium oxalate dihydrate, very friable stone. Why to do BCNL? Finish this case in half an hour. So otherwise, if the ureter is tight, we can shift to BCNL. I mean, we should be flexible in taking our decision according to the safety of the patient and according to the available resources. Stone composition and the fragility is a key factor in determining the modality of treatment to be chosen. Different stone composition can change our decision with the same size. For example, these two cases done in the same day. One stone is hard, Hounsfield unit around 1,300. So we took a ureter is tight. We took a decision to finish it with BCNL. In the same day, this stone was around 700 Hounsfield unit. Ureter was friendly, so finished in less than 1 hour with flexible ureteroscope. To do prone or supine, a famous debate, the emergence of supine by Valdivia, 3 decades, and popularized in the last few years. Each position have its merits and demerits and comparable in guidelines and according to surgical preference. But endourologists should master both and do the best for the patient. For example, I am a prone surgeon. I did a prone for this case, but the airway resistance increased and anesthesia object, so I shifted him to prone and to supine, and complete the case with supine. The endoscopic combined intravenous surgery is another perfect example for the marriage encompassing both fields, combining simultaneous antegrade and the retrograde approach. It will fulfill our need for one-step resolution of an episode of stones along the entire urinary tract. These examples of endoscopic combined. The BCNL can clear the lower calyx and pelvis, and the retrograde intravenous surgery can clear the rest of calyces without the need to have multiple tracts. Another example of endoscopic combined intravenous surgery. Regarding the retrograde intravenous surgery, the personalized approach, this can be alternative to BCNL, as I said. It helps too much in ectopic kidney, malrotated kidney, anomalous kidney, horseshoe kidney. With the advancement of the suction techniques, either flexible and navigable suction sheaths or direct in-scope suction, with the great advancement in laser machine, introduction of the super duster TFL, thulium fiber laser, high power machine, Moses effect, this pushed the limits of the flexible ureteroscope in the last few years in many centers all over the world. According to the situation, if the BCNL is risky or according to patient chair decision, many patients now and many centers pushing the limits of the procedure and agree to have a staged procedure other than have BCNL. This debate, like the transition zone from the open surgery to BCNL, now we have this transition era between flexi and BCNL. Regarding the objection or the concerns about the retrograde intrarenal surgery, many surgeons still skeptical to do retrograde intrarenal surgery, especially for large stones, for the concern of ureteric stricture, and this is sure the most famous French image after Mona Lisa by Traxer, but it was on 13 French ureteric access. Now we have in the market 9 French ureteric access, and rarely to use a large sheath like this. And we have more and more stricture if we're not sticking with the rules, if we're not following the rules to do breast stenting or not to do a lengthy operation in a tight ureter, we will have more and more strictures. So very important step or to personalize the approach to have a judicious judgment of the ureter by a semi-rigid scope like 7.5 French. If the ureter is friendly, you can put the sheath. If not friendly enough, you can do backloading. If tight ureter, to put a stent and come back after 2 weeks. This judgment is very important. Never promise your patient that I'll finish in one step only or one session only. And keep in concern the thermal effect, especially with the TFL, not to exceed 10 watts in ureter and not to exceed 20 in kidney. Sepsis is still a concern in retrograde intrarenal surgery, so the solution is to do preoperative preparation, culture negative, antibiotics, staged procedure in septic case, do stent and come back, avoid lengthy operation more than 60 or maximum 90 minutes, and use suction. Suction is the key to lessen the infection. Keeping the low intrarenal pressure all through the procedure is very helpful. For example, this is a personalized approach. We noticed a gas-containing stone suspected to be infected stone, and you can see here we did staged procedure. Also, in the large upper ureteric stone, a dilemma between ureteroscopy, antegrade, or laparoscopic. Don't take a preoccupied decision. Always give a trial of endourology. Sometimes you are preparing to do antegrade, but you go with retrograde and you find it very easy. If it is difficult, you can do antegrade approach, or you can push and pull or push and complete the case of PCNL like this. So give a trial of retrograde and change your own decision if it is impacted or it is difficult situation. Now we come to a famous question. Is it still a place for open surgery in stones in 2025? Open surgery is acceptable in situation where minimally invasive experience is not available to clear the stones. And here, for example, this is a medical student tried to have PCNL in another university and have severe bleeding, and he came refusing to do PCNL, and he's a cystinuria case, cystine patient, cleared by open surgery in one session. In endourology, World Congress of Endourology, Arthur Smith, the godfather of endourology, asked a panel of endourologists how to do this case, and finally he said, I did partial nephrectomy, and he's Arthur Smith. Still, there is a space for open surgery. Medical treatment still have a space in medical expulsive therapy and in dissolution therapy. For example, you can win the battle without polyps in large pure uric acid stone like this and got complete resolution in around 3-month therapy. So my take-home messages: do no harm and patient safety is priority. You should be as endourologist like chess player mentality. Have a deep thinking before you take a decision, not to rush to give a decision in the patient just when you see the CT, I give a decision. Take some time to think and to take the decision which is effective and safe to the patient. Sorry, just one slide or 2 slides. There is no one size fits all in endourology. Endourologists should master all the endourological modalities of management and choose the best for the patient. Don't be fanatic to one technique. It is not like football. Don't be fanatic to one modality. The PSA primary goal is to optimize the use of available healthcare system. Fundamental objective is to maximize the population health within available budget. It aims to consider a single intervention to maximize the stone-free rate via the most cost-effective approach and the least morbidity, considering patient-shared decision and to avoid the nightmares of endourology. Thank you.
Thank you, Dr. Muhammad, for the comprehensive review. I have a question for you. What about the prevention? After you clear the stone, what's your policy?
Yes, Thank you, to Professor Ahmed, for this excellent questions. I think we give a course before on the metabolic evaluation and prevention. That is very important. Unfortunately, we see cases of cystinuria, for example, with no medical treatment, and they have lost kidneys. So it's very important to have the medical, the metabolic workup, especially for children, especially for the repeated stones. And I think it is available, the labs now is available, and they can provide us with important data to have knowledge about how to prevent, and if the patient stick with the medical treatment, the prevention, we have a strong evidence from the American guidelines, from the European guideline, that stones is preventable disease. Not just drink a lot of water, a lot of medication available that can help to decrease the stone episodes among patients.
Any other question?
Thank you for a great lecture. I would ask about which you prefer in suction system. This direct telescope suction or fans, flexible navigable sheaths?
Regarding the types of suction, if you have a super duster machine like TFL or high power holmium, you can achieve a true dust less than 250 micron. You can use this. That's why in the Western they popularized this. But here in Egypt, most of us has low power holmium machine. Low power holmium machine, sometimes you cannot achieve true dust. You just do popcorning and you have a multiple tiny fragment. The flexible and the navigable sheaths offer great help that you can retrieve this fragment and declare and give comparable result to those who have the sober duster machine. So the low power holmium with fans can give you the same result if you don't have the TFL or high power machine. So I prefer fans.
We all know that there is many cases of infection after flexible uteroscopy.
السؤال جاي منين؟
Here. دكتور محمد شبايك.
اتفضل دكتور محمد.
استاذ. كنت عاوز اعرف ان حضرتك بالنسبه للبوست اوبراتيف انفكشن بعد الفلكسبل is very high. So which antibiotic regimen would you prefer to put the patient after flexible uteroscopy?
In my experience, Dr. Muhammad, the staged procedure or staged approach, especially we started to do a medium-sized stones or large stones. Most of the small stones, friable stones, finished by shockwave. Most of the centers doing flexi, now they have hard stones, 2 centimeter stones. So the key to avoid infection is to do staged procedure. Put a stent for any sizable hard stone and come back after 2 weeks. The advantages is keeping the ureter safe, keeping the intrarenal pressure all through the procedure during your work, so your infection rate will become much less, even if you work after emphysematous, after infected stones. We'll publish it soon in rares in infected stones. Regarding your question, if it is just empiric, we just give cephalosporin, we can increase to more, if fever happened, to more sensitive cephalosporin for a few days as a routine. Because in Egypt, we re-sterilize the scopes. Still most of the centers in Egypt, we don't have a real single use. Most of the center either sterilize with Cidex or plasma. So the situation needs to cover with good antibiotic intraoperatively or postoperatively. You can start with cephalosporins. You can add more like merovinum, or if fever persists or fever you have according to the policy of the antibiogram or the policy according to the situation you have. But my message, if you use suction, the rate of and the staged procedure, the rate of infection, despite we do re-sterilization, the rate of infection will decrease dramatically.
And do you have an experience with using garamycin installation with irrigation?
No, I don't have experience.
Or cold saline, using cold saline irrigation?
I don't use it. Some centers use it, but I don't have experience in local antibiotics.
Thank you, Dr. Muhammad. For sake of time, the next presentation.
Next presentation, Dr. John Hisakar's new development of neuromodulations for overactive bladder.
Thank you very much. Good afternoon, everybody. thank you for the invitation to come to Cairo again, to your beautiful country, and share some knowledge about neuromodulation. I'm from Maastricht, and we do a lot of neuromodulation for a long time already. And the reason is that we have many patients with overactive bladder complaints, and you will also have many patients with overactive bladder complaints. And since the world population is getting older and older, all of us will have more and more patients with overactive bladder complaints. And perhaps we also know that we cannot treat them all with drugs because they have a lot of side effects, there's a lot of co-medication, so we need something else. And perhaps neuromodulation is something that, that could work here. Now the idea is very simple. If you have the bladder here and the brain and the spine here, there is some nerves that are involved in the innervation of the lower urinary tract. And we think that if there is something wrong with the signals that come to the bladder from above, that means a pathological signal, then you could put current on the innervation system of the urinary tract, and then you have treatment. And that's what I call a therapeutic signal. And I tell this in such a simple way because we give the same treatment with neuromodulation on the same place with the same parameters for two complete opposite diseases, which is overactive bladder and non-obstructive retention. So, okay, if something is wrong, put current, and something is coming to the good. You can do that in various ways. You can do that at the sacral nerve here, that's the classic one. You can do that at the tibial nerve, at the ankle, easier, and perhaps also at the pudendal nerve. Now, the treatments with overactive bladder started with addressing the sacral nerve. So this is what we have. It's called intersim therapy. The firma, the company Medtronic did it that time, and what you have is finally an electrode at the spine, at the sacral level, and that innervates the roots that also have effect on the bladder, but also go up to the brain, and that more or less gives the correcting signal to the lower urinary tract, and therefore you can have treatment. Now the ways of neuromodulation at the moment that exist, this is the classic one, sacral nerve stimulation at sacral level. You go somewhere to the spine at the pelvis, and then you can address and access the sacral roots. So it's mainly done by an implant. Two companies at the moment, at least in our country, there are more, for instance China, and that gives the sacral nerve stimulation. We have posterior tibial nerve stimulation, PTNS it's called, and that can be done in different ways. You can do it transcutaneously, you can do it percutaneously with the needles, as we classically know it, and there are even implants at the moment, and that gives a lot of possibilities for us, because these implants at sacral level are difficult to apply, because you have to put your patient on the belly, do the test, go home, come back, again do the final implant. That means that if you want to do that to an 85-year-old patient, that's not that easy, especially not under anesthesia. So this is perhaps an easier way also for the other population. Now how do they compare? Do we know how good sacral nerve modulation is as compared to tibial nerve modulation? Unfortunately, we do not. So if you test SNS versus transcutaneous stimulation, there are no comparative trials. Versus PTNS only for fecal incontinence, and there SNS is better than PTNS, as a randomized controlled trial find out. And we have also SNS versus tibial implants. So far there are no comparative trials. That hopefully will come up in the future. This is the classic situation, this is the test simulation. You stimulate at S3, there is a screener as it is called, and finally if you're happy with the result of the test, you can do an implant with it. So it is a two-stage procedure, and then you have this pacemaker that can be chargeable or non-chargeable, and then you have a system that works. Now, we thought that most patients would like a chargeable stimulator for their sacral nerve stimulation, but that's not the case. Most patients want to have a stimulator that they don't have to activate themselves, no charging themselves. So the big one, this is the micro, which is chargeable. This one is the classic one, but we also have a big one which is called the X, and that has perhaps a battery life of about 10 years. What we also have now as a development, which is very important, is that we have MRI compatible leads. especially for patients that might benefit from neuromodulation, let's say the neurogenic population, which is excluded so far. You can imagine that, for instance, patients with multiple sclerosis who need an MRI every now and then, they need to have a safe system which doesn't burn the roots and the nerves, and MRI compatible leaves take care of that. So that's an improvement. Then we come to tibial implants. Well, this is the first tibial implants that we did that time in Nijmegen in 2003. This is a part of a Brinty device. We just cut it off and put it at the ankle and see what was happening that time. Well, it worked quite well. We published that in 2006, but we found out that in 8 patients it was an easy procedure. There were not major harms, and it worked also quite well. If you look at the incontinence episodes, for instance, after 6 months, one back, went from 9.3 to 3.6, voiding frequency went down, etc., etc. So you see here into the good direction with a very primitive implant that worked. So we were very happy with the implant at the tibial nerve, which is at the ankle, at the foot, easy to do, and we waited for other companies to pick it up. Well, that was done finally after about 20 years, and this one is the first. This is the Protect PNS. It is a lead which you can imagine more or less is comparable to the lead that we know from SNS. Is put subcutaneously at the ankle near the tibial nerve, and then you have some effect. The company changed a couple of years from ownership. That always is a bad sign, and there is a publication from 2023 showing that the results are good, but finally the study is still going on. It's a randomized study. It's comparing the Protect PNS versus Interstitch, so that's a good thing. So it's a tibial nerve implant versus a sacral nerve implant. But see here, it started in 2015, it's still recruiting, expected to end this year. Well, so far no news. We have to see how good it is. This is the Medtronic system. Finally, they also thought that perhaps the tibial nerve is a good nerve to address and to access with an implant. This is their implant. It is chargeable. It contains a battery, and you put it, and that's very important to my view. This is the tibial nerve at the ankle, and this is the implant. This is the fascia between the implant and the tibial nerve, and the Medtronic system is put subcutaneously, but also suprafascially in order to have its effect. It might work. The study is finished. This was the end point of the study of the patient that came in last. The results are there. It's not published yet, but finally we hope that this will give us also very good results. This in tibia is another tibial nerve implant. It is single use. There is a programmable tibial nerve implanted. It's also subfascially implanted, and what you should do is 30 minutes daily stimulation 4 weeks after the operation that starts. This is how it looks. So this is the stimulator, these are the electrodes, they're shifted also at the tibial nerve, and then it has its effect, and then you can expect clinical results. This is the first results in 10 patients. These are the number of urinary incontinence episodes. You can see that from 2.5 go back to about 0, which is good, and we expect also that this trial will finally will be very good. Another one in tibia study from Coloplast. This is also an RCT, active versus non-active after 3 months, a nice tibial implant. It looks at the reduction of urgency urinary incontinence at 1 year. There are 208 patients enrolled. The primary endpoint data have been there for half of this year. We wait for the publication, and then we know how good this is. eCoin is there already in US. It is some kind of a coin, a battery that you have in your watch or whatever, and you can put it also at the nerve, at the tibial nerve, at the sacral nerve, at every nerve. That's what the company wants finally, of course. It looks a bit like this. It's from the Valencia company. This is the first study that they had in 46 patients, a reduction of urgency incontinence episodes minus 71%, more than 50% improved, 70%, which is quite comparable to all other neuromodulation studies that we have, and that's the key thing. We all have the results more or less in all the groups of patients that we have with all kinds of neuromodulation, and the real question is how selective should we be, and what is the good outcome parameter in order to find out which of these systems is the best. 65% were responders after 1 year. That's what you also see in every study. We have about 70% success rates in every study that we do. And that also makes that we can compare the one system to the other, and then we can see which one is the best or the cheapest or whatever you want to have. This one was published by Peter Gilling also. He is also in not only in HOLAB but also in neuromodulation. And they looked at this in 1 year studies, but there were also there are already 2 year studies that was published last year. And what you can see here is that 78% of these eCoin patients had more than 50% reduction in urinary incontinence, and even 22% were dry on a 3-day diary. That's not what we quite often see, but you have to take in mind that these were the responders to the first study, so that's a selective group already. Still, this looks quite good. The thing is that this battery is more or less automated by itself. You cannot charge it. You have to replace it when it's empty. It was empty after 2 years. That was the first wish, but finally it appeared that that was already after 1 year, so they changed the system now, and it can last for a longer time. And then is the Renova system. We are involved in that. It's a passive implant, one back, which has the stimulator at the tibial nerve. You have an external wearable that activates this stimulator, and then you can also, by an iPad, you can follow what your patient did, how much time he stimulated or she, how many times a week, how long, etc., in order to find out whether the stimulation parameters were good. These were the first, this was the first results of a safety study that was done about 5 years ago, published 2020. And what you can see here, that also here the results are more or less the same. 75% success rate, which is more than 50% reduction of the primary complaint, and that also done with symptom relief. This is the study that was done afterwards to look at the efficacy. It's for the study in 151 patients that looked at effect after 6 months, but also after 3 years. So this one is after 12 months, and what you can see here is 66% has more than 50% reduction, and a couple of those are even having better success. This was published this year. It's the 2-year efficacy data of the same group of patients, and what you can see here, that 79% is doing very well, and 97% was very happy with the therapy. Now, in conclusion, we have implanted tibial nerve systems coming up. There are about 4 that are tested at the moment in a clinical setting, and perhaps all of those will finally be available for us. We focus on small or battery-less implants. Chargeable is better than replacing an implant mostly of the time. The success rates are more or less comparable to SNS so far, but there's no direct comparison yet, at least not yet published. And finally, we need to have that in order to appreciate all these systems. Then there's one more, because if you have the sacral nerve, the tibial nerve, there's also the pudendal nerve, which is having a lot of afferent symptoms, afferent nerve fibers. Afferent means going up to the brain, where we think that neuromodulation has its effect. And you can also stimulate the pudendal nerve. There are some studies on this, and this is one that at the moment is tested. It's the Inocon device from Sweden and Denmark, and what they do is stick to the dorsal genital nerve in men and in ladies, which is perhaps questionable whether that's acceptable to all of us. That means that finally you can have some effect here too. It is tested in the clinic at the moment. First results are good. Whether this will really go into clinical practice, I'm not really sure. Thank you for your attention. And if you want to come to the Netherlands, come next year to Maastricht, my hometown, because that's where the ICS takes place. Thank you very much.
Thank you, Dr. John, for your illustrative my question about the counterpart of overactive bladder for the use of neuromodulation, which is non-obstructive urine retention, as in Fowler syndrome. I want to know your experience for the use of neuromodulation in this object.
Yeah. The results are good if you have a proper workup of the patient. And non-obstructive retention quite often means that if you look urodynamically at those patients, that you don't see that much detrusor activity. And what we know from our practice, that if you see some kind of detrusor contractility at urodynamic investigation, doesn't have to be much, but it has to be something, then your results are better than if there's completely nothing, so an acontractile bladder. And if you're not sure with your statutory ambulatory urodynamics, you can do mobile urodynamic investigation, and if you see something there, then the predictive value is good of that study. So that's a good test in order to select the best patients for it.
Any question from the floor?
Yes, I have a question from the chairperson, please. It's a very nice presentation, but I have a question from your experience. What type of neuromodulators, especially the implanted one, do you prefer to use it in your clinic, and why?
Yeah.
And how much it will cost?
Well, I'm biased by that because
Okay, no problem to be biased, but tell us what's your experience.
Yeah. Well, when we developed our tibial implant and the Blue Wind company came over to say, okay, we have something that is based on your development. Can you give us some advice, consult us, how to place it, where to place it, and what kind of implant we have? Well, we had some preference there, and my personal view is that if you go very close to the tibial nerve, that means under the fascia, not staying outside of the fascia, then you might find the perfect place to stimulate, so that's what I like. I would prefer, especially at tibial nerve, an implant without battery, so activated from the outside but without battery, and also small, that if you kick your feet that you don't hurt your leg.
Thank you. Yes, please, your question.
Thank you very much, John. It's always a privilege to listen to you talking to neuromodulation because you have one of the greatest experiences in the world. Just I want to learn from you about your experience of neuromodulation in neurogenic patients, because we very often see now its utilization in neurogenic patients, but what is the evidence behind it? Or if there are any patient groups you would say, okay, this group will likely to benefit from the neuromodulation, but for this group, please do not try it because they will not benefit from neuromodulation.
Thank you for that, Tufan. Well, I think if you, there are certain neurogenic patient groups that are very well suited for neuromodulation. I think MS is one of those. And since we have compatible, MRI-compatible leads, we can also do it in this group of patients because they can have an MRI afterwards. But then you have to be not that severe attached by MS. So we do it now, we started a study on it, do it in a randomized study, and we do it in EDSS up to 6, which is mild type of MS, and we think that will be the group to test. There's not big evidence there. There are some studies testing MS. There are also studies that presented all that is known in neurogenic patients with neuromodulation, but those are so diverse groups, and the studies are also so diverse that you cannot make any big conclusion. The group I would not test is spina bifida, so the bifid spine patients, and I'm not convinced that in total spinal cord injury patients it will work, because then your theory of how it works would not fit.
Okay, we'll take the last question by Dr. Kojansik.
That's him, yes.
Right?
Yeah.
Okay,
Good
do
job.
it.
So, John, you partially answered these questions stating that proximity to the nerve, it's relevant. I believe so too. We learned this in the neuromodulation, in the SNS, and I'm doing the RAVE is the only one that kind of makes sense to me because it's subfascial is very close to the nerve. So the questions I have, is there any evidence though that being close to the nerves make a really difference compared to being above the fascia? And how are you selecting patients for SNS versus the tibial nerve?
Yeah, we did some sub-analysis in the 151 study from Blue Wind, looking at the predictive values of the good stimulation there, and what we saw that leg circumference was a negative predictive factor. So the bigger the leg, the difficulty is to have good results. That more or less means that if you do stimulation from outside, you have to cross a distance in order to get to the nerve. And for that reason, I also think that if you're closer to the nerve, your results are better. There's no hard proof for that. I don't know. I don't think so. No.
Thank you, Professor John. We shift to the next presentation. Professor Tufan Tarkan, the Trouser Under Activity, Current Concepts.
Thank you. Okay. Dear Chairman, dear colleagues, good afternoon. It's my great honor to be here again. Thanks very much for the kind invitation. I really feel at home always in Egypt. I hope our good relation will continue also in the future. Now, my talk is about data underactivity, which is a topic where our minds are not very clear, actually. So these are my disclosures, not the industrial ones are not very much related to my talk, but my main disclosure may be related to the ICS, because the ICS terminology will be the mainstay of my talk today, starting with the underactive bladder definition. The underactive bladder is defined by the ICS as slow urinary stream hesitancy and straining to void, with or without the feeling of incomplete bladder emptying, dribbling, often with storage symptoms. So as you can understand, it does not imply a specific pathology. And the management of underactive bladder greatly varies depending on the bladder of the patient. Whereas the detusor underactivity, which is the title of my talk, is a definition from pressure flow studies. And it is described as contraction of reduced strength and or duration resulting in prolonged bladder emptying and or a failure to achieve complete bladder emptying within a normal time span. And this is unfortunately not numerically or qualitatively or quantitatively described in a detail or in a good understandable way. And this is one of our main obstacles in defining detusor underactivity. So I think it is a kind of helpful for us to clear our minds if we compare the underactive bladder syndrome with overactive bladder syndrome, as we tried to do in this ICI think tank in 2017. There is a hierarchic relation, as you see, between underactive bladder, detusor underactivity, and impaired contractility. The underactive bladder, as we have learned, completely refers to the symptoms. The detusor underactivity, when we speak about detusor underactivity, we have to be sure that it is a finding of the pressure flow study. But when we talk about the impaired contractility of the bladder smooth muscle or bladder tissue, we have to know this refers to an in vitro finding, which is coming from the organ bed studies under isometric tension. For example, when the bladder tissue does not respond enough to electrical field stimulation or carbachol dose response in the presence of enough nutrients in the environment. So you can just easily reflect this information to overactive bladder syndrome, where the overactive bladder syndrome is again based on symptoms. The detusor overactivity is now a finding of the storage phase of the urodynamic studies. And when we speak of increased contractility, we mean again the in vitro isometric tension studies. We have also analyzed other differences between OAB and underactive bladder, and there are actually two main differences. One is with the underactive bladder, we still do not have an index patient because we do not have a symptom like urgency which we can build the underactive bladder on it, as we did in overactive bladder. And another unlucky situation with underactive bladder is we do not have good treatment options, either surgical or medical, for the underactive bladder. So these are the main differences, although both underactive bladder and overactive bladder refer to symptomatic conditions. Really, symptoms can vary in the presence of status or underactivity. As you see on the slide, we have here the male population and the female population. This part of the figure shows the ones with status or underactivity and the ones with non-status or underactivity. As you can see, there are all mixed symptoms, and no symptom can actually indicate or predict the presence of status or underactivity in the urodynamic studies. So can we develop reliable symptom scores for that? These symptom scores may help us to monitor our treatment outcome, but not for the diagnosis, as this one is a pioneer symptom score which was developed in Bristol in the ICI group to actually assess the underactive bladder syndrome. Regarding the pathophysiology, so I said our minds are not clear. But what is the mechanism of status or underactivity? Does the underactive status start off as underactive, or maybe because of some pathological mechanisms we develop status or underactivity afterwards? Thanks to Professor Chris Chappell to give me this beautiful slide about the etiopathogenesis of status or underactivity. We can talk about different domains of pathogenesis, such as central circuits, efferent pathways, afferent pathways, and the muscle part of it. And this can lead to failure of integration or processing, impaired activation of status, or early termination of voiding reflex, and loss of intrinsic contractility. And as a mechanism, a neurological disease or injury can lead to that, or diabetes mellitus, or bladder outlet obstruction due to BPH in the long term can lead to status or underactivity, or maybe normative aging, what we don't know very much about it, are all possible responsible factors in the etiopathogenesis of status or underactivity. We have animal models to study the possible pathophysiological mechanisms. Of course, we know that there is no ideal animal model to mimic the human disease. This is an animal model that we developed in Boston University. This model is called the atherosclerosis induced pelvic ischemia rabbit model. And we have shown that in rabbits with moderate bladder ischemia, you just create an overactivity model. But when you increase the level of the ischemia, then your model turns to be an underactive model. We still do not know whether this implies to humans or not, but very clearly, moderate ischemia in the rabbit has resulted in overactive bladder syndrome, and more ischemia results in status or underactivity. Can the same happen in the humans? We do not know yet. Phenotyping of underactive bladder is certainly necessary. We cannot put all children, young men and women, elderly male and female patients, especially the ones with coexisting status or underactivity, status or overactivity, and neurological patients to the same basket. The pathophysiological mechanism in children may be quite different compared to the adult population, where the learned misbehavior leading to voiding post-movement and dysfunctional voiding may theoretically lead to underactive bladder, whereas in male population, for example, a long-standing obstruction, as it was shown by the Italian group here, may start with hypertrophy of the bladder smooth muscle, then the compensation phase may follow, and which may lead to decompensation phase. And in that phase, we actually talk about detusor underactivity or the coexisting detusor overactivity and underactivity. The treatment options target a direct detusor stimulation, the brain, the pontine micturition center, spinal cord stimulation, sacral micturition center stimulation, sacral rod stimulation, and pelvic plexus stimulation. And at this moment, some of them are proven to work, some of them are still under investigation. According to the EAU guidelines, clean intermittent catheterization in the male population is still the mainstay of the treatment in patients with high PVRs. According to the guidelines, this is 300 milliliters, but this can, of course, change according to the clinical findings and the bother of the patients. Indwelling catheter is something that we do not like. Fortunately, no medication in a way to make the bladder smooth muscle work again for male population. And alpha-adrenergic, however, are recommended to be used before any irreversible surgical intervention in this main group. If you have a male patient where you prove that there is no bladder outflow obstruction, sacral neuromodulation can be an option. But if there is a detusor underactivity and obstruction, still surgery is recommended, although your patient counseling should include a special talk with your patient that the postoperative success may not be as good as wanted. In female population, there are conservative measures. Again, the intermittent clean catheterization is the mainstay of the treatment. Unfortunately, oral parasymptomimetics again do not help our patients, and alpha-adrenergic blockers marginally have recommended. Here they have shown to improve the voided volume and reducing PVR volumes. Onobotulinum toxin to the external sphincter has a weak recommendation because we're still not sure about the protocol and the evidence behind it is still lacking. However, the EAU guidelines strongly recommends to offer sacral nerve stimulation to women with underactive bladder refractory to conservative management. Actually, this is the only treatment option almost that is working in our hands, because even the surgical other options such as detusor myoplasty has a weak recommendation here. So as a conclusion, underactive bladder is a symptomatic definition. It is not a urodynamic definition. It may include many different pictures in itself. It may end up after a urodynamic study, sometimes with detusor underactivity, sometimes with bladder outflow obstruction. So urodynamic studies are quite crucial in this patient group to understand objectively understand the lower urinary dysfunction. Bladder re-education and pelvic floor muscle exercises are commonly utilized, but the clean intermittent catheterization is still the mainstay of the treatment. Neuromodulation works well in good selected patients, and of course, if the detusor underactivity is associated with obstruction, we have to relieve the obstruction. Unfortunately, we do not have any working medical treatment yet for detusor underactivity. And as John has stated, I would like to invite you all to Maastricht next year for the ICS annual meeting, where the heart of the functional urology is going to beat. Thank you very much for your kind attention.
Thank you, Professor Tofan, for a very comprehensive presentation. Any question from the floor? Dr. Ahmed Abdelbari.
thank you for your excellent presentation. I will ask about the detrusor underactivity, which is a aerodynamic term. We can measure the detrusor pressure during voiding and assess if there is weakness by bladder contractility index or nomograms, ICS, and Schaeffer, and all belong to the male evaluation. We don't have such data about the female.
Yeah.
Some women can urinate without the detrusor contractions even.
Yeah.
So how can we assess the detrusor underactivity aerodynamically in a woman if we cannot have proofs that there is weakness by either the nomograms or the equations?
Thank you very much. This is a very relevant question. Indeed, we couldn't develop reliable nomograms in the female population, not only to assess detrusor underactivity, but also to assess the bladder outflow obstruction, because women do not need a strong detrusor contraction to empty their bladders. Many women just void by relaxing their pelvic floor. Therefore, a very low limit of difference actually happens during detrusor contraction. Therefore, it is very difficult to develop reliable nomograms. Urodynamic studies are never alone. They are always a part of the ICS urodynamic protocol, which includes a very good history-taking, physical examination, bladder diary. So when you make a diagnosis, you have to see the whole picture and make your decision accordingly. Of course, again, you have to phenotype your patient. If you are planning, for example, stress incontinence surgery to treat an anti-incontinence surgery, then the presence of detrusor underactivity may be more important for you, since you are going to increase the bladder outlet resistance. So this makes a difference. So, but you're right, we don't have the strict criteria for that yet. We have to build a big picture and then inform our patients accordingly, and we need prospective studies in that problem.
In this particular case, in the stress incontinence slings, if we have urodynamics and it's almost normal, but no bladder contractility, you cannot expect after putting the sling, it will be obstructive or not.
Actually, 12% of all, even index patients, means non-complicated stress urinary incontinence patients, have avoiding dysfunction, usually to detrusor underactivity during urodynamic studies. And we know in the very long term, they do worse than compared to women with no detrusor underactivity. So we have to be careful. Studies have shown, even the famous value study has shown, that when the detrusor underactivity is diagnosed, surgeons are prone to insert their meshes looser compared to other patients with no detrusor underactivity. Of course, we need, again, prospective studies and the long-term outcome. Thank you.
Thank you, Professor Tofan. Thank you.
Thank you.
For sake of time, we move to the next session.
The next lecture, Predictors of Successful Pelvic Neuromodulation, with Professor Magdi Hassoun.
It gives me always a great pleasure to be here in my hometown, or my homeland, among friends, and I would like to send my sincere gratitude to the inviting committee, and particularly to my old friend Sharif Murad. We have had good time together and still in the future, inshallah.
You are most welcome in your country, Dr. Hassoun.
So I have no disclosure for this. I've been asked to take the task of selecting the best candidate for the neuromodulation. I'm come here from an experience of almost over since 1987, when we started the first one implanted in Montreal. So I'm going to try to be as vague yet as specific on certain items when you want to offer the therapy to a particular patient, whether male or female. I'm going to try to cover these three parts of my presentation. What are the factors that influence the SNM outcomes? So you try to prevent them in order to get a good response. What is in the most recent evidence medicine evidence base on the recent literature, and if there's any controversies or gaps in prediction, which one will respond or not. I'm not going to dwell too much on the SNM mechanism of action, but the trend now is we are more and more towards the belief that it's a purely sensory afferent mechanism or underlying mechanism. The patient usually comes to tell you if he's doing well, he feels the stimulation in certain part of the body, which is usually preferably in the perineal or saddle shape area. If he stops feeling this stimulation, or the stimulation becomes obtunded or less evident, the response is not as good. There is other theories that might be also entertained, try to inhibit the abnormal spinal reflexes. My presenter alluded to this. This is mainly by increasing the stimulation of the afferent. You can suppress some uninhibited detrusor contractions. And this has been also proved in experimental animals, where you do stimulate certain parts of the afferent system, you very easily can suppress the contractility of the detrusor, whether in interrupted way or a consistent way. Whether the motor pathway by itself has an effect by stimulating the motor response or the motor component of the reflex arc, still to be debatable. The problem is, for instance, if this theory was plausible, I would suggest offering this therapy to patients with pelvic floor relaxation, stress urinary incontinence, but unfortunately, we have all of us know that this type of therapy is not good for patients with stress urinary incontinence, for instance, or patients who have lax pelvic floor. The thing that comes with the first one, the first theory, it's some form of neuroplasticity or central reorganization. This can mainly help the patient assess, and we have some proof about this. There are a lot of functional MRIs done to the brain during the stimulation or during the application of sacral neuromodulation that shows some particular parts in the brain, particularly the prelimbic area, that becomes more active, and it becomes suppressed if the activity is not demanded, particularly for patients with overactive bladder. So in theory, the sensory activity of it between the first and the fourth one, both of them, to my knowledge or my sense of belief, they converge to each other. That's why when the patient has a complete spinal cord injury, the therapy is not a good option. The success of this, the definition of success has been implied with us since the early 90s when we presented the work in FDA in 97, where 50% or more improvement of one of more parameters considered to be a success for the therapy. Why? Because the good thing about this therapy that I find on my career is you offer the patient a screening test. The screening test will tell the patient whether he is or not a good candidate for permanent implantation or the implant of the procedure. I find this is a good, at least in the theory and in the practice of offering the sacral neuromodulation to patients. I always tell my patients, let's try do the screening test, whether 5 days, 7 days, 2 weeks or more, and you will be the first one to know or to find out if this is a good therapy for you or not. Definitely these success or these parameters has to be documented, and still up now I still use the voiding parameters together with the patient testimony, whether he or she feels there is improvement, and we try to address it as much as we can. Now, what are the predictive factors? When you see a patient coming to you, based on our experience for the last 30 odd years, we try to dissect a little bit which one of the patient will benefit the most. All of us wants to have good success when you apply the therapy like any other thing. The question of age, BMI, basal metabolic body mass index, comorbidity, the etiology itself of the disease, what the patient coming to see you for, laterality, I believe strongly in it, whether it's lateral, one side, other side, or both. Technical factor still holds true for good implant. It's an art still, although the procedure is simply presented, but there is a little bit of finesse in the way of applying the therapy and showing to the patient. And follow-up and programming. This is very important also in predicting the patient response. As far as the age, most of the patients we encounter are usually in the elderly group, although we have showed that there is some response that even are very promising in the pediatric age group. The higher age usually correlates with lower satisfaction rate. I think this is because of the comorbidity of the patient that usually as we get older, some neurologic disorders that happens, stroke happens by aging, diabetes, dementia, or some kind of cognitive malfunction that also contribute or erodes in the success rate of your device or of your therapy. And this is particularly when I see patients that have implanted for 10, 15, 20 years, come later on, beside the fact that the battery might run out and so on, they start losing their grip on their response. And this is because some of them have developed some diseases that also has been attenuating all the good response that you achieved before. Parkinson's disease also is a condition that age with aging. So in a nutshell, aging could be considered to be a factor that you have to bear in mind when you offer the therapy to the patient. The pediatric age group is a good starting point for patient for circular neuromodulation. We can catch this disease early on. Bad habits in toilet training can result in disastrous conditions later on. The only challenge that we face with this is some anatomical challenges, such as the size of the patient, the size of the sacrum, the development, the growth. All this can be corrected safely by using technology or techniques, adjusting some of the techniques in it. But the majority of patients, pediatric age group, show good results on the range of 75 or higher. When it comes to obesity, some studies show that there's no direct link between obesity and the success rate. In our personal hands, we found that most of the patients that are extremely obese are not the ones that usually respond very well to the therapy on the long run. Is it because the stretching and particularly the patient gain weight suddenly in a short period of time? Other comorbidity, I'll allude to it, diabetes, stroke, Parkinson, and the most challenging one is the multiple sclerosis. In multiple sclerosis patients, we agreed that there is a combination of overactivity, underactivity of the bladder, and this is timed by the fact that the multiple sclerosis pathophysiology itself is a waxing and waning condition, meaning there are periods of exacerbation, period of remission. So when you offer the therapy to patient with Parkinson's disease, at least in my hands, we wait till the patient has been stabilized for at least 6 months. They're ready to follow by a neurologist. And the neurologist himself has to be part of your decision making. And with the good thing now that we have the compatible, MRI compatible leads, this can be also addressed hopefully easily. But again, if you need practice to start with it, try to be very wary about patients with multiple sclerosis. Pelvic pain again has been a new indication for the sacral neuromodulation, particularly the pelvic pain that's associated with bladder spasticity and pelvic floor dysfunction. It's very difficult to pinpoint which one. Usually, if you want to get into this realm of diseases, you have to imply somebody, a particular psychiatrist with you that will help deciding which type of patient that would benefit from the sacral neuromodulation. I found it that if the patient has physically objective tender point in the pelvic area, particularly in the good digital internal examination in females, if there is laterality, the response would be even better. Now, the famous question whether you need to stimulate unilateral or bilateral. Most of the time, because of financial resources and limitation in the numbers, we always tend to choose the side that gives the best response. So I still, up to now, although we have a little bit more access to the technology, I stimulate the right or the left side, S3, S4 on each side, and give the patient the option which side is best for him or her. Now, certain types, you have to resort to the contralateral stimulation or contralateral offering the therapy, particularly if there is attrition on the response. The responses start to fade. We all do. Sometimes I offer it to patient to salvage the therapy itself by offering a contralateral side and give the patient the option again during the screening test to use both sides during the stimulation. I cannot emphasize enough the technical factor during the procedure. You have one time, the best time to do the procedure is the first time rather than the recurrent time coming back. Meaning the timed leads nowadays have proven exceptionally good, particularly the one that comes already pre-curved on a stylet that you put it down. And when you put it down, just spend a little bit of an extra couple of minutes to make sure that the lead is in parallel to the sacral nerve root, whether the S3, the S4. Avoid the S2, of course, as much as you can. If you want to do a longer period of time because you're not very happy with the response that comes during the first week or so, you can extend this by doing the stage neurostimulation or stage screening, percutaneous versus the stage 1. Frequency of visit, we found that programming, you need to have a good team with you to program those patients. Those patients are high demand patients. They want to be, once they felt the response objectively in a certain area, they always come to seek the same response again and again. So we found out that those patients who have to come very frequently in the reprogramming usually do not do the best on the long run. Is it because of a technique that might happen during some kind of error or misalignment of the electrode during the stimulation, during this implant? This could be also something that you have to be mind you. The future directions, the literature is lacking prospective cohort study. We heard before the neurostimulation, the sacral neuromodulation versus the posterior nerve stimulation. We don't have exactly ways of assessing this, and this should be encouraged, particularly in multi-center studies. So ways to improve, in a nutshell, proper select the patient. The screening should be done and don't lack the time for it. Screening test with percutaneous versus stage. The intraoperative procedure technique has to be really spent a little bit. The procedure should not take more than 45 minutes, but among these 45 minutes, maybe 10-15 minutes would be done during the placing the electrode in a good fashion, and you'll be comfortable with this. Post-operative programming, you need a team that's really dedicated to help those patients and make sure that they get the programming. Thank you for your time.
Thank you very much, Professor Hassouna, for your nice presentation. Due to late time, we'll move quickly to the next presentation again by Dr. Irvin Kojansik, Management of Overactive Bladder based on phenotype. And any questions will be after this presentation.
Thank you again, Sharif, for inviting me. It's a pleasure being here. And this is the very last presentation of this year. So I'm glad to celebrate this with you. We heard this idea of phenotyping and tailored medicine. Tufan told us about the phenotypes in underactivity. Let's see how much we know or we don't know in overactivity. So we have a lot of options for patients with overactivity. We have drugs, we have injections, we can stimulate the nerve at the sacral root, we can stimulate the nerve in much more in the periphery, you can do physical therapy. But what are the best options? Can we use a more tailored approach to our patient? I'm going to show you a scenario of a patient, a real patient of mine, when I was a resident in the past millennium. So this patient came with the husband and complaining of urgency frequency and urgency incontinence. I put the patient in her 70s on oxybutynin. Patient went home. A month later, the husband came to the clinic. Again, keep in mind that this is like almost 30 years ago. Husband comes back and say, she's doing great, but she just developed a dementia after we recently. But she's not leaking anymore. She's fantastic. So she was not that fantastic, and we missed a lot of options in her management. This is what the definition of overactive bladder is. But it's very difficult to identify the factors that are actually causing this overactivity. And I'm going to show you that the urodynamic is actually not really helping us in identifying all the parameters. There are many reasons why the patients may develop, and according to a urodynamic study, may develop a detrusor overactivity. One is the myogenic, the urothelium can have a role, the urethra can have a role, the central nervous system has a role. But let's look into detail of this. You may have problems in decreased capacity to handle the afferent information. Typical example, I don't know, a patient with a stroke that develop a detrusor overactivity after that. Or you can have a decreased suprapontine inhibition in these patients. But you may have also something very locally going on that is actually causing exactly the same symptoms in our patient. According to urodynamic, the detrusor overactivity, so the patient with the overactive bladder where I do the urodynamic and I measure an increase in the bladder pressure, is actually present in not more than half of the patient with OAB. In the other half of this patient, we fail to demonstrate an increase in the bladder pressure, or the increase in the bladder pressure is not necessarily correlated with the symptoms that the patient has. So probably other factors are involved, like urothelium, the subraurothelium, the urethra, and the central nerve system. Let's evaluate some of these factors. Let's look at the myogenic hypothesis. Myogenic hypothesis says that the detrusor overactivity might result of histological changes in the detrusor muscle, leading to abnormal coupling of smooth muscle cells. This is work from Mark Drake from Bristol, showing actually that the detrusor is not contracting, is not one single muscle that contracts just contracts to stay relaxed altogether. There are strips of muscles that are of the detrusor wall that are actually deputed for contraction, and others are just not contracting at all. Some of them, they have more sensory information. Some of them, they have just the role of propagation of the contraction. So you can see here they are very different compared to what we expect from, I don't know, a bicep muscle, where the whole thing contracts together. And so this micro motion can actually generate an increase in the bladder pressure. They initiate an autonomous contraction in some part of the bladder, and this actually propagates to the adjacent part of the bladder, generating slowly this increase in the bladder pressure and eventually in contraction. Here is an area showing what happens, for instance, in a normal bladder, where you have, if you have like an intact detrusor, there are areas that are just doing the propagation of the contraction to the adjacent part of the muscles, and the other is just contracting. If you have any damage of this because of ischemia, because of aging, because of many other reasons, this might develop an example of underactivity. Or this might be develop an area of selective area of hypercontractility that actually patient perceives as urgency and frequency. This is again published in his papers by Marcus Rey. The increased activity in bladder afferent support is the idea of the urgency resulting from urothelian and suburothelian dysfunction in some patients, where the contraction does not generate enough pressure in order for the urodynamic to detect this type of contractions. And this actually is a contraction within the mucosa itself, and it's not only in the muscularis mucosa. This is actually perceived by the patient, but we are unable to measure during the standard urodynamic hypothesis. Another reason why we might develop an overactive contraction is the initiation of the micturition reflex. If you have a stimulation of the urine or of any fluid in the proximal urethra. So those are patients, for example, they develop urgency frequency or urgency incontinence with just movements. So when, for instance, when they move from the sitting to standing position, they develop an all of a sudden urge to go, and sometimes they cannot subside this urge and generate the whole contraction of the bladder. Those are patients, for instance, a female patient with some sort of hypermobility or with a prolapse, which actually can benefit out of restoring of the anatomy rather than just using anticholinergic in these patients. Another interesting thing that we are actually learning with the medical treatment of overactivity is that the treatments that we have are not the same. And the new treatment, actually in the US, this actually almost completely changed the way how we treat overactivity medically. Whenever we're using a beta-3 agonist, which are actually safer than anticholinergics, they act more on the sensory pathway compared to the motor pathway. And here you can see some example of why in the subepithelium the use of the beta-3 agonist can have a better role in targeting specifically the sensory pathways in these patients. Again, easier to use for the patients and with significantly better results compared to anticholinergics. Supraspinal hypothesis, we know that the central nerve system controls the micturition, and there are many studies showing that there are specific areas of the brain deputed for this. These are famous Tadic group study showing the activation of different areas of the brain, of the pons, and of the amygdala gyrus in low feeling phase, higher feeling phase, and a complete different scenario in patients with overactivity. So these patients are patients that when you do urodynamic, they have a sensory urgency and frequency, but we fail to demonstrate an increase in the pressure during the pressure flow studies or during the system manometry. So the appears to be the insula in the lower bladder volumes and anterior cingulate gyrus supplementary motor area, maybe the neural characteristics of urgency without the trusor overactivity. So those are very specific patients that we might actually be able to identify and treat them in a very personalized way. Of course, if you look at the phenotypes of the patient characteristic, metabolic syndrome, it's very important. Now that in the US, probably here is the same medicine like Ozempic or similar are used more than aspirin. And we're actually seeing an improvement in the patient's voiding symptoms and storage phase symptoms once on the medicine. We see this an improvement also in their erectile function, which was just published in the last AUA. But also the other aspects of the patient's life, like affective disorder, what is the sexual hormone role of the patients, the microbiota in the other organs in the area, how they affect. Metabolic syndrome, we just mentioned this. We know that if we target the obesity, we're going to have an increase in reduction in the oxidative stress. We have less inflammation, less insulin resistance, and the bladder is going to actually show this with an improvement in the parameters. Affective disorder, this is not a new thing. We know that emotional stress and anxiety reflects on the bladder function. They used to say in the ancient Chinese medicine that the bladder is the mirror of the soul. And actually we see this very often in our patients. Some patients with a very high level of anxiety and OAB, they can actually benefit of managing the anxiety rather than just prescribe an anticholinergic and hope not to see the patient again. Also, patients that are in menopause, when you restore locally the hormones, so the characteristics of the epithelium that is covering the vaginal wall, this is going to actually reflect also on a better bladder function on the medium and long term. Of course, the role of microbiota is known, but we need to better identify how we can actually obtain a better composition of the microbiota in patients that are aging and that have all this comorbidity. The gastrointestinal function also very important. Whoever is doing neuromodulation knows that actually you can kill two birds with one shot, they say. Maybe you're having better results on the gastrointestinal problem than on the urinary one with the neuromodulation. So in conclusion, OAB is everything but a very defined disease. So we need to identify if there's any specific factor so that we can act onto this factor and do a tailored medicine. Have a very thorough discussion with the patient about the goals of the treatment, especially also with the patient's milieu, so whoever lives with the patient, how we can actually improve it, cooperate with the primary care and with other specialists in order to improve the quality of life of our patient. Thank you very much again for your assistance and looking forward to questions.
Any question from the floor?
Thank you. Arvind, thank you very much for this excellent talk, and special thanks for indicating the important role of urodynamic studies in phenotyping the OAB patient, which doesn't mean, of course, that we have to perform urodynamics on every patient, but on selected patient group. This information is especially important after the recently published future study in Lancet, suggesting that urodynamic studies do not change the outcome for refractory OAB patients scheduled for Botox or sacral neuromodulation. I will have the opportunity on Thursday, I guess, to talk about this, but I mean, thank you, because the conclusion of this study is not justified and it has methodological error. I hope we will have opportunity to discuss it later. My question is, what about the trigone? The trigone is a very unique feature of the bladder, and it is both physiologically and embryologically distinct from the bladder dome. And we know so much little about the possible role of trigone in the overactive bladder. Do you have any theories or hypotheses in this regard?
Yeah, thank you, Tufan. Trigone is like the brain of the bladder for me. Trigone is where the majority of the sensory nerve are located. Compared to other area of the bladder, for instance, the dome of the bladder, where there is no sensory nerves there. You can do a resection of a transurethral resection of the I don't know, a tumor or something like that at the bladder dome without any anesthesia, the patient is going to do just fine with that. You can just touch the trigon and they're going to jump there. So I think that the whole way how we manage OAB in general with injectables, with bladder chemodenervation, they're all based on one single study where we're diluting in a very specific way and injecting in a very specific pattern. I think that the things are changing right now, and there are a lot of centers that are targeting specifically the trigon, injecting all the dose of 100 or 200 units of botulinum toxin specifically into the trigon, and the preliminary results are as good as the random injections in the whatever model you're using for injecting.
Thank you, Professor Evan, for this nice two lectures. Any other question?
I'm very pleased with what you said about the importance of the trigon. Way in the old days when we were young and energetic, we did some studies on the trigon and purely in vitro. And we found something that could mimic a pacemaker to the bladder. And this pacemaker is around the 2 ureteric orifices. And the simple thing is the diuresis that induce overactivity can be induced by just the motion of the ureteric orifice in there. That by itself can induce the overactivity of the bladder. It's not by the filling, just by the rapid motion. And that's why all the tools of oxybutynin I gave it a start by the trigon.
Yeah, that's great. So there was a study using, if you can keep the microphone, I have a question for you actually. There was a study using botulinum toxin to treat pain after double J stent insertion. So they were doing injection around the orifice, exactly reducing this motility, putting a stent, and they proved that actually the patient has significantly less urgency frequency induced by the stent compared to the patient that were not treated. So clearly the trigon is like a missed opportunity in this. My question to you is regarding the nerve fatigue. So nerve fatigue. When you're stimulating the nerve for chronic years, 5, 10, 15 years, we see a reduction in the efficiency of the SNS. Do you think that is there a rule of a nerve press? So having intermittent stimulation rather than a continuous stimulation?
Well, definitely, this has been proven, the habituation phenomena that happens. I always tell the patient, if you're wearing your wristwatch, you're not going to feel it after a while. If you have to shake it a little bit or change its position, yes, you're going to feel it. So I tell them usually the cyclic way is fine, or reduce the stimulation for a couple of weeks, then put it back on. You have to get this brain start to feel where the stimulation is. Again, it's all sensory, purely sensory, nothing motor.
Thank you very much.
Thank you for all. For the sake of the time, we will finish at this point. Thank you for all our professors and thank you for all attendees.
ملي صورة. الله.
I'd like to call the chairpersons عشان نبتدي الجلسة إن شاء الله. الأستاذ دكتور محمد الجمال، الأستاذ دكتور رفيق الحلبي، الأستاذ دكتور محمد أبو فرحة، الأستاذ دكتور محمد عصمت، دكتور حازم بيه عرابي موجود؟ لسه ما ظهروش. دكتور يوسف حضرتك جاهز؟ شكرا فندم.
هو دكتور يوسف نملة بس لسه مش موجود حاليا، فهنبتدي بالاستاذ دكتور طارق عثمان اللي هو البريزيدنت اوف ذا سكشن ورئيس القسم في طب عين شمس. روبوتك اسيستد بروستاتكتومي key for successful outcome.
عارف بس تمام. Thank you for attending this section meeting. يعني عقبال بس ما الناس تتجمع هندي كده very short resume عن احنا بنعمل ايه في اليورو oncology section. This is يعني a glimpse of our activity over the last 2 years. احنا عملنا طبعا meetings الحمد لله كتيرة. بدأنا أول حاجة عملناها في 3/23 كان ويبينار، وبعد كده ابتدت بقى الاكتيفيتيز تتوالى starting من شهر 3/23 حتى الآن. يعني دي شوية كده حاجات. ده الأول ويبينار عملناه، وبعد كده عملنا ورك شوب في 6/23 في عين شمس. 7/23 عملنا another ويبينار. بعد كده عملنا اليورو تشالنج كومبيتيشن. وبعد كده عملنا اليورو اونكو ميتنج التاني في بروستات كانسر دي كان في فندق دوسيت. وان سو يعني مشينا الحمد لله ماشيين مور اور ليس الى حد كبير. طبعا ده واحد من النايس ورك شوبس ذات وي ديد اللي هو في المنصوره تحت رعايه اخونا الكبير دكتور حسن. زي ما انتم شايفين دكتور محمد غنيم كان لنا شرف ان احنا قعدنا معاه. وبعدين في طنطا عملنا اليورو اونكو ميتنج 4. وبمناسبه الدكتوره منال المهدي معانا عملنا نايس او يعني شاركنا في جينيتو يورينري باثولوجي كورس عندنا مع الدكتور محمود اجول واحد اوف ذا فيموس باثولوجيست. وبعد كده توالت بقى الايام والحمد لله ماشيين الى حد كبير كويس. ده مثلا البرنسس فاطمه تريننج سنتر كورس اللي عملناه مع الجمعيه في 10/24. وبعد كده ده اليورو اونكو 6 وبعد اليورو اونكو 7. واخر يورو اونكو ميتنج عملناه كان في اسكندريه في راديسون بلو. كان برضو a very successful meeting الحمد لله. واحب ان انا افكركم ان the next يورو اونكو ميتنج هيبقى في بورسعيد. هيبقى شريك طبعا دكتور رؤوف زخاري راجل نشيط ومصمم ان احنا نعمل عنده الميتنج يوم 9 يناير ان شاء الله 2026. my presentation على الراديكال بروستاتكتومي. ممكن نجيب البرزنتيشن اللي جايه. الحقيقه راديكال بروستاتكتومي it's انا بعتبرها one of the operations that يعني بتعبر بالظبط على التطور في الحاجه. فانا ما بقتش يعني اقدر امنع نفسي من ان انا دايما ابص على الهيستوريكال اسبيكت بتاع حاجات كتير قوي. ويظهر بقى ده مع العجز بقى ولا ايه مش عارف، لكن كل بقيت امسك اي موضوع لازم ابص على الهيستوريكال ايشوز بتاعته. فراديكال بروستكتومي دي عدت ب5 مايلستونز اساسيين. المايلستون الاولاني طبعا كان اول عمليه بروستاتكتومي اتعملت اللي هي كانت ترانسبيرينيال بروستاتكتومي. واللي عمل العمليه دي واحد مشهور جدا اسمه هيو هامبتون يونغ. والراجل ده على فكره يعتبره هو الفاوندر اوف ذا مودرن يورولوجي. وعمل الترانسبيرينيال راديكال بروستاتكتومي سنه 1904 ولحد فتره طويله قريبه يعني كان حاطين صورته على المجله بتاعتنا الشهيره اللي هي الامريكان جورنال اوف يورولوجي لحد فتره طويله. هو الراجل اسمه هيو هامبتون يونغ. ده اول مايلستون، ده اول actual prostatectomy اتعملت for prostate cancer. وبعد كده بقى طبعا السكند مايلستون كان بتاعه واحد اسمه ميلن تيرنس ميلن. ده is an Irish man وعمل اول ريبورت على الريتروبيوبيك بروستاتكتومي سنه 45. وفضلت العمليه اللي هي الميلن بروستاتكتومي is the standard operation لحد يعني اواخر القرن العشرين لحد ما جه طبعا الدكتور ده اللي هو مشهور قوي اسمه وولش اللي هو باتريك وولش. وده هي عمل زي ريفوليوشن في الراديكال بروستاتكتومي لان هو ادرست المشاكل الاساسيه في البروستاتكتومي او الريتروبيوبيك بروستاتكتومي اللي هي البليدنج والكومبليكيشنز بتاعتها اللي هي نيملي الانكونتيننس والاريكتايل ديسفانكشن. وبعد دراسه طويله جدا للديتيلد اناتومي والنيرف سبلاي والبلاد سبلاي اوف ذا بروستاتيك سبلاي والسفنكتر سبلاي والنيوروفاسكولار باندل. هو واحد اناتوميست مشهور برضه اسمه دونكر، قدروا يديسكرايب عمليه مشهوره جدا اللي هي الاناتوميكال راديكال بروستاتكتومي سنه 82. دي كانت اول مره يتعمل فيها او تتعمل فيها الاكتشوال اناتوميك راديكال بروستاتكتومي. وهو الحقيقه زي ما قلت لحضراتكم هو وولش حل 3 مشاكل اساسيين اللي هم كان الفوبيا بتاعتنا في البروستاتكتومي اللي هو البليدنج والانكونتيننس والامبotence، عن طريق ان هو he described very well and very meticulously بقى النيوروفاسكولار باندل والدورسال فين سبلاي وازاي قسمهم وازاي قدر يكنترول الاكسترنال سفنكتر. وطبعا يعني he nicely described this operation من الاول للاخر. طبعا ده بقى وفضلت هي اناتوميك راديكال بروستكتومي هي دي الستاندرد اوف كير لحد ما ظهر الفورث مايلستون اللي بعتبره اللي هو اللاباروسكوبيك راديكال بروستاتكتومي. واللاباروسكوبيك راديكال بروستاتكتومي اول واحد كتب عنها او عملها واحد اسمه شوسلر، هو المجموعه بتاعته ده في امريكا سنه 91. تستغربوا ان اللاباروسكوبيك راديكال بروستاتكتومي اول ما اتنشرت على 9 حالات، وكان الافريج تايم كان 9 ساعات ونص لما نشروا اللاباروسكوبيك راديكال بروستاتكتومي. يعني وفضلت شويه لحد ما يعني جم الجماعه بتوع فرنسا اللي هم بتوع مونسوري في فرنسا اللي هم فالنسيان وجولينو، دي برضو من الناس اللي كانوا مشهورين جدا في هذه الفتره في اللاباروسكوبيك راديكال بروستاتكتومي اللي هم الاثنين الفرنساويين دول. الفيفث and the biggest milestone بقى هو دخول الروبوت. والروبوتيك بروستاتكتومي برضو اللي هو الدافينشي روبوت ده بتاع شركه انتيوتيف، دي شركه امريكانيه. والحقيقه اول روبوتيك سيرجري اتعملت كانت في بلجيوم سنه 97 واتعملت على روبوتيك كوليسيستكتومي. واول روبوتيك بروستاتكتومي برضو كانت في يوروب سترينج انف بواحد اسمه بايندر، وده في فرانكفورت يونيفرسيتي سنه 2000. طبعا السؤال اللي يبدو للذهن اشمعنى الشركه امريكاني تعمل اول عمليه تعملها في اوروبا؟ لان الريجوليشنز بتاعت اليوروبيان ميديكال براكتس is much easier than in the United States. هي الحقيقه ابتدت في اوروبا، لكن بعد كده طبعا كالعاده الامريكان سرقوا طبعا الشو بعد كده وابتدوا بقى ايه يبوبيولارايز this robotic prostatectomy. طبعا على راس الناس اللي كانوا فيمس ابوه في فرنسا، وبعد كده بقى جت المجموعه اللي هم بتوع امريكا زي ماني مينون في ديترويت، والراجل ده اللي اسمه باتيل ده عمل لحد النهارده 20,000. Can you imagine the number؟ 20,000 روبوتيك بروستاتكتومي. لما تحسبها كده على مدار السنين اللي اتعملت فيها تقريبا بيشتغل 6 حالات بير داي. ده رقم مفزع، يعني واحد مش متخيل ازاي واحد يعمل راديكال بروستاتكتومي 6 حالات في اليوم، اللي هو باتيل بتاع فاتيكوتي انستيتيوت. طيب الروبوتيك بروستاتكتومي احنا موقعنا ايه دلوقتي في العالم؟ دلوقتي تقريبا لحد سنه 18 كان كل اللافينشيز او الروبوتكس سنترز في العالم هم 4500 تقريبا، ده في 2018. النهارده في 2025 اكشولي في اخر مارس 2025 اخر احصائيه حوالي 10,189 جهاز دافينشي موجودين في او روبوتيك يونت موجودين في العالم. طبعا معظمهم في امريكا، حوالي 6000 بس في امريكا، حوالي 2000 في اوروبا، قرب ال 1800 في ايشيا، وبقيه العالم كله حوالي 505. دول برضو دول ار ذا statistics بتاعه الدافينشي روبوت، ناهيكم طبعا عن الاجهزه طبعا ماتش ليس بقى في بقيه الايه الاجهزه اللي عندنا. تقريبا لحد النهارده اتعملت 8.5 مليون حاله راديكال بروستاتكتومي باي ذا روبوتيك بلاتفورم روبوتيك دافينشي. 95% من كل البروستاتكتوميز في امريكا بتتعمل بالروبوت، وتقريبا حوالي 90,000 حاله في امريكا. تقريبا على مستوى العالم 75% من الحالات الروبوتيك، وحوالي في سنه 2024 بس في 110,000 حاله اوف روبوتيك بروستاتكتومي اتعملت. الروبوتيك بلاتفورم اللي عندنا في مصر هو الروبوتيك اللي هو بتاع السي ام ار. الاختلاف الاساسي بتاعه ان هو البلاتفورم بتاعه مختلف، في كونسول بيبقى دايركت فيجن من غير ما بتخش جوه الجهاز. ده من الحاجات اللطيفه اللي في الموبايل بيد سايد يونتس، عكس الدافنشي اللي هو بيبقى فيه ال1 يونت ومالتيبل ارمز. الميزه الاساسيه في الروبوتيك بروستاتكتومي طبعا is the low morbidity بدون شك. البليدنج واللو بوست اوبراتيف بين والكومبليكيشنز والهوسبيتال ستي والكلام ده كله طبعا. البيتر فانكشنال اوتكم يعني it is now more or less established. Better and earlier control of urination and preservation of erectile function تقريبا في from 50 to 60% of the cases. Simply for the better and the nicer magnification. The oncological outcome is the same as in open surgery. What I'm going to say بقى في ال 4 or 5 minutes اللي فاضلين على التيبس او tricks how to make the radical prostatectomy a better approach. طبعا اهم خطوه طبعا هي البيوبسيز. والبيوبسيز what I do always do ان لازم البيوبسيز تكون satisfactory at least 30 grams. If it's a 30 gram prostate, do not accept less than 8 biopsies. If it is more than 30 grams, from 10 to 12 biopsies at least. طبعا دلوقتي احنا بنشتغل معظم الشغل بتاعنا بالام ار اي فيوجن جايدد بايوبسي. There is no place now for the random transrectal biopsies. ده الاساس. الترانسبرينيال بايوبسي دلوقتي ده more or less بقى الستاندرد عندنا. at least عندنا ناس في عين شمس very excellent في transperitoneal biopsies. وطبعا نتيجه much less side effects and much less complications of transperitoneal biopsies عن الترانسركتال. طبعا ال crucial point of prostatic cancer management is the pathology. فunfortunately احنا عندنا مشكله كبيره ان مفيش يعني strong يعني standardization of the pathology reporting system. الحمد لله عندنا في عين شمس الدنيا احسن كتير قوي من الحتت بره. فانا I please urge you if you are going to do prostatic cancer surgery you have to have a very strong pathology reference عندك. الحاجة الثانية بقى how to select the patient for robotic prostatectomies. طبعا احنا عندنا the best يعني candidate for radical prostatectomy is the patients with the intermediate risk, especially unfavorable. الfavorable intermediate risk ده بقى ممكن يكون له place for surveillance, place for focal therapy, whatever. لكن starting from the intermediate risk, unfavorable prognosis وانتهاء and the high risk هم دول أحسن عيانين هتستفيد من radical prostatectomy. You have to counsel the patients about the available options, prostatectomy and radiotherapy. لحد النهارده there is no definite randomized controlled trial that says in surgery is better than radiotherapy. They have a very similar oncological outcome. The difference بينهم الأساسي في they are all observational studies كلها و retrospective series بتقول that surgery has a better edge عن radiotherapy in local control بس طبعا on the expense of some operative associated morbidities. في محاضرة لطيفة النهارده الصبح على comparison ما بينهم. I would definitely recommend ان بتاع دانسون ان احنا نرجع لها تاني. فيها very good aspects في موضوع المقارنة بين دول. It's very important to address the patient's expectations. This is one of the crucial points. You have to tell the patients every possibility of possible complications, the possibility of some delay in his continence. لأن طبعا most of these patients are actually asymptomatic patients. They are not symptomatic. فبالتالي أنت you are turning him to another symptomatic profile. It's very important to stress that these patients are, especially the high-risk patients, will definitely need multimodal treatment. And so the patient should understand that he might need hormonal treatment, he might need adjuvant, or he might need even salvage radiotherapy. It's crucial to assess the proper sexual and urinary performance before the operation. عشان ده البيزلاين. كتير جدا بنلاقي العيانين بيشتكوا من erectile dysfunction. هم already they had some impairment of their erectile dysfunction. Staging, nowadays we definitely resort to plasma PET-CT as the standard for staging. It has the highest sensitivity and specificity. To to do lymphadenectomy or do not do lymphadenectomy. This is a very long discussion, very long يعني في arguments كتيرة جدا. لكن at least what we know that the high risk patients اللي عندهم low lymph node metastatic volume هم دول المجموعة الوحيدة اللي ممكن تستفيد من الليمفادينكتومي. Otherwise routine lymphadenectomy will not affect لا ال overall survival ولا حتى ال biochemical survival. Should we base it on PESMA PET-CT? Yes, this sometime. أنا just 1 minute وهقفل خلاص مش في طبعا علشان الريسك اوف ليمف نود ميتاستاسيس في حاجات كتير قوي بنعملها، من اشهرهم النوموجرامز. في دلوقتي ابس، الابلكيشن ده لطيف جدا، اي سترونجلي ريكومند ات. انت بس بتحط البي اس اي ليفل هنا، وتحط الكلينيكال ستيج هنا، الجروب بتاع الباثولوجي هنا، وبرسنتج اوف بوزيتيف مارجنز، برسنتج اوف بوزيتيف كورز. مجرد ما بتحط الارقام دي كلها هيطلع لك البرسنتج بتاع البوسيبيليتي of lymph node metastasis. لو البوسيبيليتي بتاع lymph node metastasis is 10% or more, you should do a lymphadenectomy. If it is less than this, you can skip it. To do nerve sparing or not, طبعا it should not do on expense of radicality. يعني اعتقدش ان في الدكتور يوسف موجود. Okay, so I will هكتفي بكده علشان ننقل على السكند بتاعه. لو في فرصه بقى نعرض الفيديو في الاخر يبقى احسن، عشان بس ما ناخدش وقت الدكتور يوسف. Thank you very much.
أولا بعتذر جدا 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 على التأخير، كان unintentional، فاعذروني، يعني حاجة تكسف بس. سوري. احنا كده بنبتدي. اوكي سوري. الحقيقه انه انا اديت المحاضره دي امبارح، بس يعني الناس اشتكت ان الانجليزي بتاعي كان مش قد كده، فهنتكلم فيها تاني المره دي بالراحه وعندنا وقت اطول فنقدر go through it better. I work at Guy's Hospital. Guy's Hospital تأسست سنة 1721، ولما تأسست كان اسمها Hospital of the Incurables. كانت مستشفى ريفيرال للناس اللي عندها terminal diseases، بس receive their end of life care. بس through the years في المستشفى دي اشتغل يعني figures of medicine and they changed the narrative of incurable diseases وخلتها أكتر curable و millions of patients لحد النهارده benefit from their contribution. توماس أديسون، ريتشارد برايت، توماس هودجكن واشلي كوبر، وطبعا من اللاست نيم you can tell what they have done for medicine. That's very relevant for tumor thrombectomy لأن هو it can be an incurable disease, and despite being a rare condition, only 10% of patients with kidney cancer would have venous involvement, only 1% of those can reach high up to the level of the atrium. بس الجراحة, what you do daily, is what significantly impact the outcome of these patients. فهي بتعكس ال 70% mortality rate of this condition in 1 year exactly to the opposite, 70% survival at 5 years, disease-specific survival. And that's irrespective of the thrombus level. طبعا we're all aware of the new joiners of the market, immunotherapy, which has changed a lot of the outcomes of many uro-oncology procedures, سواء those receiving surgery or not receiving surgery. But if we're talking about surgery for such a complex disease, should it be done open or robotic? There is advantage for each. لو بنتكلم عن open surgery احنا بنتكلم عن open field with wider opportunities. يعني تقدر تmobilize the liver completely out of the way. لو الابدومين tight و large mass تقدر تget small bowel completely out of the abdomen. Best traction و counter traction, wider space is better with open surgery. You get a better feel. احساس الايد الجراح مهما كان في حاجات روبوتيكلي ممكن نعملها، الانهانس فيجوالز، الامباكت بتاع حركه التيشو مع ضغطه الروبوتك ارم ممكن to tell you something about the texture، بس still ان انت تقدر تفيل الثرومبس at least عشان تتاكد ان الكلامب بتاعك not going across the thrombus wouldn't be as good as with open surgery. Better control. The best hemostatic intervention for bleeding هي ايدين الجراح على الانفيريور فينا كيفا او على اي bleeding point. وانه في more active surgeons involved. الروبوتك سيرجري هي single player game، هو جراح قاعد على الكونسول بيعمل عمليه، انما الاوبن سيرجري is a team game. في more active hands, more active eyes، كل واحد شايف العمليه من زاويه مختلفه، ومور importantly more active minds. عمليات زي دي بتعوز vascular surgeons, cardiothoracic surgeons، ومش كلنا عندنا نفس الاكسبيرينس والاكسبوجر للروبوتكس. فنروح لكومن جراوند زي الاوبن سيرجري، ده ممكن يكون يعني better place to meet them. بس ما نقدرش ننكر ان الروبوتك one of the best achievements in surgery in the recent years. It gives you the focus. انت تقدر تعمل zoom in with a very high resolution للتيشو اللي انت شغال عليه، وده بيجي with precision لان انت يعني بتبقى عارف بالظبط انت بتعمل ايه. You can even buzz the capillary before it bleeds, and that's why there is less blood loss and less perioperative complications, and definitely much quicker recovery. Case evaluation, every single bit of information is crucial in planning surgery for these cases. بس الكي مسج you need up-to-date multimodal imaging. مش بس في thrombus ولا لا، what is the exact level of the thrombus، ايه طبيعة الثرومبس دي، هل هي bland ولا tumor thrombus، is it invading the wall ولا لا، what is the caval diameter، is it completely caval obstruction ولا لا. الثرومبس consistency حاجة مش مكتوبة كتير في الليتريتشر، احنا دايما نقول ان هي زي البوريدج والسوسج. البوريدج اللي هي الفرايبل ثرومبس اللي هي بتيجي متفرولة، انما السوسج ثرومبس اللي هي بتبقى solid ثرومبس وسليبس اوت one piece in thrombectomy. والام ار اي can tell you now pre-operative if it's porridge or sausage، لانه طبعا بالنسبة للروبوتك surgery we prefer the sausage لان it's very difficult to be 100% sure there is no residual tumor with a porridge or a friable thrombus. البري-operative optimization, anticoagulants can reduce risk of bland thrombus، بس معظم العيانين دول بيبقى عندهم هيماتوريا ف very challenging. caval filter ممكن يبقى considered لو عندك large mass وحاسس ان يبقى فيه excessive manipulation للثرومبس قبل ما تطلعها، فدي ممكن تسيف البيشنت risk of intraoperative thrombus. وامبولايزيشن مهم يبقى معاك دكتور تخدير انت عارفه وعنده اكسبيرينس كافيه، لان الحالات دي بيبقى فيها significant fluid shifts و risk of intraoperative embolus. وبرضه يبقى معاك تيم من vascular surgeons, bowel surgeons, cardiothoracic surgeons that you get along with and you work efficiently as a team. Ideal case for robotic venous thrombus ان هي تكون right side level 1 to 3A و non-complex thrombus ideally solid thrombus. ده فيديو فيه المين تيبس فور سيرجري. احنا بنعملها في اللاترال ديكيوبيتس، العيان على جنبه. دي level 1 thrombus extending just into the inferior vena cava. الدياجرام اللي فوق على اليمين بيوريكم الاناتوميكال لوكيشن بتاع الخطوه اللي بتتعمل. You can control the artery في الرايت سايد في الانتر-aortocaval plane as shown in this view. In this case, we control the artery lateral to the cava. We reserve the intra-aortocaval control للحالات اللي عندها significant thrombus أو significant hilar lymphadenopathy اللي بتخلي الأكسس للأرتري في بداية الحالة صعب. بعد كده بنعمل circumferential dissection للرينال فين، الكونترالاترال رينال فين، وبنعدي الدبل فاسكولار لوب. طريقة one way of doing it إن أنت تتني اللوب على نفسه وتعديه ويبقى فيه كليب هو الفالف اللي بيوقف اللوب. بعد كده هنبين احنا بنستخدمه كتورنيكيه ازاي. بعد كده بنعمل circumferential dissection below and above the level of the thrombus around the inferior vena cava. احنا هنا inferior زي ما انتم شايفين في الدياجرام فوق على اليمين، احنا دلوقتي below renal vein، وبعد كده هنعمل dissection above the level of the renal vein. ميزه الدبل فاسكولار لوب عن ان هو تعدي اللوب وان تايم ان هو بيبقى بيتر جريب على الفين لان هو without traction. يعني لما نيجي نشوف في الوقت اللي هنعمل فيه التورنيكيه على الانفيريور فينا كيفا او على الفين بيسكويز الانفيريور فينا كيفا في مكانه، لكن لو هو سنجل لوب هيبقى فيه بول على الفيسل. برضه بيتر جريب علشان الوايدر كونتاكت سيرفيس اريا. مهم قوي ان انت تطمن ان مفيش لامبرز feeding into the inferior vena cava في الكنترول سيجمنت. Those should be identified in pre-operative scan زي ما انت شايفين في السي تي سكان على التوب رايت سايد اوف ذا سكرين، لانه a missed lumbar vein will result in a significant intraoperative bleeding that you don't need. Ultrasound عشان نطمن ان كل الثرومبس within the controlled caval segment. وكده بناخد stay stitch عشان نطمن ان ال upper border او ال angle of the cavotomy won't tear off during the operation. زي ما انتم شايفين التورنيكيه دلوقتي بيتحط وهو بيعمل complete squeeze للفيسل من غير ما يعمل عليه pull، من غير ما يشد عليه. وبنسكيورد ببولدوج برضو لانه الكوست اوف يعني باك بليدنج in terms of blood loss is high to risk it just على تورنيكيه. بعد كده دلوقتي احنا بنقطع بين الرينال فين اوف ذا افكتد سايد والانفيريور فينا كيفا. دي سوليد ثرومبس، دي احلى ثرومبس ممكن تتعمل روبوتيكلي. بعد كده الكيفا ريبير بيتعمل المشهور 6 او برولين. احنا دلوقتي we move to another stitch material called Gore-Tex and I can talk you through the advantage of this later. الفيرست لاير بتتعمل بيفور كلامبنج، بس السكند لاير بعد كده بتتعمل اوف كلامب علشان لو في بليدنج بوينت يتعمل. وطبعا الكلامبنج لازم يتعمل ديستال بعدين بروكسيمال علشان تافويد الاير امبولس. مهم في التورنيكيه قبل ما نوصل له لما بنعمل كنترول للفينز لازم تطمن من الانيستس عن هيموداينامكس. دي عيان تاني ليفل 3A ثرومبس ريتشنج للهيباتيك فينز. احنا هنا بنعمل الدبل لوب بس بطريقه تانية، بنعدي نفس اللوب twice around the circumference of the vein او the inferior vena cava. طبعا البروكسيمال كنترول بتاع الكيفا في الحاله دي كان very challenging لانه you have to mobilize the caudate lobe of the liver and you have to get across a lot of short hepatic veins to get above the level of the thrombus زي ما انتم شايفين في الاسكان. استخدمنا في الحاله دي الروبوتيك كليب ابليكيتور، وده ميزته طبعا ان هو بيقدر يعمل الانجلز زي اي روبوتيك ارم، لان اللاباروسكوبيك ويك ابليكيتور كان صعب جدا يوصل للزوايا الصعبه دي، برضو كان هيكلاش مع الاذر روبوتيك ارمز. ومور امبورتنتلي احنا محتاجين both assistant hands to maximize traction in this narrow operative field. Sorry? What is this? Oh, these are all hepatic veins. Not the main hepatic veins, short hepatics. احنا الثرومبس under the level of the main hepatic veins. بس كلها يعني small vessels بين الليفر وبين الانفيريور فينا كيف. After circumferential dissection هنعدي اللوب twice زي ما عملنا في الارت. احنا ممكن نعدي يعني دقيقة كده من الفيديو لو ما عندكوش مشكلة عشان الوقت. الكنترول روم لو تقدروا بس تعدوا دقيقة من الفيديو يبقى كتر خيركم. اوكي مش مشكلة، خلاص مش مشكلة. That's fine. Still challenging for robotics ان احنا الهاي ليفل ثرومبس، لان لسه دي لحد دلوقتي بنعمل لها الثراكو ابدومينال ابروتش. في تكنيكس روبوتيكلي ممكن نكوب with it بس we haven't implemented them in practice yet. برضو الليفت سايد تيومر، لان التيومر على ناحيه والانفيريور فينا كيفا على الناحيه الثانيه. This is a case that we've done open 2 weeks ago وزي ما شايفين دي very friable thrombus extending down through the genital vein. دي 2 open cases. لو وصلنا لدقيقة 2 في الفيديو من غير ما تعدي السلايد يبقى كتر خيرك. هنا يعني we're mobilizing the liver. ايوه شكرا. حلو هنا. دي الثرومبس اللي طلعت في بلاند ثرومبس كبيره بايفريكيتنج وهي اكستندنج للكونترالاترال فين. الكيس الثانيه اللي كنا محتاجين فيها ثراكو ابدومينال ابروتش، وفي كارديو ثراسيك تيم شغال في التشست، وفي اليورولوجي شغال في الابدومين، والعيان كان على complete chest cardiopulmonary bypass. So they secure the caval control from the chest. وبعدين احنا بنفتح الكيفا، احنا دلوقتي بنفتح الوول بتاع الكيفا في الهولدر، وبعدين الكلوت هتطلع كلها one piece. This is a sausage thrombus or a solid thrombus which is perfect again, not just for robotic but also for any surgery that you have the feel that you've got it all out. It's important to know what is the state of the art لما نيجي نتكلم على new technology أو عن robotic. Robotic thrombectomy is not the state of the art. State of the art is an oncologically sound operation with negative margins and complete excision of the tumor. And uro-oncologists again should have access and availability of using different modalities of treatment, and they offer the patient the best treatment modality. ده التيم اللي أنا شغال معاهم في Guy's Hospital, and they all been surgeons involved in the operations that you've seen. Thank you.
Any questions for Dr. Yusuf? And thank you very much for this wonderful presentation. Any questions? Okay, we'll proceed.
هو السؤال عن دور الاميونوثيرابي في الحالات دي. هو مما لا شك فيه ان الاميونوثيرابي is game changer for all advanced surgery، حتى for cystectomy. يعني مش عارفين مع النيو ادجuvant immunotherapy هل ده هيغير الانديكيشنز اوف تريتمنت اوف سيرجري. المشكله مع الاميونوثيرابي ان هو بيحصل معاه significant tissue reaction عكس الكيموثيرابي. يعني الكيموثيرابي يعني بنعمل سيستكتومي بعد نيو ادجuvant كيموثيرابي والتيشوز بتبقى فيرجن وجميله، انما بعد immunotherapy التيشو بتبقى so adherent, and because we can't still tell the patient that will benefit from immunotherapy احنا لسه مش واخدين الخطوه دي في locally advanced kidney cancer، وخصوصا العيانين اللي محتاجين tumor thrombectomy. بس لو في المستقبل اثبت ان هو يعني effective وسيف we can do it. في published papers عن السيفتي بعد immunotherapy لتيومر thrombectomy، بس هم بيلعبوا على statistical significance. يعني الكومبليكيشنز هنا 80% وهنا 10%، بس it's not statistically significant ف it didn't happen. بس هي في الحالات دي المهم الكلينيكال significance مش statistical significance. هو مفيش كيموثيرابي في الكدني كانسر از نيو ادجuvant او حتى ادجuvant بروف ان هو يبقى افكتيف. احنا عملنا كله على الاميونوثيرابي.
بعد اذنكم الدكتور احمد حسن استاذ الكلينيكال اونكولوجي هيحب يعلق.
Well, I would like to second what Dr. Yusuf just mentioned. Until date, we don't have evidence on immunotherapy في neoadjuvant setting so far. We have very good promising data في palliative setting and in the adjuvant setting, reduction of recurrence risks. We established دلوقتي standard of care. الاميونوثيرابي حتى بنديه هنا في مصر وابروفد بره في امريكا وفي بريطانيا وفي مصر موجود دلوقتي بنستخدمه في الادجuvant. ودي حته ما كان فيها ديفكت جامد من زمان، حته الادجوفنت في الرينا ساكارسينوما، لكن احنا وي يوز دلوقتي از ستاندرد في الادجوفنت سيتنج وفي البالياتيف سيتنج. امتى بنستخدم الاميونوثيرابي في الحالات اللي هي مش ميتاستاتيك؟ لو حضراتكم قلتوه والله ده مش ريسكتبل with the current presentation، فاحنا بنبتدي اندكشن فيز، والاندكشن ده لو لقينا فيه داون سايزنج للتيومر مع عاده بيبقى انتي في جيف اللي هو حاجه زي الاكزيتينيب او الادويه اللي هي بتشتغل اكتر على الفاسكولار اندوثيليال جروث فاكتور. لو في سايتو ريدكشن للتيومر بنعمل بعد كده ريكونسلينج مع اليورو سيرجنز to discuss within a multidisciplinary setting whether we can proceed to surgery ولا لا. فهي it's not a standard neoadjuvant treatment. However, we use it in certain selected patients لو surgery not feasible at this point.
بس يعني باكينج اب لحضرتك بتقوله، احنا الكيس سيريس بتاعتنا بتاع العيانين اللي عملنا لهم سايتو ريدكتيف نفركتومي افتر immunotherapy كلهم كانوا تي نوت.
Okay, which again echoes
I think it will be game changer. We're just waiting for the
certainly,
evidence.
certainly.
Dr. Yusuf, just question for a technical issue. The team who was working on the robot is the same team that they would like to convert the same open surgical team, or they have to call for them? This is the number one. Number two, what about, because we know that the renal cell carcinoma is a venogenic disease. This tumor, and from my experience of this cable thrombus, there is a sort of roots or arms extending to the lumbar veins, and sometimes if you omit it, you will leave a tumor behind. You will take out, of course, the main bulk of the thrombus in the cava, but there is a projection like thrombi branching from the main thrombus into these lumbar veins. Do you have experience of this issue?
هو بالنسبه للسؤال الاولاني، وحضرتك طبعا شرفتنا في جايز وتعرفت على التيم، هو التيم بتاع الاوبن سيرجري هو التيم بتاع الروبوتك. احنا كان عندنا disastrous case، عشان كده it's very important to have expertise in both techniques. كان عندنا disastrous case كانت large، ودي من الحاجات المهمه قوي فيها الاوبن سيرجري كنترول، كان large heavy tumor which slipped from the robotic arm which torn the renal vein of the IVC. والجراح اللي كان في العمليه هو العيان الحمد لله اتلحق، بس هو الجراح اللي في العمليه هو بيقول انا كل اللي انا فاكره ان العيان بدا ينزف. تاني مشهد هو مش فاكر ايه اللي حصل في النص، ان هو انا ايدي جوه بطن العيان على الانفيريور فينا كيف. ودي this is the only setting you can conduct this complex surgery robotically in a safe way. If you can't comfortably and smoothly convert to open, then it's too risky. It's much higher risk than open surgery. بالنسبة للتيومر ثرومبس، دي الميزة بتاعة اللي هي السوليد ثرومبس، ان هي حتى لو branching it will all slip out of wherever it is. بس الفرايبل ثرومبس يعني اعتقد انه ما فيش جراح هيقدر يقول 100% ان هو removed everything. لابروسكوبيكلي وروبوتيكلي دلوقتي في ناس suggest ان هو ممكن you can get a flexible ureteroscope through one of the robotic arms and you can check the intralumen side of the cava to make sure, and you can basket out any residual thrombi. بس طبعا اعتقد ده ممكن يكون سبب كبير للعيانين اللي بيحصل لهم early recurrence missed lumbar thrombus اكيد.
Dr. Youssef, last question. Did you face infiltration of the wall of the cava in some cases? And did you call for vascular surgery or grafting or something like that?
هو شفتها open and you can excise up to 50% of the caval diameter safely. We say 30% just to be on the safer side. لكن robotically we're still very selective. احنا عندنا لحد دلوقتي بس 20 حالة عملناهم robotic، ودي مهمة جدا برضو انه اي introduction of new technology في الديبارتمنت you have to start easy. لازم تبتدي بالحالات السهلة. يعني احنا الليفل 3A ثرومبس دي كانت يعني البيج ستيب فورورد، ولا بعد ما كنا عملنا 15 حالة. ف we're very selective. بنبقى مطمنين ان في we can see contrast around the thrombus. We do CT و MRI، واي suspicion of caval wall invasion we don't do it robotically so far.
Thank you, Dr. Youssef, for this marvelous video and great experience. We move to the next speaker. I think we have to call for Dr. Tariq Osman. أنت خلصت؟ عنده فيديو؟
بالتالي الدكتور أحمد حسين. I would like to call Professor Dr. Ahmed Hassin. Dr. Ahmed Hassin is a professor of interventional radiology at Ain Shams University. He's a very good guy in this regard. صحيح هو مدير حاليا احد المستشفيات الكبرى، لكن احنا بنحاول نسرقه كل شويه كده في for the scientific purposes.
بسم الله الرحمن الرحيم. أنا طبعا يعني I'm very honored to be invited في ال 59th Annual Congress of Egyptian Urological Association، وأحب أشكر أستاذي وأخويا الكبير الأستاذ دكتور طارق عثمان على الدعوة الكريمة. احنا النهارده هنقول ايه هو الرول اوف intervention radiology in geotumors. طيب اول سؤال why intervention radiology في الجيو اونكولوجي؟ الحقيقه احنا minimally invasive cancer diagnosis في المقام الاول، وبعد كده الثيرابي، organ preservation, lower morbidity, option for high risk or inoperable patients, bridge او adjunction to systemic therapy or surgery, و emergency for life threatening conditions. بدايه الدور بتاع الانترفنشن راديولوجي هو الدايجنوزس. اول حاجه زي ما الدكتور طارق عثمان قال ترانس ريكتال بايوبسي وريسنتلي ترانس برينيال بايوبسي فور ليس كومبليكيشنز. احنا بناخد 8 كورز اتليست في البروستات اللي اقل من 30 جرام، ومن 8 ل 12 في البروستات اللي اكتر من 30 جرام. وبنعمل تارجت بايوبسي وفيوجن بايوبسي ساعات في حالات الترانس ريكتال بايوبسي، بالذات لو الام ار اي او البسما كان مطلع اكتيف ليجنز، فبناخد منهم اتليست من 3 ل 5 كورز من الاكتيف ليجنز، وبناخد بقيه السيستميك ال 12 كورز من بقيه البروستات. بنعمل الترا ساوند جايدد بايوبسيس في حالات الرينال ماسز، او السي تي جايدد بايوبسي في حالات الرينال ماسز زي الحالتين اللي احنا شايفينهم دول. بالنسبه للتيومر مانجمنت، فاول خطوه الدايجنوزس، ثاني خطوه هي التيومر مانجمنت. ايه المانجمنت تكنيكس اللي بتستعمل في الجيو مالجنسي؟ هنمشي فيها واحده واحده كده. اول حاجه في الرينال تيومرز بنعمل ثيرمال ابليشن، راديو فريكونسي او مايكرويف او كرايو ابليشن. نعمل بري اوبراتيف سيلكتيف رينال ارتري امبولايزيشن او مانجمنت اوف ار سي سي ميتاسيس. امتى بنلجا للثيرمال ابليشن؟ الثيرمال ابليشن هو اول مره اتعمل كان سنه 95 في اليابان، كان بدايته براديو فريكونسي، وبعد كده بقى مور ادفانسد بالمايكروويف ابليشن، وبعد كده دلوقتي بقى في كرايو ابليشن ويز بيتر ريزلتس. احنا الحقيقه بنشتغل في التيومرز اللي هي تي 1 اي تيومرز اقل من 4 سنتيمتر، بريفيربلي التيومرز اللي بتبقى اكزوفيتيك وبوسترو لاترال بعيده عن البلفيكاليسيال سيستم، وبريفيربل مع العيانين كمان اللي عندهم كرونيك كيدني ديزيز. الريزلتس بتاعت الثيرمال ابليشن بتبقى من 89 ل 95% تقريبا في الراديو فريكونسي، ومن 92 ل 96 في المايكروويف، واعلى شويه في الكرايو ابليشن تقريبا من 95 ل 100%. هي مينيمال هوسبيتال ستي، العيان بيروح في نفس اليوم تقريبا بالليل او بيروح تاني يوم، وفي نفس الوقت بريزيرفز رينال فانكشن. ممكن الثيرمال ابليشن يتعمل الترا ساوند جايدد، او ممكن يتعمل سي تي جايدد. العين بيبقى برون بوزيشن جنرال انستيزيا، وبندخل سي تي جايدد زي ما احنا شايفين الابره جوه الماس نفسها، وبيبتدي يحصل الثيرمال ابليشن. ايه تاني ممكن يتعمل كانترفنشن راديولوجي في الجينيتورينري مالجنسي؟ السلكتيف رينال ارتري امبولايزيشن زي ما الدكتور يوسف ورانا، لما بندخل على تيومر كبير من فاسكولار عشان نقلل الانترا اوبراتيف بليدنج ريسك، نعمل بري اوبراتيف امبولايزيشن يبقى within 48 hours prior to surgery. ده بنعمل بري سيرجيكال ديفاسكولاريزيشن، وساعات بنعمله كمان لو ما فيش سيرجري في حالات البين او الانتراكتابل هيماتوريا او الاكيوت بليدنج. دي حاله احنا داخلين على الليفت رينال ارتري، التيومر في الابر بول واكزوفاتيك من الليفت كيدني. بندخل سيلكتيف امبولايزيشن، بنكتب سيلكتيف كاتريزيشن للفيدنج ارتري وبنعمله امبولايزيشن، وده المنظر بعديها. احنا بريزيرفنج بقيه الفاسكولاريتي بتاعه الكيدني، والتيومر نفسه تقريبا بقى افاسكولار دلوقتي. طيب ايه الدور بتاع الانترفنشن راديولوجي في اليوروثيليال تيومرز؟ احنا بنعمل طبعا بيركوتينيوس نيفروستومي فور اوبستراكشن وانتي جريديوريتيريك ستنتنج، وده يعني كومن لاند بيننا وبين اليورولوجي، وبنعمل امبولايزيشن برضو في حالات الهيماتوريا كنترول. دي حاله زي دي احنا داخلين انتي جريد في ستريكشر، بنعدي بالجايد واير ونركب انتي جريد دبل جي. طبعا بروسيجر ما هياش صعبه، وتقريبا دلوقتي بقت بيزك بالنسبه للانترفنشن راديولوجي. في البلادر كانسر الانترفنشن راديولوجي رول اول حاجه الهيموريدج كنترول او التيومر ريليتد بليدنج والبوست راديشن سيستايتس. بيبقى الهدف من البوست راديشن سيستايتس ان احنا بنقلل البلاد فلو اليورينري بلادر، فده بيقلل السيمتومز والانفلاماتوري بروسيس، بيعمل كات اوف للانفلاماتوري بروسيس نفسها. بتعمل ازاي؟ بيتعمل بسوبر سيلكتيف فيزايكال ارتري امبولايزيشن. دي حاله احنا هنا ده الانترنال الياك الانتيريور ديفيجن، بندخل على السيستيك ارتري بنشوف السايت اوف بليدنج في زي الصوره الثانيه في السكند رو، وبعد كده بنعمل تو كومبليت امبولايزيشن للفيدنج ارتري في البليدنج ده. طيب ايه الدور بتاع الانترفنشن راديولوجي في البروستات كانسر؟ احنا طبعا كلنا عارفين ان البروستاتيك ارتري امبولايزيشن بيتعمل في حالات علاج البناين بروستاتيك هايبربليزيا، وريسنتلي هو اتحط في الجايد لاينز. لكن لو حاله بروستات كانسر هل ينفع يتعمل لها بروستاتيك ارتري امبولايزيشن؟ الحقيقه هو ليه انديكيشن معينه في حالات اليورين ريتنشن او الجروس هيماتوريا او بري راديشن داون سايزنج، ساعات قبل راديشن لو حجم البروستات كبير عشان التخطيط بتاع الراديو ثيرابي وان احنا نقلل السايد افكت بتاعت الراديو ثيرابي، فممكن نعمل بري راديشن بروستاتيك ارتري امبولايزيشن بحيث ان احنا نقلل السايز بتاع البروستات، او البوست راديشن لوكال سيمتومز. دي حاله برضو احنا داخلين في الانتيريور ديفيجن للانترنال الياك وداخلين سوبر سيلكتيف على البروستاتيك ارتري. ده الرايت بروستاتيك ارتري باينه قوي البروستات وبالجنج جوه اليوناري بلادر، وبنعمل كومبليت امبولايزيشن ببارتكلز تقريبا من 300 ل 500 نانو جرام. طيب هل في دور في الادرينال تيومرز الانترفنشن راديولوجي؟ الحقيقه دور للثيرمال ابليشن في الادرينال تيومرز، بس يعني جيفن ان هي تبقى لوكالي مالجنت مفيش ديستنت ميتاس طبعا، بندخل سي تي جايدد بايوبسي شبه الرينال ابليشن بالظبط. بندخل بسي تي جايدد وبندخل بكو اكزيال نيدل زي دي كده، وبندخل على السوبرا رينال جلاند وابتدي يعمل ابليشن برضو نفس الكلام سواء براديو فريكونسي او مايكروويف او كرايو ابليشن. طيب هل في دور للانترفنشن راديولوجي في الميتاستاتيك ديسيز؟ احنا لنا دور طبعا في البون ميتاس ابليشن، وساعات بنعمل معاه سيمنتوبلاستي او نحقن سيمنت، وامبولايزيشن بنعمل امبولايزيشن عشان نقلل الاعراض بتاعه الميتاستاتيك ديسيز. وفي الليفر ميتاس طبعا بنعمل امبولايزيشن وابليشن. دي حاله فيها ميتاستس زي ما احنا شايفين في الفيرتبرا هنا كده، ده ليتك ليجن في الفيرتبرا. بندخل بسي تي جايدد ابروتش، بندخل هنا وبنعمل راديو فريكونسي ابليشن للتيومر نفسه. بعد ما بنعمل راديو فريكونسي ابليشن عشان نحافظ على البون انتجريتي بنحقن سيمنت بالشكل ده عشان ما يحصلش كولابس للفيرتبري. دي حالة تانية عيان عنده هيوج متاس في الرايت إلياك بون. المتاس ده بيبقى فيري بينفول للعيان وفي نفس الوقت بيبقى اجريسيف بياكل فيه بقية البون اللي جنبه. عملنا الأول انجيوجرافي وبعد كده وصلنا للفيدنج ارتري، ندخل نعمل امبولايزيشن. ده هو طبعا بالياتيف تريتمنت وبنقلل بيه السيمتومز بتاعة المريض ده. طيب هل في رول في الامرجنسي اي ار في الجيو اونكولوجي؟ طبعا اول حاجه الكنترول اوف لايف ثريتنج هيماتوريا سواء من رينال سيل كارسينوما او من بروستاتيك كارسينوما او من يورينري بلادر كارسينوما. طبعا مانجمنت اوف يورينوما وليكس بعد السيرجز، واخر حاجه درينج اوف ابسيسز في الحاجات اللي هي الاس اس اي او السيرجيكال سايت انفكشن. في فيوتشر دايركشنز للانترفنشن راديولوجي. اول حاجه الروبوتك اسيستد اي ار، زي ما في روبوتك طبعا سيرجري دلوقتي بقى في روبوتك اسيستد اي ار، وفي اي اي جايدد تارجتنج، واخيرا هو راديومكس فور تريتمنت سيلكشن بيتعمل طبعا تيومر فينوتايبنج وريسك ستراتيفيكيشن للتيومرز. Conclusion: intervention radiology plays critical role in diagnosis, treatment, and palliation of GU tumors. It's a minimally invasive option, improve outcomes and recovery. Collaboration with urology and oncology in MDT is essential. Thank you.
أحمد سؤال واحد بس. We have experience of trial to control aggressive life-threatening hematuria from the bladder by angioembolization, but response in our hands is a little bit down to the expectation, around 60%, and can recur again. What is your experience with it?
الحقيقه ان البنش مارك بيقول ايه؟ البنش مارك بيقول ان احنا من from 80 to 92% بتبقى السكسس ريت في الكنترول بتاع البليدنج في حالات اليورينري بلادر تيومرز او الماسيف هيماتوريا. الاكسبيرينس في مصر احنا في وحده الاشعه التداخليه في طب عين شمس الحقيقه بنشتغل حالات كتيره من دي، بس هي جيفن ان التولز نفسها تكون موجوده وتكون كويسه، ولو العيان معمول له سي تي انجيوجرافي قبليها بجهاز كويس، لا بنقدر نوصل كويس جدا.
المشاكل ما بتجيش يوجوالي في التيومرز بوست راديو ثيرابي هيماتوريا، ساعات بتبقى فيري اجريسيف and you cannot control it by alum, by formalin injection, by whatever, and then we call for intervention radiology to give us a hand.
هي مشكله البوست راديشن في العموم دي بتؤدي لتكنيكال ديفيكولتي. ليه؟ لان الاناتومي بتاع البلاد فيسلز بيبقى متغير نتيجه الراديشن، فالسكسس ريت بتاع البروسيجر نفسها بيقل. كتريتمنت اوف هيماتوريا بتبقى افكتيف، كتريتمنت اوف بين بتبقى somehow يعني السكسس ريت بتاعها بيبقى من 50 ل 60% ككنترول للبين نفسه.
يس. نعم يا دكتور احمد. يس. We embolize the superovasal and inferiovasal for both sides should be.
I have an experience صراحة في 3 حالات، واحدة فيها بوست كيموثيرابي واثنين بوست راديشن، والثلاثة صراحة successful. They were very successful، واحنا غلبنا فيهم، وحاجة لايف ثريتنينج اصلا، يعني الموضوع مش بسيط. وفي حاجة كمان اللي هو الفوكال ثيرابي in prostate cancer. Did you talk about it؟
No. لا.
ده يعني حاجة will be very يعني popular بعد كده.
Thank you, Dr. Ahmed. Now we will shift to the last lecture by Professor Dr. Muhammad Abdel Sattar, Alexandria University. It's a video presentation, minimally invasive treatment for the upper urinary tract tube. Connected.
السلام عليكم ورحمة الله وبركاته. مساء الخير على حضراتكم. شكرا للدعوة الكريمة من الدكتور طارق للمشاركة في جلسة أورام المسالك الجامعية المصرية. مطلوب ان احنا نتكلم في السيشن عن الاندوسكوبيك تريتمنت اور ذا مينيمالي انفيسيف بروسيجرز ان ابر تراكت يوريثرال كارسينوما. والحقيقه انه الابر تراكت يوريثرال كارسينوما ليها ستاندرد اوف كير الراديكال نيفروريتريكتومي وليها رول اوف اندوسكوبيك مانجمنت. It's not only how I do it لكن المهم when and why. يعني ممكن تبقى سهل ان احنا ناخد قرار الاندوسكوبيك تريتمنت لكن ما تكونش indicated. So how can we approach a case of upper tract؟ احنا عندنا risk stratification based على the size of the tumor, الفوكاليتي, high grade cytology or biopsy, والinvasiveness features of CT or preferably by MRI. وكذلك الهاي ريسك. معروف طبعا انه في حاله الهاي ريسك احنا عندنا الستاندرد اوف كير النيفرو يوريتريكتومي وذ اكسجن اوف بلادر كاف، وعندنا اللو ريسك بالكدني سبيرنج. ده ما يمنعش ان في some cases of high risk upper tract urethral carcinoma بتحتاج مننا اندوسكوبيك في سبيشال سيتويشنز زي البايلاترال ديزيزز، زي اناسوليتري كدني، زي لو كان البيشنت with renal impairment. So we should put the endoscopic treatment of upper tract urethral carcinoma in high risk when indicated. ده الالجوريزم للمانجمنت اوف upper tract based على السايت اوف ذا تيومر والريسك اوف ذا تيومر، وبالتالي بقى ما بقاش عندي صعوبه في ان انا اخد قرار هعمل ايه لابر ثيرد لو ريسك او هعمل ايه لكاليسيال لو ريسك او ميد ثيرد هاي ريسك. ده من خلال الالجوريزم اللي قدامنا. اكزامبلز للابر تراكت يوروثيرال كارسنوما ممكن تبقى فيري سمول ويونيفوكال زي الصوره اللي قدامنا وطلعت في الاخر فايبرو ابيثيليال بوليب. ممكن تكون something like more than 2 cm with normal contralateral kidney. Bilateral diseases on the left side intermediate size لكن على الرايت سايد large وinvasive وهيدرونيفروزس. والصوره اللي هنا الديستندنج نفروستوجرام in a solitary kidney after radical cystectomy diagnosis of upper to mid third large ureteric tumor. وبالتالي احنا عندنا different scenarios للupper tract. هنا صوره on the right في upper calyceal large filling defect، وهنا large filling defect in a solitary kidney. وبالتالي اذا كان القرار سهل نيفرويتريكتومي، هنا القرار مش هيبقى سهل لان انا عندي حاجات تانية تمنع. الستبس للاندوسكوبيك تريتمنت اوف ابر تراكت يوريثرال كارسينوما رقم 1 سيستاسكوبي. انا داخل عشان اعمل دايجنوزس واعمل مانجمنت اندوسكوبيكالي، لكن انا عندي الجزء of the cystoscopy is important to diagnose and to map the bladder tumor, and if there is a bladder mass we can go to do TURBT and then complete our mission for the upper tract, or we can abort. لو احنا شفنا ان في bladder tumor multiple في carcinoma in situ, something will change our decision. بعد كده هنقف قدام اليوريتريك اورفيس شويه، هنطول شويه علشان نشوف اليوريتريك جيت البلد افلكس going from this orifice. It's a diagnostic. We can localize, we can lateralize the hematuria لو كان البيشنت جاب هيماتوريا وما كانش عندي اي diagnostic features في السي تي. وكذلك في الفيديو الثاني showing الترايجونال هايبريميا، الترايجونال اريثيما near to the suspicious ureteric orifice. الليفت ureteric orifice كان free، لكن الرايت سايد او الرايت ureteric orifice showing the hyperemic area in the trigone مكان السيدلينج اللي بيحصل من الرايت ureteric orifice. Then we can go to the ureter either by retrograde or antegrade. المهم ان احنا ما نطلعش من العمليه نقول احنا مش عارفين ابروتش الابر تراكت يوريثرال كارسينوما. انا عندي الريتروجريد من اليوريتريك اورفيس لغايه ما افشل نتيجه بقى لارج ميديان لوب اوف ذا بروستيت، نتيجه انه في دايفيرتد يوريتر بافتر سيستكتومي، نتيجه انه ري امبلانتد يوريتر مش قادر اعمل ريتروجريد، ساعتها هلجا للانتي جريد. طبعا خطوه مهمه جدا خطوه اليوريتريك كاتيتر تو تيك سيتولوجي. قبل ما المس اليوريتر ده، قبل ما احقن فيه صبغه، قبل ما اخش باليوريتروسكوب، هنحط قسطره الحالب وناخد السلكتيف سيتولوجي عشان يكون ريبريزنتيف فور ذيس يونت. الخطوه الاولى خطوه الجايد واير، سيفتي جايد واير، عشان نطمن ان احنا هنقدر نكمل البروسيجر، خاصه انه لو كان لارج تيومر زي ده احنا عارفين ان احنا هنضطر للاندوسكوبيك لو كان في سبيشال سيتويشن زي ما كان سوليتري كيدني. باي ديفرنت سكوبز، عندنا الريوزبل وعندنا الديسبوزبل، مش هنتكلم فيها كتير كتكنيك. في نون تاتش تكنيك احنا ممكن نستخدم السيمي ريجيد يوريتروسكوب من غير واير، بس مطمنين من السيستوسكوبي ان اليوريتريك اورفيس وايد نقدر نخش بيه لغايه ما نوصل ونشوف الليجن. ده يمكن له ادفانتج ان احنا ما نلمسي اليونت دي بواير او بقسطره حالب، فنتجنب ان يحصل اي تروما، حتى لو تريفيال تروما تيجي بهيماتوريا فاحنا نفتكر او نظن انها من التيومر. وانس احنا شفنا التيومر هنرجع خطوه ورا ونحط الواير ونعمل السلكتيف سيتولوجي والريتروجريد ستادي وخلافه. لازم يبقى عندنا هاي اندكس اوف سسبشن في الابر تراكت، لان احنا ممكن يبقى البيشنت عنده هيماتوريا ومعاه بوزيتيف يورين سيتولوجي والسي تي نيجاتيف، فانا مضطر ان انا اخش ادور على اي حاجه تكون سسبشس اوف يوريثيليال تيومر. ما لقيتش في البلادر، دخلت اليوريتر، ممكن تكون الحكايه كلها كارسينوما ان سايتو. فالوايت لايت اوكي، لكن انا عندي نارو باند ايمجنج اف افيلبل، عندي ادفانسز في الفيجوال تكنولوجي زي السبايس كاميرا، عندي الفوتو دايناميك اف افيلبل، وبالتالي دي صوره مثلا لكروما فلتر and then shifting to the spectra to show after laser ablation of some tumors نقدر ندور لو كان في residual or suspicious lesion. وكذلك في الناحيه الثانيه بعد ما انتهينا من الليزر ابليشن حسينا ان لسه في residual mucosal lesion، وبالتالي رجعنا لها تاني بالليزر. بعد ما عملنا الدايجنوستيك ممكن ناخد بايوبسي، واحنا عندنا تو ويز، في البيجوبسي وده باك لودد بايوبسي فورسبس على الفلكسبل يوريتروسكوبي، نقدر ناخد منه بجود بايت، او ممكن نستخدم الدورميا باسكت by taking a biopsy from the suspicious lesion present. ده فيديو تاني لدورميا باسكت its role in taking a biopsy from the urothelial tumor just before taking the decision. لغايه كده انا ممكن اقول ان ده هو كل اللي بنعمله لاي upper tract urothelial carcinoma، لكن انا عايز اكمل. هل الحاله دي محتاجه مني هتستفيد من الاندوسكوبيك؟ هنا بقى القرار. لو هنشتغل يبقى عندنا جزء الابليشن، واحنا عندنا different ways of ablation، لكن يمكن احنا بنستخدم اكتر الهولميوم ليزر اذا كولد ستاندرد فور ستونز ابر تراك. طبعا الثوليوم موجود، لكن احنا بنتكلم على اللي موجود في معظم المستشفيات واقسام المسالك. ف اور بروفيسور دكتور اوليفر تراكسر كان عمل تويتس لطيفه كده من كام سنه على السيتنجز اوف ذا ليزر ان مانجمنت اوف ابر تراكت ارثيريال كارسنوما، بالبلس ديوريشن، بالانرجي، بالفريكونسي. وبالتالي عشان ما نتحيرش والبروتوكولز تتغير من جهاز للتاني، قال ان احنا عندنا ممكن نستخدم اللونج بالس ديوريشن لو في اجهزه بروفايد ده، والميديوم انرجي او الميديوم فريكونسي زي ما هنقول بعد كده. وبالتالي انا من الفيو سلايدز بتاعت الليزر بارامترز دي هوصل ل conclusion عشان ما اطولش على حضراتكم في ان الجود سيتنجز عندي فور لونج ديوريشن with medium energy with medium frequency. طبعا فكره ان احنا نتاتش بالليزر فايبر او نون كونتاكت حسب الثيكنس اوف ذا يوروثيليوم قدامي وحسب السايز اوف ذا تيومر. ده الواي اوف ابليتنج ذا تيومر. عندنا فرصه ان احنا نابليت التيومر الميوكوزال بارت اللي باين قدامنا لغايه ما نوصل للبيز، وده الموست كومنلي يوزد تكنيك ان احنا بنابليت كل الميوكوزال ليجنز لغايه ما نوصل للبيز اوف ذا تيومر. في الديسيجن سام كيسز ممكن ابقى شايف انها بالاندوسكوب از فيسبل، اخش الاقي ميدل ثيرد تيومر 3 سم بس انا عارف انه اتحط في الهاي ريسك وذ نورمال كونترالاترال كيدني، اللي يخليني اعمل اندوسكوبيك. او الاقي 4 سم رينال بلفس تيومر، صح ممكن تخلص ببيركوتينيوس ريسكشن بس هي اذا هاز نورمال كونترالاترال كيدني، اللي يخليني اعمل له سب اوبتيمم. وبالتالي some cases are doable but not indicated، وفي some cases are indicated but challenging زي اللي احنا هنشوفهم يمكن جاي. ده حاجه من الحالات اللي كانت مثلا فيها سمول بلفس تيومر، ودي كانت دايفرتد يوريتر، فاضطرينا نعمل انتي جريد ليزر ابليشن. انا هوفر بس الفيديوز اللي احنا ممكن نتخطاها. دي حاله من الحالات اللي كان فيها upper third pelviureteral tumor، ولما دخلنا بالمنظار شفنا ان التيومر كان بي excised completely by laser، وهنا استخدمنا الان بلوك تكنيك ان احنا وصلنا للبيز اوف ذا تيومر وجينا the junction between the ureteric wall and the mass وعملنا ان بلوك ريسكشن بالليزر لغايه ما بقى completely free in the ureteric lumen، وبعد كده استخدمنا الدورميا وريموفينج ات ان توتو. طبعا يعني في ريسك اوف بيرفوريشن، في كل حاجه وارده، لكن احنا بنتكلم على تو ابلاي ذا تكنيك. وطبعا بعد ما خلصنا عملنا الكونتراست ستادي اطمنا ان مفيش اكسترافازيشن وحطينا الدبل جي، وبالتالي ممكن يبقى ذير از رول بحيث يبقى في سبيسمن كويسه للبايوبسي بعد كده. ده بعد ما بقى الماس فريد كومبليتلي دخلنا بيه الدورميا باسكت واخدنا الماس اوت، وبعد كده الفيديو الناحيه الثانيه شفنا البيز اوف ذا وول وبرضه عملنا كواجيليشن بالليزر فايبر. الفيديو انا مقسمه ممكن عشان ما اضيعش وقت حضراتكم. الناحيه دي طبعا الصوره بتاعت اللارج فيلنج ديفكت ان سوليتري كيدني. البيشنت ده كان بريزنتد بيوريميا، اتحط له دبل جي، هو يعني مش كان جاي لنا من مكان تاني، كان جاي مركب دبل جي، فاحنا دخلنا بعد ما الكريات كان استابلايز وسحبنا الدبل جي وعملنا الستيبس بتاعتنا، حطينا الواير وعملنا سيلكتيف سيتولوجي. دي الصوره للتيومر in the upper third، الصوره اللي احنا شفناها من الريتروجريد ستادي من شويه، هو ده شكل الماس. وبعد ما اطمنا وعدينا الماس ودخلنا وشفنا باقي اليوريتر وشفنا باقي الكاليسز واطمنا ان فري، فاحنا ما عندناش غير سنجل فوكس لارج تيومر ان سوليتري كيدني. استخدمنا الليزر ابليشن واستفدنا من السبكترا مود ان احنا نطمن ان ما يكونش فيه اي ريزيدوال ميزد ميكوزال تيومر. ده كان الفاينل فيو قبل ما نكمل بالليزر ابليشن للبيد، بعد ما عملنا ابليشن لكل الميكوزال ليجن. الصوره للريتروجريد قبل والاندوسكوبيك قبل، الصوره افتر ابليشن ريتروجريد ستادي، والصوره افتر ابليشن بالاندوسكوبي. كان الصوره دي يمكن من اكتر من 8 سنين، ما كناش لسه بنفكر في الامبلوك ستوك قوي، فكان عندنا سمول سنتي ونص رينال بلفس تيومر اتعمل له ابليشن بالليزر، والفيديو الناحيه الثانيه كان ابليشن للبيد. وده بنقول لو اقدر اعمل الامبلوك لسمول ليجن ويز سمول ستوك اوكي، لكن ما اقدرش خايف من البرفوريشن، يبقى ممكن اعمل الكومبليت ابليشن بالستاندرد كونفنشن. ده فيديو للبيركوتينيوس او الانتي جريد للانتي جريد ريسكشن. ده كان لارج بلفس تيومر ان سوليتري كيدني بدايجنوستيك نفروسكوبي، ودخلنا وشفنا اليوروثيليال تيومر في البلفيكال سيل سيستم، وطمنا على باقي الكاليسز، ورجعنا بالبايبولر ريسكشن، عملنا كومبليت ريسكشن للتيومر. تاني ده مش للنورمال كونترالاترال كيدني، لان ده هيخلي العيان اخذ سب اوبتيمم تريتمنت انا مش محتاجه. ممكن يبقى سهله ولطيفه وجميله وحافظت على الكليه، لكن انا حطيت العيان في انه محتاج كلوز فولو اب، وانه في ريكارنس، خاصه ان ما عنديش الادجفنت ثيرابي اللي يسمح لي زي ما بنعمل في البلادر. وبالتالي خلينا الحالات دي للانديكيشن اللي احنا محتاجينها ان ابسوليوت انديكيشن. وطبعا بيطلع ثروزا نفروسكوب، وبيبقى فيه نفروستومي تيوب، اما ممكن نقرر نحقن منها بي سي جي، مايتومايسين، وات ايفر الادجفنت ثيرابي بعد كده. اهم ما في الموضوع بالنسبه لي انه احنا مهتمين جدا بالسيرفيلانس اوف ذا ابر تراكت يوروثيريال كارسينوما اوف ذا راديكال سيستكتومي، لان احنا ما كناش بندور عليها وما كناش بنركز قوي. احنا في اسكندريه دلوقتي عندنا اكتر من رساله على الابر تراكت، سواء كانت دايجنوزس او التريتمنت، من الام ار اي ومن الاندوسكوبيك مانجمنت والريسك ستراتيفيكيشن. لما بدانا نحط رسائل بدانا نلاقي حالات وحالات اكتر، وبالتالي الابر تراكت يوروثيريال كارسينوما دلوقتي يمكن ما نقدرش نقول عليها رير ديزيز. الشغل اللي احنا قدمناه ده كله ده شغل وحده الاورام في قسم المسالك جامعه اسكندريه. كل الستاف من اول اكبر استاذ لاصغر نايب شاركوا في تحضير الحالات وتجهيزها، فشكر ليهم جميعا وشكرا لحضراتكم.
دكتور محمد, thank you very much for an excellent presentation. الحقيقة طبعا الشغل تكنيكالي حلو قوي, بس أنا كنت أحب أعرف الأوتكم واللونج تيرم ريزلتس بتاعت العيانين دول, بالذات إن أغلبهم high risk patients size wise appearance, فكنت عايز أعرف سنة واتنين إيه الأوتكم بتاعهم.
دكتور محمد, هو المحاضره فيديو برزنتيشن فانا كنت محصور شويه, لكن انا هجاوب على سؤال حضرتك بس ليه ما حطيتهاش في الشغل النهارده, لان هي كانت جاست فيديو برزنتيشن. وطبعا الفولو اب بالنسبه لنا احنا لسه الحالات دي عدى عليها سنه او سنتين, لكن احنا ما شفناش لوكال ريكارنس. احنا شفنا بس الحالات اللي بتبقى ناسوليتري كيدني. احنا جربنا بعض الحالات فيها نورمال كونترالاترال كيدني وفيري ليميتد كيسز اوف هاي ريسك, لكن احنا كنا مهتمين مع الحالات السوليتري كيدني او البايلاترال ديزيزز علشان الفانكشنال اوت كم والاونكولوجيكال اوت كم كشورت تيرم فولو اب ما كانش فيه الهاي ريت اوف لوكال ريكارنس.
دكتور محمد معلش سؤال تاني.
اتفضل يا بيه.
هو حضرتك كانوا لو جريد ولا هاي جريد؟ لان هتفرق كتير قوي.
طيب تمام. هو طبعا سؤال استاذي رفيق سؤال مهم جدا. احنا في الابر تراكت يوروثيريال كارسينوما بنهتم بالسيتولوجي البوزيتيف فور هاي جريد, وبنهتم في البيوبسي بالجريدنج, لكن الاثنين دول بيتحطوا جوه ريسك ستراتيفيكيشن.